So good morning, everybody, and we are ready to start with our second day of Advanced Pediatric Endocrine Symposium. Yesterday was a very grueling and academic marathon, which lasted for around 11 hours. And today also we are going to have a short but a more brisk race probably from that perspective. The first session is a very interesting one on debate, and this is basically going to discuss about three controversial topics in pediatric endocrinology. Every speaker will get 8 minutes to speak for the topic, and the other person will talk 8 minutes against the topic. Then there will be a couple of minutes for rebuttal. And then finally, the judges. We have got two very senior judges, Dr. Rajni and Dr. Hemchand, who will be judging about that. There will be no winner or loser, but we might try to get a consensus at the end of it. So I think over to Ria to start the proceeding.
Thank you, sir. So, as sir said, we'll have three debates on three very interesting topic, yet very conflicting one. So, the duration will be of 20 minutes. Four speaker will argue first, and then again speaker will take the floor. So, let us begin. For the first topic, is central precocious puberty in girl, whether to treat all versus to reassure. So we have Dr. Manisha Maurya ma'am to argue to treat all and Dr. Shayan Banerjee sir to argue to reassure. So I would invite Manisha ma'am to start.
I think a debate brings out the true flavor of pediatric endocrinology. And it's very interesting to have this debate. I think central precocious puberty, we are looking at the story of the rabbit and the tortoise. The child with precocious puberty who is going to run through the race and land up as a short adult at menarche at an age where she's not going to understand things, or whether you treat and convert it into a tortoise so that the menarche is delayed, the final height is up, is acceptable, and the child is mentally composed to accept this milestone. So is all the children, should they follow the path of the tortoise or rabbit? I think that is the debate. We are looking forward to that.
So good morning all. So for the first debate as discussed by sir, I will speak for, we have to treat all the children with central precocious puberty. And so what are the concerns for GnRH analog if we are giving in to all girls? So does it have a short-term benefit in terms of psychological issues, or is there a long-term benefit in terms of height gain? Does the child achieve a predicted adult height greater than the others? Is it safe regarding the bone mineral density or BMI? And what about the future pregnancy and the risk of PCOS? So let us discuss one by one. About the psychological problems in girls with central precocious puberty, there are evidences given by study done by Dinkelback et al. Published in JAMA in 2025, in which 1,094 patients with idiopathic central precocious puberty were compared with normal controls, about 5,448. And they found that the children with central precocious puberty were likely to have a diagnosis of any mental disorder. And it was 24.7% in patients as compared to 16.9% among the control. So there was a high risk of having a psychological disorder. Again, a study done by Hugh T.K. et al., published in Journal of Clinical Endocrinology, and they compared 2,955 children with central precocious puberty with the normal matched population according to the age and sex. It was a nationwide cohort study done in Denmark, and they saw that the precocious puberty children were associated with statistically significant increased risk of ADHD, anxiety, autism, depression, eating disorder, and even schizophrenia. Now, does the treatment with GnRH analog decreases these psychological issues? There are evidence that they have increased psychological issue. So does this treatment decrease the psychological issues? So we have a study which was done by Rafat S. et al., published in Oman Medical Journal in 2024, in which they did a case control study among 30 children with central precocious puberty and 30 with normal. So what they found that they had children with central precocious puberty had significantly lower scores of health-related quality of index but it was not in terms of cognitive function in school function. It was just simple health related quality index. And after treatment, they had a significant improvement in their scores. So this study shows that there is a improvement in psychological health related quality scores after treatment. Now, is there a psychological problem while giving GnRH analog? The children are receiving injections every 3 months. Will it cause psychological problem in the parents or the children? So again, one study was done by Lucascioni et al. In Research Square, published in Research Square in 2026. They did compared the 56 female with ongoing and previous central precocious puberty and matched with 30 matched control. And what they saw that there was no difference in the psychological issues while they were on treatment among the treated group and the control group. Now, what are the evidence of positive effect on the adult height, final adult height? Now, one systemic review was done by Firvana M. et al., published in Journal of Clinical Endocrinology in 25. They did compared 14 studies with the number of 1,835 children. Mean age was 8.2 years, plus or minus 1.8 years. With it was done among around 12 countries, in which they found that the mean adult height was improved um, as compared to the treatment. And they also saw in 9 of the study where GnRH analog was given alone versus GnRH analog plus growth hormone was given, and they did not find any difference. So at one time, they are saying that there is a final adult height gain of around plus 2.5. And if there is no improvement, if we are giving along with the growth hormone. Again, one meta-analysis done by Chen et al. In 2025, published in Endocrine. They did a meta-analysis of 15 studies in which they saw that there was a significant improvement in height gain in GnRH treated group, about 2.5 centimeter, and the final adult height about 3.18 centimeter with a confidence interval of 1.49 to 4.87. Now, again, a study done by Akin, SB, and OSCA and IT, they found that they compared children basically around 8 years of age. 117 girls were diagnosed around 8 years, 46 between 7 to 8, and 71 children between 8 to 9 years. And they found that the improvement in predicted adult height was observed even when the GnRH analog was given after the age of 8 years. So this was a good study. And again, one study by Logmeyer, B.E. et al. In 23, published in Pediatric Medicine, a review article in which they saw the 61 PubMed articles from 1990 to 21. And they what they found that the positive adult height outcome over predicted adult height at diagnosis. So there was an improvement in predicted adult height at the diagnosis. So they got a positive adult height effect. Now, so it is evidences show that the height improves, there is a positive effect on the adult height. Now, long-term side effects about the bone health and the BMI. Logmeyer et al. Again, they did found that there is some decrease in BMD during GnRH analog treatment in the bone mineral density and bone mass, but this bone mass is sufficiently preserved after discontinuation of treatment. And if we see the BMI, they found that most of the children had high BMI at the diagnosis, but there was no significant change during the treatment or treatment. As against Howell et al., they found that there was a significant increase in BMI from the baseline at the end of treatment, but they returned back to normal after stopping the treatment. Soliman et al. Did a systemic review with 148 studies included. They found that the bone mineral density decreases with GnRH analog treatment, but it normalizes afterwards with no lasting effect on the peak bone mass during puberty. Now, the last one, the future fertility and the risk for PCOS. Soliman et al. In ACTA Biomed Journal in 2023 did a systemic review in 148 patients. They found no significant difference in the prevalence of PCOS was seen in 2751 women treated with GnRH analog versus treated patients. So there was no difference among the about the risk of PCOS in children who were treated with GnRH analog, and most of these on long-term follow-up, pregnancies occurred within 1 year of conceivement. It was in line with the waiting period for the woman without central precocious puberty. So the conclusion is the evidence shows that there is improvement in quality of life after treatment. There is a significant improvement in final adult height after treatment, even when started after 8 years of age. There is nominal effect on bone health, which improves after stopping the treatment. Some increase in BMI, which improves after stopping the treatment. And there is no long-term problems regarding future pregnancy and the risk of PCOS. Thank you.
Thank you, ma'am. That was very insightful. Now I invite Dr. Shyan sir to speak against the motion.
So good morning all. Thank you, Dr. Manisha, for starting off this debate. Now, I am standing on the stage to speak for observation and not starting treatment at the first go. Now, I'll start off with a case. So this was an 8-month-old female came to us with breast development for 4 months, bilateral breast staging 3. Now, LH 0.8. Now, the doctor who referred the patient to us had a stimulation test done as well. The stimulation test showed a peak of LH of 10.7. So as the precocious puberty definition goes, breast development less than 8, LH more than 0.2, peak LH more than 5. So this is precocious puberty. So what is the plan next? Is it treat all? So should we treat this patient for the next 9 years of her life? Or should we wait? Now, this patient, we waited for 1 year. She never progressed. So now, today, I will try to show you why treat all would have failed her. So coming to the point of CPP in girls, it is not a question of whether to treat CPP. It is actually a question of whether to treat everyone who comes to you with CPP. Now, the HPG axis of life, you all know, the initial mini-pubertal spike, breast development in most of the females. But the main question is the duration from 6 months to 3 years. Is any child who presents to you within 6 months to 8 years of life with breast development, do they need treatment? Whom to observe versus whom to treat actually? Now let us come to the let us come to the changes that we generally face in children between 6 months to 3 years of age. Now, first, let us know about the normal responses that any child can have. So this entire slide is not coming, but if you see the 2 to 3-year-old segment, the initial part is of stimulated LH. So these are all normal children who have no breast development, no signs of central precocity. The stimulated LH in a normal child, even at 2 to 3 years old, can spike up to 9.96. So 10. Again, if you go by the standard definitions of precocious puberty more than 5, so this is actually precocious puberty level. But also look at the stimulated FSH level. In a normal child, with a 9.96 spike of LH, you have a spike of FSH which is turning out to be around 36. So just do not look at LH, just do not look at stimulated LH, also look at the FSH which is coming along with it. If you have a FSH dominance and you have a low LH FSH ratio, so rest assured, do not treat. This is a normal response. Now coming into the spectrum of patients who present to you with breast development. Now, this was a paper which the question itself is the one we are debating. Is premature thelarchy in the first 2 years of life transient or is it permanent? So this was 67 girls followed up for 1 year. They checked out for Tanner staging advancement, that is breast development, which is advancing, or a high growth velocity, which is growth velocity SDS more than 1. Now, out of this, they found 30% of patients who had early puberty. Now, this is the catch. Early puberty and CPP, I'll come to it. But 30% of the patients were diagnosed with early puberty. None of the biochemical, none of the radiological parameters could differentiate those with isolated premature thelarchy versus the segment with early puberty. Now, what happened? Is early puberty CPP? You're advancing on breast staging, you are advancing in terms of growth velocity. But what they found out is that they followed this entire segment up to an age of 8 years. Only 3 patients went on to develop CPP, only 3. Now, how did they define actually CPP? They defined CPP on the basis of decrease in the predicted adult height with respect to their target height. Now, only 3 patients developed CPP, and that too at an age of around 6 to 8 years. So again, observation was the key. Not only stimulated LH, not growth velocity advancement, not a Tanner state advancement, but observation was the key, with let us find out the actual group of patients who used to benefit from treatment. Now, the same paper, again a different paper, but the same fundamentals of it, they followed out 119 girls. They saw advancement of breast stage up to B3, height SDS, growth velocity SDS, bone age advancement, all were there. Most had stimulated LH more than 5, basal LH more than 0.2. But what they found out, you all want follow-up data कि आज मेरे पास आया growth velocity SDS थोड़ा ज़्यादा है, bone age थोड़ा ज़्यादा है, breast development B3 है, हम क्या करें? But follow-up data में क्या दिख रहा है? कि height velocity SDS is falling off. And you see, when the child first presents to you, height velocity SDS is so different from the premature thelarchy segment, but within 2 years, you have a height velocity which is coming out to absolutely the segment which is normal. So again, the point, watch, do not treat at the first go, and go for selective treatment with those who actually benefit from the treatment. Now, the point I already made is that stimulation testing in the normal cohort can peak up to 9.9. So this is another paper which tells us that stimulation barely changes your management. So they followed up 450 girls, 92% of them had final diagnosis of idiopathic premature thelarchy. If you see the stimulated LH level, my PPT is not functioning well, but if you look at the stimulated LH level, around 31 of premature thelarchy patients had a stimulated LH of more than 5. So again, there had been a question at that point of time, is it progressive puberty or will it only be transient puberty who won't require treatment? The follow-up in these patients showed that most did not require treatment. And again, the same thing that I want to mention to you is that premature thelarchy patients even went up to a peak LH of 22.6. Just look at the peak LH level. But again, look at the peak FSH level as well. You had an overwhelming FSH dominance, which was telling you no treatment was required, only observation. So please observe and selective treatment only to those patients who actually require on follow-up. Now, this was the segment which was 6 months to 3 years of age. Now coming to the segment which we most commonly will face, that is of 6 to 8 years old. Now, this was a 6-month, 5-year-old female whom I just met 2 weeks back. Now, her mother brought her to us with pain in chest 2 months back, bilateral B2, P2, height at 50th centile, bone age mildly advanced at 7 years, not that much, LH 0.23. Again, going by the latest definitions, more than 0.2 is pubertal. But look at the FSH. It's 1.2. So again, a FSH dominance. But if you look at the estradiol, again, you have a pubertal level of estradiol. So is this precocious puberty? Is this progressive puberty that we need to treat? So again, going by the definitions, this is actually precocious puberty. But again, the question, should I start treatment now and should I treat up to 10 years? But I, at 2 weeks back, have told her to review after 3 months. I'll watch for progression and then we'll decide on treatment. Now, the Endocrine Society guidelines have just come up last month. Now, they exactly tell us the same thing for segment of girls within 6 to 7 years group, and also within the 7 to 8 years group is that watch first. So when to decide on treatment? If within the next 6 months, you are having a progression of Tanner staging, if you are having a growth velocity which is peaking to more than 6, then decide on treatment. Along with that, there will be one segment of patient who is advancing on puberty, who is also having a slightly higher growth velocity, but his height age is also normal. So his height age and bone age is also normal. In that segment of patients, you would want to observe further. But if you find a child who has height age which is on the lower side, bone age which has advanced further, this cohort will be the best to treat. Not every patient with an advanced bone age. Look at the height age first, then decide on treatment. Now, they also tell us the exactly same thing. Observe for progression of puberty. If you think that they will benefit from treatment, then only go ahead and do. So what is the so treatment versus no treatment? The CPP diagnosis is certain, but benefits remain uncertain. Again, this is a cohort of patients who they diagnosed as central precocious puberty, defined the slowly progressive segment, then only treated those whose predicted adult height fell. All biochemicals were overlapping, did not benefit in diagnosis and management, but only follow-up. Only follow-up where predicted adult height decrease benefited. And again, the final paper, this was from pediatric adolescent gynecology. Same thing. Diagnosis of CPP in around 211 out of 212, but rapidly progressive puberty again in 44% patients, but treatment in only 15%. Why? Because again, height age and bone age, if they are corresponding, you don't treat because you don't benefit that much. If your bone age is advancing too much, then only treat. That is why only 15% patients were treated. And what about height loss? As Dr. Manisha has already said to us, it is the age. If your age is less than 6 years, you don't have to think about treating or not treating. We are mainly debating about the segment which is between 6 to 8 years. If you start treatment after 6 years, height benefit not that much, only around 0.2 to 0.3 SDS. So remember the 8-month-old. Treatment on day 1 would be a success. If you treated that patient, no progression in breast development, child would be best. But again, observation showed us that observation is also a treatment related success, which gives us equal benefit. So thank you.
Thank you, Dr. Manisha. Thank you, Dr. Sen, for very excellent deliberation. So basically what I would like to say is for Sayan that the isolated thalarchy, we are not debating that, but you were right about the 6 to 8 year segment. That is what we are debating mainly. So would we like to take a vote? Like how many of you would treat 6 to 8 years? Yeah. Okay, so now rebuttal by Manish.
So before 6, he's in line with me. So we have to treat all. And in very small children, obviously, observation is a must. I have not taken this group in my debate. Very small children. But after 6 years, treatment will be good because most of the systemic analysis which I have shown as evidences show that there is a significant improvement in adult height of about 2 centimeter, 2 to 2.5 centimeter. And though there is no adverse effects of treatment of this agent, so why not to treat?
Yeah, so the main point was 6 to 8 year old, but because we are seeing a huge number of patients between the 6 months to 3 years, and we might also catch up patients with hypothalamic hamartoma in this age group. So I brought up this segment. And to rebuttal, no specific rebuttals. We all know that more than 6 years, you don't have very much change in the final height. You will have change, but not much change that you expect. It is to pick up the right patient, whom to pick up and treat, where you'll have the maximum output. As Dr. Manisha said, there is no harm in treating. But we have not talked about the financial harm. We have not talked about the cost benefit ratio that we can offer to the patients. This is the first point. And one more thing that I did not bring up is of the psychological concerns that you had brought up in your first slide. Now, you are comparing a child of a 7-year-old child who has precocious puberty versus a normal segment. Now, I want to know data if this was a 10-year-old child who had menarche at that age versus a child who is a 7-year-old who has menarche at that age. Is that significantly different? That is the question. Not comparing a 7-year-old with menarche versus a normal, that won't be a question at this point of time. So as far as I know, there are not much data, but precocious puberty children at around 6 to 7 years, they go on to have a persistent psychological concern which can last up to 6 to 7 years. I don't know further from that, but rest of it is picking the right person to treat. I am not for observing, but picking up the right person to treat among the observation cohort. Right?
Height age is low, then
Yeah.
you should treat.
Yeah.
But what is if height age is equivalent to bone age, should we treat or not?
Nah, so this is the question. So, so there is no concern of height. So when height age and bone age are corresponding, there is no concern that you will remain short. Then you can observe and see. But the family concern, if it is overriding it, you may treat, but observation will not do any harm at that point of time, is my point.
Thank you.
Thank you. So Dr. Sen had presented a study from 6 to 8 years. How many actually progress rapidly?
So this is, I already presented in this slide. It is around rapidly progressive will be that Journal of Pediatric and Adolescent Endocrinology. Around 40% to 30% to 40% will rapidly progress. But again, height age and bone age will be corresponding. Final treated variant would be 20%.
Okay, so some of them will not progress rapidly.
Yeah.
And perhaps we could observe that.
So 60%
Yeah.
is the actual slowly progressive, rapidly 40, actual treatment required 20.
Okay. So yes, and Dr. Manisha, your study that they have psychological problems, that was very interesting. And that has to be explored a little bit so that if they get treated, then I don't know whether it would benefit them in that way. So should we take a vote? Yeah, in the quality of life.
So I think we can take a vote.
Yeah. So from 6 to 8 years, if you have a child presenting with precocious puberty, how many of you would like to observe? Majority, it seems. And how many of you would like to treat immediately? Okay.
So actually, we had done with Cyan initial study as well on that, and we have hopefully publish it soon. So what we found was that around 20% would merit treatment right away. So obviously, if their bone age is very advanced, their LH is very high, ET is more than 3 mm. But most cases, we followed up 80%. And out of those 80%, I think 40-50% progressed during 3 to 6 months. So it's not that you say observation does not mean that you will not treat later on. So I think that will be the caveat with a chance of treatment later on, I think.
Yes, they require close observation and assessment. And whenever you think it is progressing, you have to treat.
And a bit a small note, and central precocious puberty is a bouquet in itself. Idiopathic, post-cancer survivors, SGA babies, GHDs who present late, and ISS. So it's a heterogeneous. So I think applying the same yardstick to 5 different flavors might not be the. So I think an individualized clinical decision has to be taken. Thank you.
Thank you, ma'am. Thank you, sir. That was a very informative debate. Second topic is CAH in adolescents, whether to treat with hydrocort versus hydrocort with prednisolone or dexamethasone. Speaking in favor is Dr. Arpita, ma'am. Please.
So as we know, congenital adrenal hyperplasia in adolescence is a challenging phase in which they require increased doses of hydrocortisone to keep the disease under check. And many times the disease goes out of control and we have to hike the doses. At the same time, that could affect the growth. So this is a very interesting topic. So let us see what Arpita has to say.
So very good morning to all of you, respected judges, seniors, and my dear colleagues. I will be speaking for hydrocortisone alone therapy in CAH in adolescents. So We know that in growing adolescent, the safer default is optimized hydrocortisone. I'm not against prednisolone and dexa, and the studies do support that they are a rescue tool, but not used as a routine add-on, because the clinical endpoint in CAH is finally the growth in terms of the final height and puberty, safety in terms of the metabolic profile, as well as a safer androgen control. So my case for hydrocortisone rests on 7 convergent line of evidence, which I'll be going through in terms of growth preservation, metabolic safety, bone accrual, mental health, what the guidelines and the evidence have to say about these therapies, and a bit about pharmacology. Future direction in CAH, we know that it is towards hydrocortisone sparing approaches, as we saw in yesterday's talk, and not towards the combination therapy. So the debate is not suppression versus no suppression. It is a balance. We have to see whether we are undertreating an individual and avoiding that, because it leads to advanced bone age, virilization, menstrual dysfunction, TART and ORT. And we have to definitely avoid this. And overtreatment also has its own metabolic problems in terms of growth deacceleration, weight gain, increased BP, insulin resistance, low BMD, and mood problems. So hydrocortisone sits somewhere in the target zone because it is titrable and replaces the cortisol and androgen acceptably, also promoting growth and long-term risk. So a regimen that wins just on the biochemistry but loses height, bone, and metabolic safety is not a pediatric win as we know it. We know that adolescence is a fragile window. The individual is going through a lot of changes in the puberty in terms of pubertal spurt. There's increase in the growth hormone IGF-1 levels, which decreases the 11 beta HST, which in turn leads to increase in cortisol clearance. There is also a difference in the body composition, which leads to increase in insulin resistance. It is also a phase of life when an individual is exploring a transition of care. There's a difference in the education and lifestyle recommendation. He's gaining independence, which in turn leads to less adherence. So we have to balance that and not jump to the combination therapy. The literature also supports that the cortisol clearance as well as the volume of distribution of cortisol is higher in the pubertal versus the prepubertal age. The sex-specific pharmacokinetics is also different, with girls having a shorter T half, leading to more menstrual problems, leading to difficult treatment in girls especially. So the implication here should be puberty may require smarter hydrocortisone timing, frequency, or maybe modified release hydrocortisone, and not automatic the combination escalation for isolated increase in the lab value. However, there should be a word of caution here because the evidences goes against hydrocortisone dose of more than 17 milligram per meter square per day, because it has known to be predicting shorter stature. So the guidelines are in place and they support maintenance hydrocortisone. Chronic long-acting potent glucocorticoids are not recommended during growth because the growth plate are still open, and the monitoring still depends on the clinical parameters more in terms of growth velocity, weight, BP, physical signs, and not merely a perfectly looking 17 OHP on the lab values. So hydrocortisone first, escalation only when we have seen the adherence, the timing when the sample was taken in terms of the timing of the day, the time of the dose of the last hydrocortisone, as well as assessing whether we are controlling mineralocorticoid adequately, and clinical endpoints still remain the dictum of treatment in CAH rather than the lab. So hydrocortisone alone does not mean passive treatment. It means optimize hydrocortisone in terms of tracking oxology, in terms of height velocity, BMI trajectory, regular bone age tempo, clinical androgen suppression, testicular volume, also safety in terms of metabolic profile and mood, and having an adequate and safer androgen suppression. The studies are in place, and one cannot deny that dexamethasone suppresses the strongest in terms of 17-OHP and androstenedione. Hydrocortisone and prednisolone do not differ significantly when they were compared in the trials. But the same evidence shows that the individuals who were subjected to dexamethasone had higher BMI, and lower lumbar and femoral BMD signal with DEXA. And adult BMD data still matters because adolescent is the peak bone accrual phase. So better suppression does not equate better long-term adolescent health. When we talk about hydrocortisone and the combination therapy, the Sweden has a good registry, and they followed hydrocortisone alone group with the combination therapy, and they saw that prednisolone exposure group had decreased corrected final height, as you can see in the purple figure, and increased BMI at 18 years of age. So adding long-acting steroid during growth may buy suppression at the price of the height and BMI. So we need to choose whether we are going to do that. Final height in CAH is not a cosmetic. It is a clinical endpoint and very important as a pediatric endocrinologist. And severe genotype lose more height potential, as you can see in this diagram. And pubertal growth is a vulnerable period, and even modest overtreatment can matter. So a slight biochemical adjustment, which we are doing in the puberty, may have a long-term oxological and fertility issues in an individual. A word about the bone age data. So we saw that in the study done by Junior et al. They showed that the BMD looked perfect when they saw the chronological age because of the advanced bone age. However, when they adjusted for the bone age, the BMD fell. So adolescent peak bone mass accrual we have to take in mind, and if dexamethasone or combination therapy should be taken very cautiously and judiciously when we are using it. We know that CAH starts as a cardiometabolic risk. So the studies are there where they've compared CAH versus controls, that CAH patients have more worse metabolic profile in terms of blood pressure, HOMA-IR, and carotid media thickness. So when the cardiometabolic risk itself is high, why choose a therapy which will further worsen that burden? The real-world cohort also shows a cumulative burden where the transition age CAH cohort had lower BMI, elevated BP, and the increase in the female visceral adipose tissue. The adult cohort also showed similar data with shorter individual, more obese, more oligomenorrhea, and TART problem in the combination therapy. So both under treatment and over treatment accumulate consequences, and we have to choose cautiously. There's an emerging youth data in terms of the mental health, where the increase in glucocorticoid dose correlated with worse mental depression scores. However, we have to see that with caution, because association is not a proof of causation. So the counter evidence also supports that, yes, the combination therapy was better accepted in a subset of individuals with similar growth indices, but that cohort were older individuals, were short studies, were retrospective studies, and these support individualized care and not a routine treatment. So this is the slide which summarizes the CAH treatment in total, which was published in 2026. So they followed a cohort including 32 individuals where DEXA is actually required, and added it around the final height after persistent biochemical as well as clinical hyperandrogenism. And they found that the 17-OHP and androstenedione decreased at 6 to 12 months. Female-reared individuals had better pubertal problems. Male-reared individuals showed falling androstenedione and testosterone ratio. So this is the group where these DEXA is regarded as a rescue therapy. So my idea is to take dexamethasone like a scalp and not a blanket therapy. So evidence at present is limited with fewer studies, fewer RCTs, and those studies did not follow long term. There was no data on the final adult height, adrenal crisis prevention, osteopenia, and BMD issues, start, OART, subfertility, quality life. They were short-term study. So do not escalate for 17 OHP abnormality without checking the adherence timing and the clinical phenotype. And with that, I rest my case. Thank you.
Now we have Dr. Manoj Agarwal, sir, to argue for the combination therapy in CAH.
Request all speakers to restrict to 8 minutes.
So when we were talking about the CH, I think thank you very much for esteemed judges and Dr. Alpita. She has set the stage for me that whenever we are talking about the CH, we are not just replacing the hydrocortisol deficiency, but the main goal of the treating CH to suppress the androgen. And whenever we are talking about adolescent with the CH, as in our experience, we have seen the 100% patient of the CH, they do have a peripheral precocious puberty due to the untreated high testosterone. And when we treat the no, with the hydrocortisone, that time the central precocious puberty comes. So ultimately, if we are designed the height management, then their height would be stopped at the 12 to 13 year of the age. So now what will happen after that? So this is my real life case scenario. This is 16-year-old Ria, and she do the perfect adherence, as Dr. Alpita has said, to the hydrocortisone. But the real problem was there because of the hydrocortisone. Although becoming the adherent, she has a severe acne, hirsutism, irregular menses, and there is a elevated high testosterone, high 17 OHP, and there was a frustrated parents were there. And the most common fear was not about the treatment. It was about what is the future, what is about the fertility. So is it the treatment failure or is it a pharmacological failure? So why adolescent has changing everything? Here we are not talking about the pediatric populations that is growing. Here we are not talking about the normal population who attain the puberty maturations at the 14 or 15-year of age. Because of their pathology, might be they'll end up completed the puberty at the 12 to 13-year of age. So why adolescent change everything? Because in the CH, the average growth nearly complete and the high ACTH drive in the morning and the every time. And when you give the hydrocortisone, that time at the 4 p.m. your doorbell is not ringing. So whenever you have a high ACTH, that time your hydrocortisone flips his work. Might be is not doing the job what time the 4 a.m. ACTH should be done, and that time it is high. It is firing the androgen and the testosterone, and the patient may have a high androgen and the testosterone. So you have seen the RIA. The similar consequences happens with the particularly adherence with the hydrocortisone. And the poor adherence was also the big issue in the adolescent age group who is transiting to their parents to their friends. Constant phone is buzzing, and they do have a lot of behavior issue. So if we are talking about the adolescent, then poor adherence also we have to think about. Why hydrocortisone is sometimes the escape control? It is a base medication if we are treating in the particularly controlled child. But what happens with the hydrocortisone? The half-life is only 8 to 12 years. That means overnight, when it has to work maximally, it is not working that time. And it required 3 to 4 daily dose. It would be many times difficult for the adolescent who are not adherents to the treatment, and it cannot reliably suppress the ACTH whenever you require in the morning dose. So whenever you are treating, I would like to give the example. We always has been told like that. Whenever you are driving the car, go slow, go steady, and go safe. But whenever road are empty, you have to reach in the 10 minutes. that time might be instead of the 40, you can take the pickup of the 80 kilometer per hour. So that is the my point for today's discussion. Then the what is the cascade of the ACTH? We are just seeing the cascade uncontrolled ACTH and the elevated 17 hydroxy progesterone in the CH patient. But you can see there is a high ACTH is causing the adrenal hyperplasia. That adrenal hyperplasia is causing the androgen excess. What is the endpoint? If you are talking about the male, then there is a risk of the testicular adrenal raised tumor. And according to the Turkey study, 50% adolescent by sonography, they have seen that 50% has a testicular adrenal raised tumor. And if you are talking about the female, then it is a very burning point. They are talking about the PCOD, not due to the metabolic issue, but because of the untreated CH. And what is the long-term consequences? Because the testicular adrenal tumor and the PCOD was there, so the highest chance of the infertility is there. And there is a lot of the psychological burden by not treating well, because child is not feeling well because of the acne, hirsutism, amenorrhea, PCOD, subfertility, and there is a lot of the psychological fear is there, not because you are treating well, but not you are treating adequate. So this is the data that has been published in the England Journal of the Medicine, and they have seen that 30% adolescent people have testicular adrenal raised tumor that is missed on the diagnosis by the examination, but that you will see on the sonographical features. What is that? It is the tissue that the adrenal tissue is sitting in the testicle. Whenever you have high ACTH, that ACTH is going to the testis, it will replace the germ cell, your adrenal tissue will be further proliferate, and it will create the testicular volume, and it will cause the infertility. So there was a long, and it is by intensify the glucocorticoid suppression, like dexamethasone and the prednisolone in this kind of the particular patient in the adolescent, not in the childhood, you will have a ultimate result in terms of the tumor regression and the restoration of the progressive. So let's compare the three glucocorticoids as Dr. Arpita has said. One is a hydrocortisone. So always in the children, hydrocortisone is winning the race. I'm not denying it. But whenever we are talking about the adolescent, you talk about the prednisolone and the dexamethasone. Prednisolone will be perfect for the middle age group. And why? Because it doesn't have that great harm as a dexamethasone do, but it adequately treated in the particularly adolescent. Twice a daily dose is there. Once morning, once night, that is over. And it adequately, it suppresses the ACTH. Whenever you are talking about the obese children or obese adolescent, that time might be dexamethasone will not work. You have to give the prednisolone will not work, or the hydrocortisone. You have to give the dexamethasone as seeing the child age. Why? Only one tablet has to be given in the night, and that tablet will work and for the entire day. And probably by just treating that, you are treating his, her, or his acne, PCOD, testicular raised tumor, and for the future infertility. So this is a side-by-side number that hydrocortisone work for the 8 to 12 hours. So 3 times tablets has to be given. Child is sleeping at the 8. Forget about the ACTH surge in the morning. It will not adequately suppress the ACTH surge. Whenever you have to pull the fire, that time it is not working. If you are talking about the prednisolone, it works twice a daily, and the dexamethasone once a daily treatment is there. So why long-acting agent has won the war? Because you require maximum in the morning. That time it is adequately there to safeguard you. And there is a hydrocortisone which is not working that time. Dexamethasone was there. And why this debate is matter? Because this is the Turkish paper. They have seen that it is a head-to-head trial. This is the gold standard in the medicine. One group has been given the hydrocortisone, second would be the prednisolone, and third would be the dexamethasone. And they have seen that those patients, they have seen the 172 patient with the hydrocortisone, 178 with the prednisolone, and 79 with the dexamethasone. And they have seen the comparison between all of them. What they have seen, there was no significant difference in the 17 OHP and the prednisolone, but they have seen, versus the hydrocortisone versus the prednisolone, but dexamethasone was given. It was correctly suppressed the 17 OHP and the androstenedione. And they have seen that hydrocortisone sometimes in that case has to be given more than 80 milligram per meter square. That Dr. Arpita only denied that if we are increasing the dose, might be the metabolic complications would be high. I'm ready to accept that because it has a metabolic complication, it has a poor problem in terms of the bone density, but this is the warning is written in the endocrine society. So always whenever we are seeing the guideline, we have to see the warning. It is not asked to abandon this medication, but it is asked to use as a manual whenever you require. So this is the what meta-analysis has been told. Prednisolone would be the good options if it is not treated well. Dexamethasone for the particularly for the heavy child, because the highest chances of the suppression would be there. You have to go give for the neurotherapeutic window. You have to counsel the patient, and then you have to switch to the hydrocortisone. And this paper has been shown that dexamethasone in adequately controlled adolescent, it is a retrospective single institute trial. The age group was 15 year, and the 24-hour periods of the CH was there, and they have seen that if we giving the dexamethasone, probably it is treating very good in terms of the suppression, in terms of the PCOD is and for the future infertility. And they have mentioned the lowest dose. So you have to decide the lowest dose and you have to give according to that number. So when suppression restored the fertility in the 78% of the patient, they have restored the fertility, and it would be very beneficial. This is a case report. Then one patient was the sperm count was only 2.4 million. By giving the adequate suppressions, they have seen that sperm count by just treating the drug and switching the drug, they have seen 18 million per ml sperm count has been seen. Why prednisolone usually it is an advantage because it has a suppressive effect and the better psychological management would be there. So higher BMI and the lower bone density would be there with the dexamethasone, but this is the just user manual. You have to use for the short time, and then whenever patient is ready, you have to flip on the hydrocortisone, and it doesn't stunt the growth because at the 13 or the 14-year-old age, probably your puberty has been completed in the CH patient. This is the normal, not normal growing children. They do have a higher androgen central precocious puberty that is led by the peripheral precocious puberty. Why we have to be this is the no, if I summarize my slide, you have to stay on the hydrocortisone whenever the drug is working for you. But in the adolescent, as we seen 50% hydrocortisone is not working, that time probably you have to talk about the prednisolone and the dexamethasone. So there is no universal criteria what drug has to be choose. So I will skip this slide, but I will mention that what Endocrine Society has been said in the 2026. They have clearly seen the goal is always to use the lowest dose that adequately suppress adrenal androgen. And they haven't mentioned about which adrenal androgen or which glucocorticoids you have to choose. They have mentioned that glucocorticoid choice should be remained individualized. So here we have to choose over the precision medicine rather than the population medicine. This is my only slide. Thank you very much.
Dr. Manoj, rebuttal by Dr. Arpita.
So CH treatment in adolescents is a challenging thing to do. And yes, dexamethasone does bring the biochemistry down, the androstenedione and the 17-OHP. There is compliance, there is adherence issue in adolescents, but we have to also see whether this comes at a risk. So the risks are the final height, the lower BMD, and the future fertility options. So we have to judiciously and, as Dr. Manoj said, individualize the treatment and not chase the biochemistry to have a perfect lab values because we treat the child, we don't treat the reports. So with that, I would like to emphasize that the treatment should be individualized. It should not, it cannot be a blanket treatment, one fits all. It has to be individualized. If there is clinical and biochemistry evidence of hyperandrogenism in the form of severe acne hirsutism and the testicular adrenal rest tumors, so definitely we should be considering if we have reached a cutoff of 17 milligram per meter square per day for hydrocortisone, but only after we have checked the adherence, the compliance, and the timing when the sample was taken. Thank you.
Thank you. Thank you to the two debaters for bringing out the flavor of this very, I think the focus of the debate is on a specific subset of adolescents who have not completed their growth potential. So, but their control is compromised. I think that is the focused group which the scientific committee wanted. They have not yet completed growth, but their control is not there. So is it wiser to just add on one more bullet to the armamentarium? The benefits of adding the bullet would be, yes, you're going to have biochemical control. Yes, you're going to have improvement in the TART. You're going to have improvement in the menstrual irregularities. But the cons would be you're going to have a compromised growth, and you're going to have a compromised final height. You're going to have a compromised bone health. The reproductive health may be a pro point. You're going to have a compromised metabolic health and mental health. So I think it's a spring balance. You have points for and points against. I think an individualized decision with consenting of the parents, explaining the pros and cons, and a careful decision has to be made, because you're going to add on one more method for which, and most of the studies in this specific group are all retrospective studies. They are not prospectively planned studies, so to say. So I think who would go in for an additional bullet of Dexa or prednisolone when you have a difficult adolescent who has not completed growth? How many of you would add one more? A very aggressive girl. So the rest of them would just go with old is gold. I'm supposed. Yes. So pediatric endocrinologists are always conservative people. All right. Thank you, ma'am. You can add.
And as Arpita said, once we reach a dose of 17 milligram per meter square, at that time we may consider, and it is important to remember that the conversion of dexamethasone, actually we say 1:25, but actually the dose is much lesser for control. So maybe the conversion would be 1:50. And of course, there are other kinds of growth, methods to increase the growth. And during that phase, like maybe you would have to use some anti-androgen sometimes, or depending on the condition. Thank you.
Thank you, ma'am. Thank you, sir. That was a very insightful debate. Our final debate is on a very commonly encountered issue, which is subclinical hypothyroidism, whether to treat or observe. So speaking for the treatment is Dr. Riddhi Patel, ma'am, and I would like to invite ma'am.
I request all speakers to restrict to 8 minutes.
Very gray zone and most common indication for referral nowadays for subclinical hypothyroidism, because most commonly picked up incidentally or sometimes coincidentally also. So I am favoring the treatment. So this is the normal physiology. We all know TRH, then TSH from pituitary, and then T4, T3 from thyroid gland. And what I would like to emphasize here, ki thyroid normal functioning of the HPT axis is required for multiple organs, starting from head to toe. So brain development, growth, puberty, then normal cardiac functioning, as well as adipose tissue, metabolic parameters, gut health, and the bone health. Okay, so why SCH happens, subclinical hypothyroidism? So any form of stress to thyroid gland resulting in the elevation of the TRH and then elevation of the TSH, but then further axis is suppressed. T4, T3 remains normal because stress is just milder form. And this can happen in any form of initial phase of autoimmune thyroiditis, obesity, trauma, medications, genetic, so many genetic conditions are also associated with subclinical hypothyroidism, and so many of lay bearers are also found nowadays, especially streptavidin and some interfering substance, which would result in the milder elevation of the TSH. So what happens to this mild elevation of the TSH or subclinical hypothyroidism? So this Lancet article has shown that 60% of this patient revert to the normal. So we are not worried about this. 1 to 5% cases per year may progress to overt hypothyroidism. That depends upon the initial TSH concentration as well as antithyroid antibody status. We are also not worried about this, but remains in the middle zone, remain persistent subclinical hypothyroidism. Another paper about the natural history of thyroid function test over 5 years in large pediatric cohort. This is prospective observational study where 1,21,052 children aged 5 to 16 year, 5 months to 16 year from Clelit Medical Health Organization had TSH in 2002 and then followed up TSH in 2007, and 2.9% has subclinical hypothyroidism, out of which 73.5% remained normalized, 2% has increased to overt hypothyroidism, and 0.03% developed overt hypothyroidism, and remaining had persistent SCH. And what was the inference of this study? Female gender and initial TSH of more than 7.5 had higher risk of developing overt hypothyroidism or sustained rise. So I am talking about those who remained in subclinical hypothyroidism with normal FT4 and T3 does not always equal to normal thyroid function. So this is the correlation of the subclinical hypothyroidism with the metabolic complication. And this is my own paper published in IJP showing the effect of subclinical hypothyroidism in obese children and adolescents. And this is the retrospective review of 404 obese children and adolescents. 122, it's large number, 30% had subclinical hypothyroidism. But what we found that obese with subclinical hypothyroidism had significantly higher fat percentage, higher android to gynecoid ratio, and high SGPT level. So inference of this study was SCH predisposes to NFLD irrespective of the severity of obesity. Another paper where serum TSH level are associated with blood pressure in children and adolescents. This was published in Journal of Clinical Endocrinology and Metabolism. And this here they have reviewed 6,400 children 3 to 10 years and 5,918 adolescents 11 to 17 years, and where 2 readings of blood pressure were taken in sitting position, and TSH was measured with the CLIA method. What they have found that serum TSH were significantly associated with hypertension in children as well as adolescents, very high odds 1.112. And so what was the inference of this paper? SCH increased the risk of hypertension in children and adolescents. Third study, SCH had any cardiovascular risk or not. So cardiovascular risk factors in children with long-standing untreated idiopathic subclinical hypothyroidism. Here, 49 children with persistent long-standing SCH were compared with the 49 control. And what they have looked, which metabolic cardiovascular risk parameter they have looked: BMI, waist to height ratio, lipid profile, HCRP, that is high reactive CRP, homocysteine, insulin, and HOMA-IR, fibrinogen level, and adiponectin were measured. And what they have found, there was significant high level of waist to height ratio, atherogenic index, triglyceride to HDL ratio, and homocysteine level in SCH subgroup as compared to the normal healthy children. So mild, long-standing, untreated subclinical hypothyroidism is associated with the subtle proatherogenic abnormality in children as well. SCH, again, another study where they have measured epicardial fat thickness in children with subclinical hypothyroidism and its relationship to the subclinical atherosclerosis. This was the pilot study of 35 children with autoimmune subclinical hypothyroidism. They have compared 35 age and gender matched control and 2D echo was done to measure the endoepicardial fat thickness. And what they have found that there was significantly higher epicardial fat thickness, lower FMD level in the patients who had subclinical hypothyroidism as compared to the healthy children. So children with SGH subclinical hypothyroidism has higher epicardial fat thickness and higher risk of this subclinical atherosclerosis. So should we wait or should we start the treatment? And can the strategy of watchful waiting be justified in each and every child with SCH? So we'll look this paper, SCH and short stature. And in this paper, they have shown that there is height improvement with levothyroxine treatment in subclinical hypothyroidism. 267 children admitted with short stature, and out of which 39 had subclinical hypothyroidism. They were divided into the prepubertal and pubertal age group, and their anthropometric data compared before and 6 to 12 months after the levothyroxine treatment. And what they have found that both the groups have showed significant improvement in the growth velocity and growth velocity SDS after the treatment. So levothyroxine treatment in patients with short stature after ruling out the other causes can improve the height velocity. This is the research article of the subclinical hypothyroidism in childhood treatment of follow-up, and where they have seen that 65 patients with age of 2 to 18 year were retrospectively studied for 6 to 12 months, and they have seen that 44%, they have found that 67% TFT is normalized, TSH persistently elevated in 21% with negative antibody, 7 had raised TSH more than 10 and mildly elevated positive antibody, and they are given treatment. So, female gender and positive antibody increases the risk of overt hypothyroidism, need treatment. That was also inference of this study. And SCH progression, so 5-year follow-up of the 127 girls with subclinical hypothyroidism with different etiology, and they have found that rate of progression to overt hypothyroidism was high in the those who had associated positive antibody. So this is the autoimmune thyroiditis and associated syndrome. But even quarter of the patients with who have idiopathic subclinical hypothyroidism, they also need treatment. So I'm worried about this. Those who had idiopathic hypothyroidism with subclinical hypothyroidism. This is the paper published in endocrinology related cancer, and levothyroxine treatment with nodular goiter lower the serum TSH and lower the frequency of the papillary thyroid cancer. And this is the very well known phenomenon कि higher the TSH is associated with the higher risk of the development of the papillary thyroid cancer. So all patients who had nodular goiter require the levothyroxine treatment despite the subclinical hypothyroidism. Only one paper I found that effect of levothyroxine treatment in children on the cardiovascular risk parameter, and here they have seen that there is improvement in the cardiovascular risk parameter with levothyroxine treatment. This was the case control study of 39 children with SCH and 39 healthy control. And what they have found, there was significant improvement in the waist to height ratio, HDL level, triglyceride to HDL ratio, homocysteine level, and ADMA with levothyroxine treatment. So LT4 treatment has beneficial effect on cardiovascular risk parameter. So again, we are dealing with the debate of SCH to treat or not treat. So decision to treat depend upon the baseline TSH level, underlying etiology, signs or symptoms of hypothyroidism, goiter or thyroid nodule definitely need treatment, and proatherogenic risk. Okay, so my final slide and approach to treat or not, that is like if any patient with subclinical hypothyroidism with normal T3, T4 and high TSH, if TSH is more than 10, definitely start treatment. But do the workup for etiology, but start treatment. If TSH between 4.5 to 10, gray zone, look for the risk factor, especially We all know other risk factor, but also look for the cardiovascular risk factor, because that is most emerging parameter, because they are more prone to develop this cardiovascular atherosclerosis risk. If it is there, start the treatment. No, then you can wait. It's not working, but if these risk factors are not there, you can wait and continue monitoring at least 3 to 6 monthly. If it is progressive, start treatment. If remain normal, then definitely not need to treatment, but continue monitoring those who remained in the borderline for at least 6 months to 1 year. Thank you.
Thank you, ma'am. Now I would invite Dr. Sandeep sir to speak against the motion.
Thank you, ma'am, for speaking in favor of treatment. Now I am going to speak where treatment is not required. So we'll describe the definition of pediatric subclinical hypothyroidism. We'll understand the natural history, as ma'am has already discussed. We'll review evidences regarding the effects on growth, the bone health, obesity, cognition, and metabolic outcomes. We'll identify the children who doesn't require treatment and what should be the long-term follow-up for those children. So as definition is there, elevated TSH with normal FT4, mild SCH is between TSH between 4.5 to 10, which is the gray zone, and severe SCH is TSH more than 10, where we all recommend treatment. So the prevalence of mild subclinical hypothyroidism in children and adolescent in last studies is found to be between 1.7 to 2.9%. So why are we diagnosing more and more SCH? Because as we all know, TFTs are included in the health checkup packages. So very often it is found to be elevated. Again, in routine pediatric practice, there is increased awareness and more TFTs are ordered. Obesity epidemic rather. So more and more TFTs are being ordered. Parents are now more aware. They often demand TFTs. And during the evaluation of non-specific symptom, often we do TFTs. And again, with improved lab sensitivity, we pick up small changes in the TSH. And causes, as ma'am has already explained, Hashimoto thyroiditis, then genetic mutations or genetic syndromes like mutation in the TSH receptor, dual oxidase 2 mutations, Down syndrome, Turner syndrome, persistent neonatal hyperthyrotropinemia, obesity can lead to mild SCH, iodine deficiency or excess, ionizing radiations, medications like amiodarone or anti-epileptic drugs. And last but not the least is idiopathic subclinical hypothyroidism. The natural history, as ma'am has already discussed, 40 to 70% of the mild cases, they normalize spontaneously. Many of them remain stable, and around 10 to 11% they progress to overt hypothyroidism. So it can be a transient biochemical abnormality, and we have to observe to look for the progression. So in this study, a five-year prospective evaluation of thyroid function in girls with subclinical hypothyroidism. Ma'am has already quoted this study. In this study, there were 42 girls with idiopathic subclinical hypothyroidism and around 85 girls with Hashimoto-related subclinical hypothyroidism. And over a period of 5 years, it was seen that around 60% girls, they became euthyroid in group of idiopathic, and around 10% became euthyroid in Hashimoto thyroiditis group. And around 25% of the girls remained subclinical in idiopathic group, and 55% remained subclinical in Hashimoto thyroiditis group. And around 11% of the idiopathic group progressed to overt hypothyroidism, and 30% from the Hashimoto group progresses to subclinical hypothyroidism group. So in the conclusion, the progression to overt hypothyroidism is less in idiopathic as compared to the Hashimoto group. Growth outcomes in the study on linear growth and intellectual outcomes in children with long-term idiopathic subclinical hypothyroidism. In this study, 36 children with persistent mild subclinical hypothyroidism were enrolled. The mean age was 9.7 plus minus 0.6 years. They were followed up for around 3 years, and they were compared with the 36 healthy sex and age match controls. They were assessed for growth, the thyroid function, and intellectual outcomes, and the height, BMI, bone age, chronological age were normal at the baseline. and they remained normal at the follow-up of 3 years. Clinical course, there were no children having overt hypothyroidism during the follow-up. The verbal performance and full-scale IQ remained normal, and there was no association found between the IQ and severity and duration of subclinical hypothyroidism. So, as a conclusion, the mild subclinical hypothyroidism has no effect on the growth, delayed bone maturation, and reduced intellectual performance during the 3 years follow-up in the study. Bone health outcomes in this study, bone health in children and with long-term idiopathic subclinical hypothyroidism, non-on treatment. So 25 untreated children and adolescents were included with idiopathic mild subclinical hypothyroidism not on treatment. The mean age for this population was 9.8 plus minus 3.5 years. And the follow-up was 3.3 plus minus 0.3 years. And against 25 age and sex matched healthy children were included as control. The bone health was assessed based on the DEXA for lumbar spine to look for the BMD, and quantitative ultrasound of non-dominant proximal phalanges to look for the amplitude dependent speed of sound and bone transmission time. So in this study, the lumbar spine BMD, the bone quality based on ADSS and bone transmission time were both comparable in the both groups, and there was no deterioration, and all bone parameters were within normal limits. So net effect is that long-term untreated subclinical hypothyroidism doesn't affect the bone health. Neurocognitive outcomes. In the National Health and Nutrition Examination Survey 3, around 1,327 adolescents were included in the age group of 13 to 16 years. Thyroid group was subdivided based on the TFT levels in subclinical hypothyroidism, subclinical hyperthyroidism, euthyroidism. They were assessed cognitively with revised wide range achievement test and revised Wechsler's intelligence scale for children. And the cognitive outcomes were divided into reading, arithmetic, block design, and digit span domains. So as you can see, subclinical hypothyroidism group remains better than the subclinical hyperthyroidism and euthyroidism in most of the domains. And subclinical hypothyroidism could be a potential risk factor for neurocognition. Metabolic outcomes. Long-standing untreated mild subclinical hypothyroidism has been associated with subtle proarthrogenic cardiovascular risks and changes, but it is just an association, and long-term effects are not been found. So long-term studies are required to look for the effect of this changes. Obesity, as we all know, there will be a high leptin, which will lead to more TRH, and this TRH will lead to more TSH. The net effect will be mildly elevated TSH with normal free T4. And as we have seen in a lot of many studies, that obese child will have mildly elevated TSH, normal free T4, and this is a effect of obesity, not the cause. So we should focus on the weight reduction. When there is weight reduction, there will be decrease in TSH, there will be normalization of TFTs. So ultimately, levothyroxine is not the treatment of obesity. Why routine treatment may be harmful? So the question is, why we should not treat all? Because it will lead to medicalization of a normal healthy child. There will be a cost burden on the family, cost of treatment, cost of investigations, cost of the traveling, cost of loss of daily wages, cost of a doctor's appointment. Frequent blood sampling in the child will lead to anxiety, will lead to monetary loss, family anxiety, and sometimes over-treatment can lead to iatrogenic hyperthyroidism. So what we should do, as ma'am has already mentioned, we should observe rather than treat if TSH is less than 10, if the free T4 is normal, if there are no symptoms of hypothyroidism, no goiter or nodule, and antibodies are negative with normal growth. Practical follow-up strategy in mild subclinical hypothyroidism, we should repeat the TFTs 3 to 6 months, and if stable, at 6 to 12 months, and we should simultaneously monitor for the growth, the puberty, the symptoms of hypothyroidism, goiter or nodule, and thyroid antibodies. So it is usually benign, and most of them, around 70% normalizes with time. Growth and puberty is usually normal. Cognitive outcomes are normal. Bone health is not affected, and obesity-related subclinical hypothyroidism normalizes with the weight loss. And levothyroxine as a routine is not going to improve the outcomes on the cardiovascular outcomes. So these were my references. Thank you very much.
Patel by Dr. Riddhi.
Um, I am with Dr. Sandeep that though treating idiopathic variety of subclinical hypothyroidism would not affect the height velocity, bone health, neurocognition, but still unanswered question is cardiovascular risk parameter. And though so many studies have proven that there is association of idiopathic untreated subclinical hypothyroidism even in pediatric patient have higher risk of proatherogenic the parameters as well as cardiovascular risk parameter. So observe those patient, at least we can do lipid profile, waist to height ratio, and some of the laboratory parameter which is mentioned like homocysteine and HSCRP. If they are altered, don't wait, start treatment. And if they are not altered, then wait and watch for the progression of this parameter. But frequent monitoring is must. So it's not like don't treat because it doesn't affecting height or bone health or neurocognition, because so many adult studies are proven that is treating the subclinical hypothyroidism has cardiovascular benefit, though pediatric data are still not yet proven or long-standing data are available, but we should be very cautious.
Thank you very much, ma'am. As you said that subclinical hypothyroidism has more proatherogenic properties and risk factors, but ma'am, as I've seen in the studies, these are risk factors, and none of the studies have shown the effect of levothyroxine in reduction of these risk factors. So basically, these are just associations, and we don't know the long-term follow of this patient and effect of levothyroxine on the risk factors.
Were these studies corrected for obesity? I
Ma'am?
mean, the presence of obesity and the association, was it just because of obesity that they had an association?
Were these factors taken in consideration, ma'am?
Not on the non-obese children. So, they did not treat them. Long-term studies, they are just still.
Thank you to both the debaters. I think it's a volcano that is hidden inside. We don't know whether it is active or whether it is a dormant volcano. In terms of the long-term growth, metabolic health, cardiovascular health, psychological health, bone health, we really don't know at this point of time. But I think the guidelines have been summarized very beautifully. Persistent elevation of TSH probably warrants action. And just to continue with yesterday's, we should not forget the impact of heterophile antibodies, which can cause a mild increase in TSH, carryover effect, and isoforms of TSH, which can be biochemical abnormalities that are masquerading as clinical abnormalities that warrant replacement. So I think the debate is out, and vote how many of them would really treat the sub.
Bodies, and we have to see all these entity presence of goiter. If these are present, then we have to start treatment. And apart from these, we have to look for obesity, stress factor, any sickness. We have to rule out all these things also.
True. Nicely pointed out. Thank you, ma'am. I think with that, we thank the organizers and thank you everybody for the opportunity. And on behalf of madam, I think these debates have opened multiple opportunities for research. So I think the society runs a very nice journal, JPET. So request all of you to take this forward in your practice, explore these research opportunities and submit it. ISPE president is here. Madam is the editor of the journal. We look forward to submissions from you in the journal. Thank you very much.
Thanks a lot. I think this was a wonderful debate. Just hold on. We will like to honor the all these chairpersons and the debaters as well. I request, yeah, one minute. Okay. So I request Dr. S.P.
Hemchand sir. Riddhi ma'am. Sandeep sir. Manisha Maurya ma'am. Manoj sir. Arpita ma'am. Uh, Science sir. With this, we have come to a very and end of the power packed session. Now we move from argument to evidence. That is recent advances in pediatric endocrinology session. To chair this session, may I invite Dr. Namita Mishra ma'am, Dr. Dr. Prasoon Ristogi sir, and Dr. Medha Mittal ma'am. Please take the seats.
So Dr. Prasoon is he has been associated with Paras Hospital and he has been part of our events for many times. Welcome, Dr. Prasoon. Dr. Namita, please. And Dr. Medha. I'll also request Dr. Vijay, since you are there, to please join up because we'll be happy to have your insights. Dr. Medha is faculty in Chacha Nehru Bal Chikitsalaya. And Dr. Vijay is HOD of LLRM Medical College, Meerut, Pediatric Department.
Growth hormone therapy has entered a new era with long acting formulations, aiming to improve adherence with maintaining the efficacy. May I invite Dr. Ganesh sir to give this talk on long acting growth hormones?
Just a show of hands, how many of you are scared of getting injections? Okay. If you have to take a injectable therapy, how many of you, if you have a choice between daily and let us say monthly therapy or a weekly therapy, how many of you would go for less number of injections? Right. And let's take an example of our clinical circumstance where in precocious puberty, there is, that there's a choice of monthly versus 3 monthly depot formulations. So inherently, as a human being, or when you are seeing these children, do you think that there's a little bias towards preferring the 3 monthly injections over the 1 monthly injection just to avoid more number of injections to the child? Agree? Yes or no? Yeah. So I think it's only natural that there's a plethora of medications now in market in terms of long-acting medications. GnRH analogs is the most commonly used example. We know those who have managed children with neonatal hypoglycemia would know that we had to give octreotide so many times, and once these long-acting formulations have become available, life has become much, much more easier. We yesterday discussed once a week basal insulin. And in terms of GLP-1 analogs, those taking daily liraglutide versus weekly semaglutide, obviously there is a preference for weekly injections. It is given that oral will be preferred than even weekly injections. So oral gets more preference, but in some molecules such as insulin, that choice doesn't exist. Similarly, growth hormone falls in the same category. So daily growth hormone has been, the recombinant one has been available since 1985. It has been shown to be highly effective for growth hormone deficiency as well as several non-growth hormone deficiency. However, the problem of non-adherence is quite common. So this was a study done in New Zealand. This was a national survey of about 180, 177 to be precise, children receiving growth hormone, and they just kind of assessed the compliance because it's a public health system, they assess the compliance of, in terms of amount of vials of GH that was returned to the formulary to see how much of it was used. And it was found that almost 66% of patients were non-compliant to the daily growth hormone therapy. So the compliance here was defined by at least more than 85% of adherence to the treatment regimen. So this creates a problem, because although the therapy is effective, it will be effective only if you take it. So those with low adherence had lower height velocity SDS, as compared to clearly better outcomes were seen in those with higher adherence. Particularly, some of the ethnic groups were associated with, the indigenous ethnic group was associated with lower compliance, probably because of the socioeconomic status. In addition to compliance, there remains a concern about the injection schedule and pain, which was reported as the most common of their concern, in terms of the children saying that their injection pain would be the, sorry, let's go back. How does this go back? Okay. So injection site related pain would be the most common concern reported by their children, and the hassle of giving it daily at a fixed time, that thing interfering decisions about travel, schedule, etc., was also one of the concern. As a result, the non-adherence of therapy leads to obviously affected height outcomes. Sometimes it may lead to a lot of workup for why the non-adherence is there, or unnecessary changes to the drug dose. Sometimes conflicts between the parents and the doctor, because it becomes like as if some code to addict, that we are saying that you are missing the dose, they are justifying that we are not missing the dose, etc. So reducing the number of injection theoretically would be expected to improve compliance. I'm saying theoretically because long-acting growth hormone therapy is a recent addition to therapy, and we don't know whether this assumption holds true in practice, because non-adherent may be non-adherent even to the weekly. So real-world outcomes are yet, I would say, awaited. As of now, the data that is there is largely from the trials, phase three studies, and although they have been conducted for a very long period of time, but real world outcomes are still lagging behind. So how is the long action achieved in terms of growth hormone? So just like many other, it's classically the insulin formulation, the long action will be achieved either by the slow release from the subcutaneous depot or reduced renal clearance. Okay, and also the receptor affinity. So these are the three ways through which the long action is achieved. So in terms of the three commonly available preparations, the somapacitan is the one that is the most recent here. So here there is a single point mutation in GH with a albumin binding moiety, which leads to slow release of the medication into the circulation. Somatrogon is a fusion protein, and lonapeg-somatropin is a pegylated molecule. In addition to these, there are two molecules which are approved in specific countries. So there is Jintrolong that is approved in China, and there is Utropin, long-acting Utropin that is marketed in Korea. These are exclusive to these countries only. So we will not be talking about those products here. How does it go forward? Yeah, Sabinita. This is stuck. Escape.
You carry on.
Yeah. Yeah. Huh. So as I discussed, somapacitan has this single amino acid substitution of leucine to cysteine and a hydrophilic spacer and a albumin binding moiety, which kind of holds the protein for a longer period of time. Somatrogon, which is another available, which was, I think, available from 2022 or 23 in India, contains it's a fusion molecule with growth hormone molecule fused to the C carboxy terminal peptide of the beta subunit of the HCG, beta chain of the HCG. This extends the half-life by decreasing the clearance of the molecule. Conceptually, whereas daily growth hormone would give a daily dose, these red waves that you see, the weekly growth hormone, this is the pharmacodynamics. So after the injection of the dose, on the third or fourth day, the levels will be maximum, and then the low levels will decline and last up to for 7 days. So closer to 7 days, there will be a trough in the action. So one may say that this is not mimicking the physiological growth hormone action or secretion, but even the daily growth hormone per se doesn't mimic the physiological secretion, because ideally the physiological secretion is growth hormone pulses secreted through the 24-hour period. So as I said, that all these molecules have had phase 3 studies showing non-inferiority to the daily growth hormone in growth hormone deficiency. And now increasingly the data is coming up on SGA, idiopathic short stature, and other conditions. So this was a study, a real 4 study on somapacetine, where 200 prepubertal children were assigned randomly to receive daily growth hormone versus 0.16 milligram per kg per week. This dose was decided in the phase 2 studies, that is the dosing study. So 0.16 milligram per kg per week. And it was given for 52 weeks, and subsequently there was an extension up to 3 years. So the randomization was in 2:1 frequency. And it was shown that the growth velocity, that was annualized growth velocity with somapacetine and daily growth hormone, was comparable. I think it was somewhere to the tune of 11 centimeters in a year. From the time of randomization, subsequently, the annualized height velocity was comparable throughout the study period in both the groups. It was also well tolerated in children with GHD at 3 years of age, mainly the injection site related side effects such as pain, erythema, swelling being there. And in this particular study, no neutralizing antibodies were detected. In some other studies with somatrogon, neutralizing antibodies were detected. So this is the data from the somatrogon study, which was published in 2022. Again, it's a phase 3 non-inferiority study compared to somatropin. The weekly dose here is 0.66 milligram per kg per week. Again, these doses are decided by trying multiple doses in phase 1, phase 2 studies, etc. If you can see the daily dose or daily growth hormone doses that are there in these particular studies are to the tune of 0.034 or 34 microgram per kg per day, which is kind of, I would say in GHD, that is a little, I mean, in India, the doses that we use, 35 would be on the upper side for the GHD individuals. Again, similar height outcomes in terms of the annualized height velocity were seen in somatrogon versus daily somatropin therapy. The third molecule that is currently not available in India but is available elsewhere is lonapeg somatropin. Here it's a pegylated product. It acts like a prodrug. So after it has been administered, the active drug is released and is released slowly into the circulation. The half-life is about 25 hours and the dosage recommended is 0.24 milligram per kg per week. It comes as an auto-injector device, which has to be used within 4 hours of reconstitution. It's not a multi-dose. In the other two products, the dose is decided and the vials are multi-dose. So you can use this vial for 2, 3, 4, depending on the number of injections that would be, depending on the dose, of course. In phase 3 studies, it was shown to be non-inferior as well as superior to daily GH for the primary endpoint of annualized height velocity at 52 weeks. Now, who are the children who may particularly benefit from the long-acting growth hormone? This is from the JCEM consensus statement published in 2025, which largely again is an expert opinion-based consensus and probably more of a generic logical kind of a statement. But children with risk of poor adherence, typically adolescents, and those with proven non-adherence to daily GH, those who are receiving multiple medications, hypopituitarism, or let's say cancer survivors, or cancer survivors, I would talk later. Neurodiverse children, children with autism, ADHD, where daily administration may become particularly very difficult. Those with a lot of fear or anxieties with needles, having frequent travel schedule, and children living in more than one home. So storing this is particularly true for separated families or children shuttling between the grandparents and parents' house, etc. So instead of storing the molecule at multiple places, this is just a logistical difficulty. So these are the situations where weekly growth hormone may be particularly more beneficial. The recent news is that in February of 2026, the Novo Nordisk's long-acting growth hormone, once-a-week growth hormone, has also been approved by the US FDA for idiopathic short stature, SGA with failure to catch up, and Noonan syndrome. Again, this is based on phase 3 studies in these particular situations. Some practical pointers with respect to the weekly growth hormone therapy. Remember that weekly dose is not same as daily dose into 7, unlike what we discussed in the once weekly basal insulin. These growth hormone doses are decided in scientifically done phase 2 studies, and we should try and adhere to the recommended schedules. In terms of somapacitan, it is 0.16 milligram per kg per week. In terms of somatrogon, it is 0.65 or 0.66 milligram per kg per week. Dosing can be adjusted on ideal body weight in significantly obese children, because if we just take the actual body weight, the dose will be practically impossible to administer. Preferably fixed day of the week. It can be given at any time of the day. It is necessary that it has to be given at bedtime, unlike the daily growth hormone therapy. Injection site rotation is important, as if you administer, because this is a depot formulation, it is going to stay in the subcutaneous space for a longer time. So if you keep on giving multiple injections at the same place, injection site atrophy has been shown in some of the studies. In case the dose is missed, the missed dose can be administered within 3 days in somapacitan and somatrogon. And in case of somatropin, it should be administered within 2 days. And the next dose has to be administered as per the previous schedule. So that previous schedule would continue. IGF-1 monitoring is more important in these molecules, unlike in daily growth hormone. In daily, we do once in 6 months or once in a year to avoid over-treatment. Remember that IGF-1 monitoring is more from a safety perspective. So if IGF-1 levels are more than 2 standard deviation for that particular age and sex, you will titrate the dose downwards to get the IGF-1 into safer range. As I said, adverse effects are mainly local, injection site related redness, pain, or swelling. Lipoatrophy is one of the side effects that we should be aware about. Particularly in the somatrogon study, about 77% developed antibodies. In somapacitan, I think the percentage of non-neutralizing antibody was very, very less. The non-neutralizing, these antibodies typically do not cause GH resistance, unlike in GH1 gene deletion, where the antibodies would interfere with the GH action that we are giving, forcing us to give IGF-1. But in these particular situations, these are non-neutralizing antibody. They do not affect the efficacy of binding of GH to the GH receptor. Because there is a trough effect towards the end of the medication, in neonates or in infants or younger children, those who are having hypoglycemia as a manifestation of GH deficiency or hypopituitarism, the risk of hypoglycemia would be slightly higher towards the end of towards the trough period, and therefore glucose monitoring would be important in that phase. I don't claim to have a lot of number of children on the weekly growth hormone. There is a small group, I would say. One consistent observation that I have, I mean, except for the period in which the daily growth hormone had just gone out of, market, we've largely stuck to only growth hormone deficiency. We've not given long-acting growth hormone for non-GHD condition. So this particular child had come with short stature, otherwise totally normal, no other systemic conditions, and the workup was also normal. His height was minus 3.8 standard deviation on WHO growth chart. Although the bone age was delayed, considering the severity of short stature, we went ahead with the growth hormone stimulation test, and the peak value was 2.75 nanogram per ml on glucagon stimulation test. So we gave this child, we discussed both the options, daily as well as weekly. The parents chose weekly injections, and he was given weekly somatrogon. So there is a one standard deviation, although one standard deviation change in terms of delta change of the height standard deviation. Although one pitfall here is that because the child at the beginning was 4 year old and now the child is 6 year old, so the type of chart that we are using has changed. So the first standard deviation is on WHO growth chart, and the second standard deviation is on IAP growth chart. So maybe Anurag or Rajni or Hemchand can help in deciphering how to tackle this situation, because I don't have the data of IAP standard deviations below 5 years of age. So this is a practical problem. Although, and the growth chart, you can see that this child has shown improvement. So one prominent observation that I have with weekly formulations is that you don't really see that spike of height that you kind of see in the daily growth hormone therapy. However, what happens with the daily growth hormone therapy is you may get a spike, but later on it kind of tapers off. So here, at least in the literature, it has been shown that the results, the improvement in growth velocity seems to be sustained. So what ultimately they may end up achieving the similar heights. One is achieving at a continuous sustained speed. One is achieving a portion of it faster and then tapering off. So final height may be similar, although the final height outcomes, etc., remains to be seen, because these are new products and we have to carefully interpret the data that is reported in the company drug trials. So to end my talk, I would say that daily GH is effective, provided it is taken daily. Okay, so adherence problems are practical. Adherence to treatment remains poor. This can interfere with the outcomes of growth hormone therapy. And weekly administration is definitely likely to improve compliance and improve outcomes to therapy. Currently available LAGS formulations, these are the three. I mean, in India now, I think one was available, one is becoming available or has become available now. So these currently available preparations are shown to be non-inferior to daily GH in the GHD cohort. Remember that all these studies have excluded cancer survivors. So we don't know right now in the date. The word is not out on how to use these medications on cancer survivors. So that is one group we'll have to be careful about. Definitely now SGA, ISS has been like approved, and I think increasingly it will get used over there also as we see more and more data. IGF-1 monitoring is important. We need to wait the long-term safety data as well as the long-term outcome data from the real-world studies. But this is an interesting development. I think slowly, everybody, once the weekly formulations are available and are shown to be effective, natural choice would be to shift from daily to weekly formulations. Thank you.
Thank you, Dr. Ganesh, for Thank you, Dr. Ganesh, for presenting such convincing evidence. Any situations, practical situations, where would you still go for daily ones?
Yeah, see, I am a little conservative sort of a person. So any new therapy, I don't just blindly trust them. So my approach is right now to discuss both the options, and the family's choice would remain the priority. If I have less time window available, if I don't want to really, if I'm treating a younger child like this, I don't have hassles, because even if the therapy was not effective, I would kind of change to daily GH later. But if I have a narrow window available for me, then I wouldn't probably experiment right now. So I would choose daily GH over there.
Thank
In
you.
terms of cancer patients and in terms of other conditions such as Prader-Willi, I would go for daily, definitely.
Any questions from the house?
The clinical monitoring would remain the same. So because height, growth velocity, delta change of height standard deviation, bone age, those monitoring would remain the same. The only difference that is there is that the IGF-1 monitoring is little more frequent. I think some countries, probably Japan or some countries, recommend every 3 monthly IGF-1 monitoring in these individuals. But I would say, considering the cost, etc., you can individualize the frequency between 3 to 6 months.
Thank you, Dr. Ganesh.
Thank you.
Thanks a lot for the informative talk, sir. Next up, we have a talk on recent advances in DST by Dr. Rajni Sharma. I'm Dr. Suyash Gupta. I'm a DM in endocrinology from Bhopal, Madhya Pradesh. And today I'm MOCing with Dr. Ria. Please.
Thank you. So we're going to discuss an update on approach to case of DSD. So as you all know, DSD, also known as differences of sex development, is a heterogeneous group of disorders with discrepancy in the 3 Gs, that is genetic, gonadal, and genital sex. And the incidence is approximately 1 in 5,000 newborns. They can present either with atypical genitalia in the newborn or infancy, or in adolescents with abnormal pubertal development. So let us come to this case with a baby with atypical genitalia, and on examination, female-looking genitalia with fused labia and single opening at the base, clitoromegaly of 1 centimeter. However, there is a gonad palpable on the right side, and the external genitalia score is 5.5 by 12. So basically, now we are more shifting to the external genital score, in which we have, there are, based on the various, the labioscrotal fusion, the presence of genital tubercle, urethral meatus, where it is located, and the presence of gonads. So basically, based on this, a total score of 12 is generated. And this is gender independent, like it can be used in either sex. And EGS has been found to be a reliable and valid score to describe external genitalia in premature and term babies, both up to 24 months of age. So these are the various external genitalia score given from the 10th to 90th, the centiles. And we can see that less than 28, the median would be around 10. And in a full term baby, the median would be 12, with a variable from 10.5 to less than 12. So if it is less than 10.5, then we would investigate for DST, and females would have a score of 0. So previously we were using the external masculinizing score, as you all know, but what happened in this was that this was a very, either it gave a score of 3 or 0. So as a result, there was a lot of overlap in the severely under-virilized and less virilized. So it did not give much information. And in females, the virilized females, Prader score is used, in which the stages 1 to 5 are there. We are still using Prader score, but now the shift is more towards the external genital score. And this score has also been validated in India based on a study from PGI, in which it has been shown that this score is valid for Indian babies as well. Now, coming to the principles of initial evaluation, the same things like the history examination are very important with the investigations. The main thing is that we have to rule out any life-threatening disorder like congenital adrenal hyperplasia. Then we have to classify and give the etiological diagnosis. Family support and counseling are very important. Gender assignment and referral to a multidisciplinary team. Now coming to history, so there is no doubt that the history and examination are still very paramount. We have to take the history of vomiting, lethargy, failure to gain weight, any hyperpigmentation, the antenatal history of maternal virilization, drug intake, like progesterones or spironolactone, and the family history, early neonatal deaths, DSD, and infertility. So I want to just emphasize on the family history. Many times, I would like to share my experience that once we had a baby we have a boy with congenital adrenal hyperplasia, and he landed up in the emergency with adrenal crisis. So when the mother was not there, and the grandmother was there. So I asked her, where is the mother? So she said she has just delivered a baby in the other hospital. So I said, what is it? Is it a boy or a girl? Then she said she was very reluctant to say. Then basically the child had atypical genitalia and they had not revealed the gender. So, and the whole team was doing a lot of workup in the other hospital. They had even gone up to doing an MRI for the gonads because the gonads, they could not palpate. Basically, it was a girl, virilized girl. So they were doing an MRI to look for the gonads. So what I'm trying to say is that the whole team had forgotten to take the family history. And they could have easily taken the history that the child is already a case of congenital adrenal hyperplasia. So always ensure that your residents are doing a complete workup. And that would have saved a lot of investigations. So once the 17 OHP was sent, then the diagnosis was made in that baby. Then examination, always do a head to toe examination, including vitals, blood pressure, dysmorphism, hyperpigmentation. Dysmorphism is very important because there are a lot of syndromic DSTs. And systemic examination, anthropometry, and then the complete genital evaluation. The investigations also remain standard. We do electrolytes, blood sugar, 17 OHP, and we do the karyotype, which is very essential in all children. We may send a fish for Y material to get an early diagnosis regarding the presence of Y material. Imaging, that is ultrasound, is always done to look for the uterus, and then the hormonal evaluation. Again, I would like to share another anecdote regarding karyotype. So what happened was the baby was born and the team just sent this child came to us when he was around 16 years of age with atypical genitalia, and he was being followed up in another hospital in pediatric surgery. So what happened was that he was short, and when we reviewed this thing, everywhere it was written 46XY. But when we looked deeper, we realized that actually only fish material for Y had been done in the baby, not a proper karyotype. And based on that, he was labeled as 46XY. But actually, when the karyotype was performed, it was a mixed gonadal dysgenesis, that is 46XO-XY. So there are total different implications in that case, in which the height and other cardiovascular and other things also have to be looked, because it is a variant of Turner syndrome. So again, I'm emphasizing on the need for karyotype. Now, this is a very good, review article published in Nature's Review in 2025. The classification remains the same based on the Chicago consensus. And basically, it is based on the karyotype, that is 46XY, sex chromal DST, that is 46, mixed gonadal dysgenesis 46XO, 46XY, and even Turner and Klinefelter are included in that, though they don't present with genital ambiguity, and 46XX DST. So these are the three main. In 46XY, we have the disorders of androgen synthesis, androgen action, disorders of Leydig cell function, then persistent Mullerian duct syndrome, and other non-specific DSTs. In the 46XY, mainly we have the gonadal development issues or the disorders of androgen excess. And 46XX syndromal is basically the Mullerian, Muller-Yucatanzi-Hauser syndrome, in which the uterus is hypoplastic. Now coming to the ultrasound, which is very important to perform when we have a baby with atypical genitalia. It tells about the presence or absence of uterus and provides important, fast, and easy to assess findings that guide in the diagnostic evaluation. It helps to localize the gonads. And you can also look at the adrenal glands, whether they are hyperplastic, and identify any associated renal anomalies. So hormonal evaluation, as we all know that we have a window of 30 to 100 days when the child has a mini puberty. So that is the opportunity to do the basal biochemical investigations, including LH, FSH, testosterone in a 46XY male baby, and in a estrogen if we are suspecting aromatase deficiency in a 46XX, because in that the estrogen levels will be very low. After that, we have to rely on an HCG stimulation test to look at the testosterone, DHT, and androstenedione. So we look at the testosterone DHT ratio as well as the testosterone androstenedione ratio, which can tell us whether it is 5-alpha reductase or it is 17-beta HSD deficiency. During puberty, we may assess the gonadal function by a GnRH stimulation test. And AMH and inhibin B are also very important because AMH will tell whether there is a presence of any testicular tissue. So normally XY males will have 100 times the AMH concentration compared to 46XX. And inhibin B levels will also be 10 times higher in 46XY with a testis. Now, when you are suspecting any androgen biosynthetic defect, then you would do an ACTH stimulation. And ideally, those hormones should be done measured by LCMS-MS, which is the more specific method of checking the steroids. Now coming back to this case, so when we did the electrolyte 17 UHP, they were normal. Ultrasound pelvis showed no uterus. The day 30 LH was in the pubertal range, 6 FSH was 2. Testosterone was also normal, more than 100 at this age is considered normal at this mini puberty. It was 200. The T-DHT ratio was also within normal, less than 20. So 5 alpha reductase was a little unlikely, though it is a not very good measure, not very specific. The AMH, as you can see, is 80 nanogram, which is in the male range. Females would have up to 10, and boys would have up to very high levels. And cortisol is normal, and the karyotype is 46XY. So which group does this fall into? 46XY with androgen action effect, I guess, because testosterone is normal. And so this is the diagnostic algorithm for DST. Basically, you do the physical examination first and you look for any identified gonad. So in this child, we have an identifiable gonad. So we have an identifiable gonad, and once we do the ultrasound shows that absence of uterus. Then we look at the karyotype. So if the karyotype is uterus is absent, then it is a 46XY. Then it could be it could either be a testosterone biosynthetic defect, but in this the testosterone is normal, or it could be 5 alpha reductase deficiency or androgen insensitivity. And if the uterus is absent, the identifiable testes are there, uterus is absent, and the karyotype turns out to be 46XX, then it is a testicular DST. On the other side, if the testes are identifiable and the uterus is present with a 46XY, then it is a partial gonadal dysgenesis or AMH resistance or deficiency. If it is a 46XX, then it is an ovotesticular DST. And if it is a mixed gonadal dysgenesis, if it is 46XY or 45X combination. Now, if there is no identifiable testis and the uterus is present, then this is quite straightforward. Then it is a 46XX, then it is a CH. Or it could be aromatase deficiency, in which we have to measure the estrogen levels. Or it could be maternal androgen exposure, which would be apparent from the history. If it is a 46XY, then it is a complete gonadal dysgenesis. If there is no identifiable testis and uterus is absent, and it is a 46XY, then it is testicular regression. And if it is 46XX, then it is MRKH syndrome. So this is a very straightforward algorithm that we can follow. Now coming to the management, there's a major paradigm shift in the last 5 to 10 years based on, so now we have very good genetic testing. So we have precision genetic diagnosis. And mostly we try to have a multidisciplinary care because these children require multiple specialities. The decision is always a little bit individualized based on shared decision making with the family and the healthcare team. Surgical timings are also individualized in each case. There's a greater emphasis on preservation of fertility if possible. Psychosocial support and transition of care are also very important. So again, this review article, so multiple genes are getting identified. So I won't go into the details of each thing, but as and when we're doing more genetic testing, more genes are being seen. So nowadays, it's not just the SRY gene, which leads to the male development. We can see other genes are also involved, like SOX9, and which is very important for the testicular development. So if the SOX9 gene is duplicated in a female, that would lead to testicular development. And many genes like the DHX37, is there a pointer? Okay. Yeah. Thank you. So if you can see here, initially it was said that SRY gene is the one which leads to the testicular development and ultimately AMH and the development of testis. So now, but here we see there are multiple genes here, NR5A1, GATA4, WT1, CBX2. So all these are involved in the gonad development. So if these genes are affected, then it would lead to gonadal dysgenesis. Then we come here, another set of genes are involved, GATA4, ZFPM2, WT1, and NR5A1. So these are all involved in the, there are promoters of the SRY gene. So these all will go into testicular development. And this SOX9 is very important because if SOX9 helps in testicular development, sometimes it gets duplicated. And then a 46XX female can have testicular development. Another gene which is quite getting in DHX37, which is being more and more identified, this helps in testicular development. So if this gene is mutated, they would have testicular regression, or they would have, sometimes even they could have testicular regression, and sometimes they could even have gonadal dysgenesis. So there's a lot of variable presentation in this. And now multiple genes are identified in the ovarian development as well. Like initially it was thought that ovarian development was passive, but now we know multiple genes like WNT4, RSPO1, FOXL2, these are all required for ovarian development. So if they are not present, then they may go into the testicular development, or they could lead to gonadal dysgenesis. So now genetic testing has become quite paramount, but it's important that we just don't rely on genetic testing, because many patients would not come out to have any genetic mutation. So always establish the genetic etiology, and it helps to establish the genetic etiology and sex assignment. It helps to explain the prognosis in terms of future puberty, fertility, and tumor risk, and plan genetic counseling for subsequent pregnancies. But still, it should only be planned after proper phenotypic characterization by clinical and laboratory data is done. And always involve a geneticist as well. So what is the choice of test? So basically, there are various tests available. Normally, if it is a 46XY DST, then we go in for there's an overlapping phenotype. Then we go in for next generation sequencing, or a gene panel in which the genes for XY DST are there. If it is a 46XX DST, as we know in CAH, congenital adrenal hyperplasia, we don't always have to do genetic testing for the diagnosis, but sometimes it may be required for counseling, or where there's a doubt in the diagnosis, and there we do the MLPA, multiple ligand probe amplification, because this is associated with gene deletions. So that is the ideal way, followed by Sanger sequencing, where we know that a single gene is involved, like androgen receptor, like complete androgen insensitivity, we would go for Sanger sequencing. In the presence of dysmorphism or a suspected syndromic etiology, we would go for comparative genomic hybridization, CGH, which would show the copy number variants. So that would be the first test to be done. So now this is just to share our data regarding Indian data for 46XY DSD, in which we have evaluated 147 children with 46XY DSD, and the provisional diagnosis was 5-alpha reductase in 83, that is 56%, or androgen insensitivity, that is defects in androgen action, gonadal dysgenesis in 21%, and testosterone biosynthetic defects in 7.5%, and others 15%, which could not be classified. Then we did sequential genetic testing for SRD5A2 gene and AR gene. And it was found that 44 subjects, that is almost 44 out of 147 had either 5-alpha reductase or androgen insensitivity. Then the remaining children underwent an NGS panel of 155 genes. And ultimately, 68 out of 147, that is 46%, could achieve a molecular diagnosis, but still the remaining half did not have a molecular diagnosis. Similarly, this is a study from Brazil, published recently. So this is showing contribution of clinical and genetic approaches for 209 cases of 46XY DSD. So what they did was, they did not do a gene panel, but they have done exome sequencing. They have done massive parallel sequencing, in which all the genes have been checked in 209 non-syndromic 46XY DSD. And what they found was that gonadal dysgenesis was present in 36%. So they had three subgroups, that is gonadal dysgenesis, disorders of androgen secretion, and DSD of unknown etiology. So when they went ahead with genetic testing, they found that among the patients with disorders of hormone secretion or action, 96.5% could be diagnosed by genetic testing. In gonadal dysgenesis, only 36% could be diagnosed. and DST of unknown etiology, 31% could be diagnosed. So overall, they achieved 59.63% could be classified. And DHX37 was the most important gene in gonadal dysgenesis, and NR5A1 was the most important gene in unknown etiology. So these emerged as important genes. So basically, we could classify up to 60% with NGS, with whole exome sequencing. And now we have done a further study in which those children who had gonadal dysgenesis, because you can see a lot of patients, there's no genetic etiology. We did CMA, we did a CMA in all these patients, and another 10% could be classified. So many patients with gonadal genesis have large deletions which can be identified on further testing. So coming to the approach to genetic testing, if you have a patient with DST, 46XX, suspected steroidogenic effect, you go for Sanger sequencing or MLPA for the gene deletion. If you have others, then you go for targeted sequencing by NGS in aromatase deficiency. If you have over-testicular or testicular DST, you go for FISH for SRY duplication. If that is not there, then you go for whole exome sequencing, and then you go for CMA. If it is a 46XY, you're suspecting androgen biosynthetic defect, you go for targeted NGS. If you're suspecting gonadal dysgenesis, non-syndromic, again, you go for WES. And if it is not there, then CMA. In syndromic, if the candidate genes are known, you can do the genetic testing. And not known, then you go for a CMA. Now, coming to parental counseling. So parents may suffer from psychological distress, shock, anxiety, and depression. And this is compounded by the stigma and social taboos. So appropriate counseling and anticipatory guidance are very important. And pediatricians must communicate with sensitivity and first address the condition of the health of the baby, and then talk about the genital ambiguity. If it hinders gender assignment, then parents should be counseled that certain tests will be done, and to clarify the diagnosis, and ultimately referral to MDT team will be done. So coming to gender assignment, it is based on the underlying diagnosis, future gender identity, appearance of genitalia, future sexual function, fertility, feasibility for surgical correction, and socio-cultural factors. So though, you can say that it's a third gender, but there are not many studies on the long-term outcome of assigning a third gender. So ideally, we should assign a gender to the baby. And though in Western countries as well, where third gender could be assigned, there are still no long-term studies on the psychological effects of this. So in India, we still prefer to assign a gender. And based on this, 46XX should be read as girls, 46XY CAIS, complete androgen insensitivity and complete gonadal dysgenesis, also would have female body habitus and gender identity, so they should be read as females. Majority of 46XY with 5-alpha reductase and 17-beta HST would also have male gender identity. So most would be read as males, but individual decisions have to be taken based on the shared decision making and MDT team inputs. So all these things have to be guided by the multidisciplinary team. Now coming to the multidisciplinary team, it is consisting of pediatric endocrinologist, surgical team, psychiatrist, psychological specialists, and geneticist, and gynecologist, urologist were required. And the role of psychologist is paramount in identifying mental health issues in parents and providing coping strategies throughout the life cycle. That is, as the child grows, at each stage, they would require support. Now, just coming to gonadal risk, the presence of a Y cell line and intra-abdominal location of testis increase the risk of malignancy. So it is highest in patients who have Frazier syndrome and Denny-Drash, complete gonadal dysgenesis. 30 to 60% would develop a gonadal tumor. So in these patients, gonadectomy has to be done upfront. In mixed gonadal dysgenesis, 15 to 40% would have a malignancy risk if they are intra-abdominal gonads, and 15% of CIS. In CIS, the risk is very low. So coming to surgery, again, we have to have individualized timing. Surgical options include diagnostic laparoscopy, gonadal biopsy, corrective surgeries for genitalia like hypospadias repair, orchidopexy, clitoroplasty, vaginoplasty, and gonadectomy. So the main thing is that we should defer irreversible cosmetic genital surgery where there is no urgent medical indication. and perform urgent surgery if there is a urinary tract obstruction, severe urogenital sinus complication, or gonadal torsion, and use shared decision making for elective procedures, and involve older children wherever possible. Irreversible surgery like gonadectomy is prohibited unless there is a cancer risk. And orchidopexy in case of male gender assignment should be done at the age of first 1 year and to preserve the testicular function. Hypospadias repair and correction of cordia are also best done in childhood. So basically the neurodevelopments are that MPS and whole genome sequencing will be able to identify structural and non-coding missing variants as well. Transcriptome and epigenetic analysis are emerging. Artificial intelligence associated genomic interpretation will also emerge. And various apps are available, like Dr. Anurag's team has developed the DSD interpreter app, in which it is shown that the discordance in the final diagnosis would be decreased if we use these DSD apps and DSD interpreter. Then there are various development of patient decision aids, how to support the family in making a decision regarding complex decision regarding the gender assignment or the surgery. And local DST teams will be are coming up tailored to the social, cultural and economic settings, especially in our developing country settings. We should have our own local DST guidelines and expansion of international DST registries to know the long-term outcome. So the key messages are that DST offers a diagnostic and therapeutic challenge. Now we are shifting to evaluation of genital score, external genital score, stepwise approach to clinical and hormonal evaluation. Genetic etiology can be established in 30 to 50% of XY DSD. Appropriate counseling and psychological support of the family is required. Multidisciplinary team approach is ideal. Psychosocial care and support are important. All irreversible surgeries are prohibited unless there is a tumor risk. And individualized surgical timing should be there. And there is an urgent need for guidelines and decision-making tools. Thank you.
Thank you, Dr. Rajni ma'am, about this exhaustive slide presentation and getting us through the complete management of a DSD case. So in our DM days also, it was a very fertile area for discussion. So it remains so, but clinical acumen is always important, as you previously indicated in your case scenario. But in this era of evidence-based medicine, we have to take aid of the genetic tests as well. Thank you.
Thank you.
Thanks a lot, ma'am. In our residency, we used to joke that in DST cases, better send a South Indian nurse who would go out and say ki, if someone asks ladka hua hai ki ladki hua hai, she would just say baby hua hai. So baby is a safe term to use here. Next up is recent advances in Turner syndrome by Dr. Radhi Patel. I request kindly comment. Thank you.
We are running late by half an hour, so please stick to time.
Okay, so we'll talk about the Turner syndrome in 2026. What are the recent advances? So first, what is Turner syndrome? So it is the constellation of clinical features in phenotypic female due to the complete or partial absence or structural abnormality of the second X chromosome. Prevalence is 1:2000 to 3000 female live birth. So we are talking about the prevalence at birth. Still we are missing who are diagnosed later and who are diagnosed prenatally, because now studies have shown that 42% of TS, Turner syndrome, are diagnosed prenatally because of the high risk inclusion of the non-invasive prenatal testing. So what are the objectives of the today's talk? So this is recently published clinical practice guideline for the care of girls and women with Turner syndrome and published in European Journal of Endocrinology 2024. So we'll discuss what are the recommendations from this guidelines, and 6 areas are discussed: genetics and diagnostics, management strategies, cardiovascular care, fertility preservation, health surveillance, and neurocognition and mental health. So first we'll talk about the genetics and diagnostics. So genetics, if there is defect in the, if there is non-disjunction error at the level of meiosis, then monosomy Turner will occur, and that is the most common karyotype found in the Turner syndrome. And if there is no non-disjunction or structural abnormality at the post-meiotic or post development of the gametes, then development of the mosaic or structural abnormality of the second X chromosome that are also very common, 50 to 60% of the cases of Turner syndrome. So what are the commonly found karyotype? Monosomy X, most common, 40 to 50% cases, but mosaicism with Y cell line and XX, 46XX are also common, 15 to 25 percentage. Other structural abnormality like isochromosome or isodicentric chromosome and mosaicism with the triple X cell line, they account for 3 to 15% of the cases. Others are the rare like the ring chromosome or deletion of the short arm of the chromosome number 11 or autosomes. What are the karyotypes that not included in the Turner syndrome? This is also important to understand because they do not follow the routine recommendation for health surveillance or comorbidity screening or the management guideline that is recommended by this Turner guideline. So distal deletion of the chromosome number, distal deletion of the 22.3 gene on the distal arm of the chromosome number X, that is just associated with the SOX haploinsufficiency and short stature, not other features of Turner syndrome. Deletion of the of the 24 gene on the long arm of the chromosome number X, that is associated with just premature ovarian insufficiency, and isolated isodicentric chromosome are not associated with the Turner syndrome phenotype. So this do not follow the guideline recommendation of the routine comorbidity screen. So who all are tested for Turner syndrome? So any of the following feature like fetal cystic hygroma or severe hydrops on USG finding, unexplained short stature, unexplained delayed puberty or failure to progress of puberty or secondary amenorrhea, and left-sided outflow CHD defects like coarctation, aortic stenosis, mitral valve abnormality or hypoplastic left heart syndrome, but isolated bicuspid aortic valve do not need straight away diagnosis further or straight away testing for the Turner syndrome. Unexplained infertility and characteristic facial features that meets the dysmorphic criteria of the Turner syndrome, they should be tested. And any two of the following minor features like isolated renal anomaly, mad lung deformity, or neuropsychiatric problem, multiple typical melanocytic nevi, coarctation, cardiac anomaly, excluding the coarctation, just isolated bicuspid aortic valve and other non-specific findings like partial anomalous pulmonary venous return and ostium secondum type of ASD or VSD with any of this feature require the Turner syndrome testing. Which test to do? So karyotype with the 30 metaphase is the first line test and only confirmatory test for the diagnosis of Turner syndrome, and this is the gold standard. But where the rapid result is required, like in the prenatal period or in the neonatal patient with the findings of the Turner syndrome, you can offer rapid test like microarray, FISH or PCR, but definitely the result should be confirmed with the karyotype. And for antenatal testing, if the do offer antenatal testing, if there are suspicious USG finding like increased nuchal translucency or abnormal ductus venosus flow, low PAPP-A level on triple marker or quadruple marker testing, or high risk non-invasive prenatal testing. And this finding must be confirmed with the amniocentesis or chorionic villus sampling or the postnatal karyotype for the confirmation of the Turner syndrome. So this was all about genetics and diagnosis of Turner syndrome. Second is the management strategy. So short stature is one of the most common presentation of the Turner syndrome. Why it happens? Because of lack of the SOX on the pseudoautosomal region of the X chromosome, and it starts in utero. So a growth failure starts in utero. Many of these babies born IUGR, and downward growth continuous more at more rapid speed in the first 2 years of the life. Height deficit is established by 3 years of the age, suboptimal growth throughout the childhood and absent pubertal growth spurt. So average adult height in Turner syndrome girls is like 138 to 147 centimeter depending upon the population. Growth hormone treatment is FDA approved for the Turner syndrome, but when to start as early as 2 years of the age if the growth failure or declining growth found on Turner specific growth chart or even normal population growth chart also. And it should be continued till 14 years of the bone age or the growth velocity is less than 2 centimeter per year. Higher dose is required. Initiate with the 45 to 50 microgram per kilogram per day, and maximum dose is 68 microgram per kilogram per day. What are the adverse risk of the more adverse effect in Turner syndrome? So higher risk of the BIH, benign intracranial hypertension, SCFP, SCFP, that is suboccipital femoral epiphysis, and scoliosis or lymphedema. Monitor for the, so this is the prescription insert in USA for growth hormone, especially for Turner syndrome girl, for monitor for the progression and potential malignant changes of NEMI. So this is not direct, though there is no direct correlation was found between the Turner syndrome treated with the growth hormone and malignant changes of the NEMI, but they have mentioned this in their package insert. Height velocity, monitor the height velocity on the population specific or the Turner syndrome growth chart for the efficacy of the growth hormone, and monitor IGF-1 annually and keep it in the normal range. They do not recommend, guideline do not recommend concomitant use of the oxandrolone because there is no potential benefit, rather risks are high. Ultra low dose estrogen in prepubertal years are not recommended because this is not adding any height benefit. And trials of long acting growth hormone are still underway. Only one study where they have did 2-year retrospective data, and results are promising but yet not recommended long acting growth hormone. So we should offer just daily growth hormone. Delayed puberty is second most common presentation in Turner syndrome, and causes are absence of BMP15 on short arm and FMR1 on long arm of the chromosome number X. Presentation can be delayed or stalled or absent puberty. 15 to 30% have spontaneous pubertal development. Out of this, 5% have spontaneous menarche, and out of this, 10% have spontaneous pregnancy. So LH and FSH shows biphasic pattern in Turner syndrome. So they rise immediately after birth, then come to normal level during childhood period to the girl, though they have normal ovarian function, and then begin to rise in the prepubertal years. So start monitoring LH, FSH and AMH by 8 to 9 years of the age. There is no role of doing LH, FSH in the childhood years because they may be normal also. FSH more than 6.7 and AMH less than 4 suggests the higher rate of ovarian insufficiency, and this finding is important for the fertility aspects, and pelvic ultrasound do not predict the spontaneous puberty. So there is no role of doing USG. Hormone replacement, especially estrogen replacement for the pubertal induction, when we should start at 11 to 12 years of the age if FSH is elevated on 2 separate occasions, suggesting there is no scope of the spontaneous development of the puberty. And if there is delayed diagnosis more than 12 years of the age and epiphyses are open, you can offer them combined GH plus low dose growth hormone, which provides some height benefit. Which preparation is preferred? So 17 beta estradiol, which is more physiological and preferred option because it will give the more physiological pubertal progression as well as little effect on the cardiovascular risk and the bone health. Estradiol valrate is the second option because it is rapidly converted to the 17 beta estradiol in the gut and liver and provide the stable concentration of E2 in the blood. But synthetic estrogens like ethinyl estradiol and combined estrogens should be avoided because of higher risk of the thromboembolism and cardiovascular and metabolic side effects. Which route is preferred? Obviously, transdermal is more preferred and physiological than oral. And if start with the low dose and then escalate the dose towards the 2 to 4 years, which mimic the normal physiological progression as well as provide the potential height benefit. So this is the recommended doses of the 17 beta estradiol by the guidelines. If you are using the transdermal estrogen, then start with the 1/4. So 6.25 microgram patch, and if you are using oral estradiol preparation, then 0.025 milligram per day, then gradually increase the dose at least 30 to 50% every 6 months to reach the final dose of 50 to 200 microgram per day of the transdermal preparation and 2 to 4 milligram per day of the oral preparation. And what are the endpoints, or what are the goal to achieve the serum estradiol level of the 150 to 450 picomole per liter, and endometrial size of the 50 centimeters. So pelvic ultrasound is important while monitoring somebody on estrogen treatment, but not for initiating the treatment. Progesterone replacement should be started if there is spontaneous bleed on estrogen replacement, or once you reach the endometrial thickness of 4 to 8 millimeter, when if the treatment duration is more than 10 years, 2 years of the estrogen replacement. Preferred preparation is micronized progesterone or dydrogesterone. These are the more physiological progesterone available. Medroxyprogesterone acetate is alternative if the physiological preparations are not available or costly for the patient. Synthetic progesterone like norethindrone should be avoided due to the high effect on the androgen receptor and glucocorticoid receptor, so higher risk of the toxicity. Which route to preferred? Oral, obviously. And if you are using the combined sequential regimen, estrogen followed by progesterone, then add the dose of 200 microgram 12 days each month. And if you are using the continuous regimen, then half dose with the regular estrogen preparation. Combined sequential regimen for medroxyprogesterone acetate dose is 5 to 10 milligram 12 days each month, and for continuous regimen 2.5 to 5 milligram daily. The guidelines have also recommended intrauterine device with levonorgestrel for endometrial protection and also for contraception that lasts for 5 years. This is also the good option for the adolescent or nearly adult patient. How to monitor the patient who are on HRT, hormone replacement therapy? So clinical monitoring is the must. Look for the pubertal stage, height SDS, vaginal bleeding, and quality of life and neurocognition. Laboratory monitoring, they have recommended to do estrogen level annually. And if you are using transdermal route, then 2 days after applying the patch. Goal is to achieve the estradiol concentration of 100 to 150 picogram per ml. After that, you should add progesterone, and radiological monitoring, especially for the bone density. DEXA BMD should be done once the adult height is achieved or at approximately age of the 18 years. USG pelvis, when you choose to add progesterone, then it should be done. Third important important criteria in the Turner syndrome is cardiovascular care. So more than half of the Turner individual have the cardiovascular abnormality, either congenital or acquired, and they carry the lifelong risk of acquiring the cardiovascular disease, and this is the important cause of the mortality in the Turner syndrome. So this is the recommended flow chart for the cardiovascular monitoring by the guideline. First, monitoring, if somebody is diagnosed in the antenatal period, then fetal echo should be done and cardiology consultation based on the echo finding. If not done in the fetal period, then first echo should be done in neonatal period before discharge to rule out the congenital heart disease, especially left-sided outflow tract obstruction abnormality. If this then age again at the age of 4 to 6 year, ECG and BP should be done. They have not mentioned echo, but if first echo is normal, then there is no need to repeat the echo here. But if the echo is not done, then you can repeat at the 4 to 6 years of the age. Then again at 9 to 11 year of the age, echo, ECG, BP should be done, and further testing based on there are findings of aortic dilatation or not, and that will discuss in the next slide. So aortic dilatation and dissection TS girls have 25 times high risk of aortic dilatation and dissection as compared to general population. 70% have type A involving just ascending aorta, and mean age of aortic dissection is 30 to 35 years. So surveillance for aortic dilatation and dissection based on the risk as well as age. If somebody is less than 15 year of the age and there are no cardiac anomaly and TA specific Z score for the aortic dimension. If less than 30, then this is considered low risk and monitoring frequency of monitoring should be 3 to 5 years. If TA specific Z score is more than or equal to 3, then this comes into the moderate risk category without any congenital heart disease. Then monitoring should be annually or every 2 years. And somebody who has an underlying cardiac congenital heart disease and TA specific Z score is more than 3, considered high risk category and require every 6 months to 1 year monitoring for aortic dissection. And if the age is more than 15 years and with cardiac underlying congenital heart disease, then risk for aortic dissection is determined by the aortic height index as well as aortic size index. And if it is more than 2.3 or aortic height index more than 23, comes into the high risk category, requires 6 months to 1 year for category, 1 year monitoring, and early or preventive surgery depending upon the risk. Hypertension in Turner syndrome girl, again very high risk, 3 to 4 times more prevalent in Turner girl and more common with somebody who has dysmorphism, coarctation, renal anomaly. Even idiopathic hypertension is also more common in the Turner girl. So screen for hypertension is recommended by guidelines annually. And diagnosis of hypertension based like general population, if adults who has systolic blood pressure more than 130 and diastolic blood pressure more than 80 and children more than 95% of the normative value. Assess for the secondary causes of the hypertension like coarctation, kidney malformation, thyroid disease, obstructive uropathy or sleep disordered breathing, and promote the lifestyle changes at the early age like weight loss, diet and exercise modification. If there is no aortic disease, then treat them according to hypertension guidelines, adding the ARB or ACE inhibitors plus or minus thiazide or calcium channel blocker. If aortic disease is present, the criteria we have discussed in the previous slide, then treat them at the as per the aortic disease guideline management at the beta blocker plus or minus ARBS, that is the angiotensin receptor blockers. Other cardiovascular diseases like lipid profile should be done first at 9 to 11 years and then at transition to adult care and then every 3 years. ECG at diagnosis and follow based on the cardiologist's need. Coronary artery disease surveillance, diagnosis and management as per the normal or general population guideline, no specific recommendation, and no routine screening for the clotting disorders. Fourth area of the care is the fertility preservation, and that should be offered to each and every patient with Turner syndrome. Even parents should be counseled at the time of diagnosis about what are the potential for, there is high risk of potential for the infertility, what are the options available for family building, maternal health risk during the pregnancy, and what are the fetal health risk if you continue or carry the pregnancy. What are the high risk of fertility preservation or the factors which favor the fertility? Mosaic karyotype with 46 XX cell line, spontaneous puberty or spontaneous menarche, measurable AMH level or FSH level less than 10. That favors the fertility outcome is good in this patient. And there should be offered oocyte cryopreservation with ovarian hyperstimulation. So though the procedure is very cumbersome, and that should be offered to post-menarchal girl with appropriate psychological maturity after the proper consent from parents as well as patient, and only in centers with sufficient expertise. With this procedure, only one reported case of live birth is reported till now. This is very emerging modality, ovarian tissue cryopreservation with primordial follicle. This should be offered in prepubertal girl with mosaic karyotype. This is commonly done in girls who are undergoing cancer, chemotherapy or radiation, but still it is in experimental phase. No proper recommendations are yet available. Non-autologous gametes like oocyte or embryo donation and gestational carrier are alternative for fertility options. Fifth is the health surveillance, and that should be done throughout the life, starting from newborn to infant phase, then childhood, then adolescent and adult care, because they carry the lifelong risk of the certain comorbidities and so many health disorders. So comprehensive physical examination neonatal period, especially for hip stability and lymphedema, Monitor pre-fit sugar because they have higher risk of development of the hypoglycemia because of the other risk factor like SGA, prematurity, IUGR. Plus, they have one of the association is found between congenital hyperinsulinism and Turner syndrome because of one gene. I exactly don't remember the name of the gene because that presence of this gene increases higher risk of the hyperinsulinism. So the need monitoring for the sugar in initial 48 hours of life. Karyotype with 30 metaphase should be done in neonatal period to confirm the diagnosis if there are prenatal evidences or the postnatal findings. Echocardiography and renal ultrasound should be done before the discharge and monitor weight, length gain and plot on the Turner specific growth chart from the neonatal age only. Assess development every 3 months and then throughout the life period, what are the physical examination we should do? Weight, height and BMI every 6 monthly and annually in each and every visit in each and every girls till the early adolescent period. BP monitoring done in every girl annually. Cardiovascular care 2D echo once at diagnosis, once in adolescent period, and then in adulthood every 5 to 10 years. Ophthal evaluation once at diagnosis and further on if indicated based on symptom. Otoscopic examination in prepubertal till prepubertal age annually and after that if clinically indicated. Dental examination should be done throughout the life every 6 to 12 months. Scoliosis examination should be done annually till the completion of the linear growth. Breast examination for pubertal staging in the prepubertal and adolescent girl, and after that for the risk for breast cancer that depends on the as per the local guidelines. So there are no specific recommendation for Turner syndrome. Laboratory monitoring, AMH, FSH and LH monitoring should be started from 9 to 18 years until we are doing the hormone replacement therapy. Estrogen level should be monitored along with HRT, hormone replacement therapy, to assess dose of HRT, and in adulthood every 5 years to evaluate the efficacy of HRT. TSH should be done every 1 to 2 years or earlier if there are suspicious clinical symptoms. Celiac screening should be done every 2 to 5 years or there are suspicious clinical symptoms. Liver enzyme should be monitored once at diagnosis and then in childhood, adolescent and adulthood period every 1 to 2 years. HbA1c monitoring should be done once at diagnosis and after adolescent phase every 1 to 2 years. Lipid profile in pre-adolescent till pre-adolescent phase or adolescent phase as per the local recommendation, and in adulthood every 3 years. And vitamin D level done once in childhood or adolescent phase and in early adulthood every 2 to 3 years. Urine analysis only if clinically indicated or there are abnormality on the renal ultrasound. Radiological monitoring include the USG KUB once at diagnosis and repeat if there is hypertension or recurrent UTI. ECG once at diagnosis and in adulthood every 5 years. 2D echo again at diagnosis, once in prepubertal year, once in early adulthood, and then an adult every 5 to 10 years. Cardiac MRI once after the completion of the growth and before the planned pregnancy. Tympanometry annually till 5 years of the age and in adolescent phase if clinically indicated. USG pelvis only with HRT to assess the dose of HRT and when to add progesterone, and in adulthood if clinically indicated. DEXA hip, DEXA scan for the bone health once in adulthood and then in adult every 5 years. And neurocognition and mental health, this is also one of the important parameter to look in the Turner syndrome girls, because 90% of Turner syndrome have average intellectual ability, but some of them suffer the discrepancy in verbal reasoning and visual spatial reasoning. Ring chromosomes have high risk of cognitive impairment. So there is some phenotype genotype correlation, and it is very well understood genetic link between abnormal X chromosome number and neurobehavioral problems. And it is recommended that cognitive neuropsychological evaluation and social emotional behavioral screen should be incorporated across the lifespan based on the karyotype. So those who have those who have complex karyotype refer to the neuropsychiatric evaluation straight away, and those who have mosaic or the monosomy, that depends upon what are the associated risk factors present. Transition to adult care should be done appropriately, and this is the toolkit provided by the European Society of Pediatric Endocrinology in 2016, which gives assessment for the patient readiness, knowledge and skill, recommendation for adult care provider, and summary for screening recommendation. And patients should be counseled about the potential for lifelong complications of Turner syndrome, especially cardiovascular parameters and hearing loss. Reproductive issues should be discussed once you are transitioning to the adult care. Educational consulting, vocational training, and support continued in adult life if learning difficulty is present, and encouraged to engage with Turner syndrome emotional and psychosocial support group in adulthood care also. So summary of the today's talk is early diagnosis is key. So once you have suspected feature, do the karyotype, and karyotype is the only confirmatory diagnostic test. Start GH as early as possible, at least by 2 years of the age, to achieve the optimal adult height. HRT regimen should mimic the physiological tempo of the puberty. So start with the low dose estrogen and gradually increase the estrogen to achieve the adult features of the puberty, and then add progesterone for the withdrawal bleeding and endometrial protection. Cardiac surveillance and timely management across the lifespan is required for the Turner syndrome girls, and fertility options and outcome must be discussed timely so they can have option of what are the options available for their family building. Thank you.
Thanks, Dr. Riddhi, for nice presentation. It's really, we have to see that early diagnosis, early treatment, and the later, that is for fertility issue. There are so many issues which we have to take care of, and this is really important. And you have just all the domains what a Turner syndrome and the family will need, including mental health, is really important. So house is open for any question, please.
So recent guidelines, they have discussed the maximum doses for
Because many a times we get turners who we keep giving estrogen, but there's no bleeding and it causes a lot of distress. So are we justified in going further? Is something which the guidelines say 4 milligram, but the long-term health and everything we don't know. But lack of menarche is a huge social distress. So can we just inch up beyond that? Is something which. And then come back. So estradiol valerate, you go up to 3 milligrams.
So basically, sometimes what happens is that they are taking already 2 years, 3 years, and they are not responding. So then you go up the dose. Once the menarche happen, you comes down. And they've also talked about the estrogen level monitoring. So I think that is also a good way to look at, as to you're not going too high from that perspective.
Also, sir, in transgender medicine, when we give estrogen at higher doses to transgender men to females, so we are giving for very long term also, and the side effects theoretical that we read about VT and all things, they are not really that high in occurrence prevalence. So it is relatively a safer thing.
Thank you, ma'am. Thank you, ma'am. That was a very insightful talk. Artificial intelligence, telemedicine, wearable technologies, and digital platforms are rapidly progressing. Let us explore how these innovations are shaping pediatric endocrinology from none other than Dr. Nurag sir.
Thanks a lot, Riya. And we know that technology is something which is changing our lives. We are seeing every part of our life, be it booking a ticket, be it watching our any movies or going on anything. Intelligence and artificial intelligence is deciding about that. So are we there for pediatric endocrinology in that regards? If you look at technology in pediatric endocrinology, we have now pumps which provide physiological delivery as close to possible. We had a big session on AID last time. Novel therapeutics, long-acting growth hormone, long insulin, they are all derived from these technology. We have been discussing about them. Precision medicine, and Manoj really talked about precision medicine, and a lot of things we are reaching that. And also getting accurate diagnosis based upon biomarkers. So this is what is happening. But in reality, we still have scenarios where the basic medicine is not being changed. So while for a small section, we are seeing huge changes, but sometimes things are not improving at the grassroots level. So this was a 12-year-old girl, height is 120 and weight in 15. So the question is, how do we evaluate? So we conducted this study to see how the pediatricians, the pediatric trainee, the pediatric endocrinologist, and the endocrine trainee respond in terms of gold standard responses. So what you can see that for short stature in 300 cases, there were huge variations that we were able to find in that perspective. And we found there was significant missing of pathology on one hand, and on the other hand, there was overdiagnosing. So it was on one side, investigations were not being done, and on the other hand, investigations were being done too much. So I think this is something which is not really appropriate, resulting in misclassification. So what we are seeing, despite all these technological evaluation, is that the diagnosis is missing. 15% of children who are coming to us with short stature are actually short adults by the time the bones are already fused. We have protocol deviations and complicated conditions like DKA, which contribute to mortality and morbidity. Primary care errors result in significant amount of cost, which is not required in that perspective. And of course, referral is delayed. And this is reflected by a 4-year lag in terms of growth hormone treatment in Indian setting. So despite all the changes that have happened, still we are lagging behind. So there is a India versus Bharat, and the same story is going on from that perspective. And we thought that technology can really help out as a solution in that perspective. Why pediatric endocrinology is suited for technological interventions? Clearly, we have mostly algorithmic evaluation. Investigations are usually robust and clear. There is a definite potential for intervention. Once you diagnose, you can treat, and there is objective management. So we thought that we can use a clinical decision support system which can help make evidence-based guidelines translate into clinical practice. So we went on and developed a number of pathways. First, we started off with our approach pathways, which were just the algorithms, which were converted into a flow chart, sort of a question answer, which the clinician has to use for diagnosis and management. We subsequently developed tools for assessment of bone age, and Hemchand talk about this tool basically, which we validated, in which only 5 sites have to be compared, and you can get a precise, quick evaluation of bone age. We then went on to develop interpreters. So we found that people don't want to spend so much time answering questions through the algorithm. So in interpreters, you just have to put some data and you will get interpretation based upon that, making it easy in clinical practice. This was our first study. This was published with Riddhi. This is in Journal of Pediatric Endocrinology and Metabolism. This is our own approach for growth failure based upon growth interpreter. So after entry of basic findings, it tells us whether what is the exact objective evaluation, what is the likely diagnosis, how do we evaluate and manage it. And what we found that there was over 98% concordance with gold standard diagnosis. So we were encouraged that we have a tool, and people used to say you have to basically draw the chart, assess, interpret, and so many errors were happening. This tool was able to provide us with a very high level of concordance in that regard. So we subsequently have went on to develop a number of tools. Around 8 of them have already been validated. So this was our obesity interpreter, in which this was with Dr. Arpita's group. We had validated this. And what we found that obesity interpreter had a very high level of accuracy compared to the gold standard and had the potential to improve outcome in terms of assessment by pediatricians and pediatric training. So this has recently been published in Indian Pediatrics. And obesity interpreter clearly showed a 98.6% reduction, potential reduction in diagnostic errors. Now, we want to do multicentric studies to get more data onto it, but the preliminary evidence is clearly there and it's published from that regards. A big problem which often we face is in terms of diabetes management and classification. So this was a 16-year-old boy with polyuria. There is clearly diabetes, had DKA, and after some time the requirement was less. And the treating physician thought that this child is obese and this looks more likely to be type 2 diabetes rather than type 1 diabetes. So what they did was that they stopped insulin and the child developed DKA. So clearly this is more likely to be a obese type 1 rather than type 2. And as we discussed yesterday in my talk, we should have had the GAD antibody which should have been done to get the right diagnosis. So this is a situation where we can potentially prevent these life-threatening complications. So we developed this algorithm which is largely derived from ISPAD guidelines and based upon the age, presentation, insulin requirement, and BMI. So essentially, less than 1 year, a consideration is given for neonatal diabetes. Beyond 10 years, a consideration is given for type 2 diabetes, but you have to do autoimmunity before you diagnose type 2 diabetes. And between 1 to 10 years, the default is type 1 with the exception of very low insulin requirement. So diabetes interpreter, you all have to tell the age, the BMI, the insulin requirement, and it gives the recommendation and the likely diagnosis. So what we really found was that there were a lot of errors which were happening not only at the level of trainees, but also at the level of pediatric endocrinologist and adult endocrinologist. And this was like interesting and expected. So while adult endocrinologists were correct in diagnosing type 2 diabetes, they were not recommending GAD antibody in that scenario. This is expected because most of their adult cases, they do not recommend GAD antibodies. While pediatric endocrinologists were picking up MODY and type 1 very well, they were making errors or they were not thinking of type 2 diabetes in an appropriate scenario. So I think this was something which we found. And when we were able to use this tool, we were able to reduce these discordances. Now, we had a full talk on DSD by Dr. Rajni, and she talked elaborately with regards to the approach. We have also developed a DSD interpreter, and you can see this looks a very, very complicated algorithm. So we do classes, we have done workshops on DSD, and the next day people say we forget everything. We cannot implement them in that perspective. So what to do again? Technology can come to our help, and we developed a DSD interpreter, which is interesting in that it is basically looking out in terms of clinical findings first, whether there is gonad or not, whether there is Mullerian structure or not. Based upon that, the investigations come up and then you decide which one is that and will make the diagnosis. So this child who has XY DSD with gonads and no uterus, who has got hyponatremia and hyperkalemia, you get the diagnosis of 3 beta HSD out there. So this is really giving you a diagnosis across all that algorithmic arms that I talked about in that perspective. And what we found was that there was significant improvement in terms of concordance for both diagnosis and plan, substantially compared to the trainees. So obviously pediatric trainees were doing very, very poorly in that regards. The pediatricians also not that up to the mark, and neonatologists. Now these are the three prime people whom these cases will come. And if you make an error in DSD, that will have a huge implication from that regards. So DSD interpreter clearly showed that this had a very good concordance, and compared to the other groups, particularly the trainees, it had a potential of good outcome from that regards. We have also developed a puberty interpreter, and we talked about a lot of pubertal evaluation. Again, high level of concordance. So these tools clearly tell us that by simple decision support tools. Now, these are algorithmic tools. These are not AI yet. We are not talking about AI yet. In pediatric endocrinology, even with algorithm based, and often the rules may do better compared to AI also. I'll talk about that. So they can provide you with a very good concordance with gold standard from that perspective. So we have interpreters for thyroid, for hypoglycemia, calcium, and electrolyte. These three are covering the entirety of emergencies as far as pediatric endocrinology is concerned, and hopefully we are validating them in the next session. We might have these tools validated as well. So we have talked about diagnosis. Next issue, of course, comes is interpretation. And as I said, one of the big challenges is bone age interpretation. So this was a 13-year-old boy with short stature referred to us with a reported bone age of 14 years. Now he's short, and if the bone age is 14 years, we are really worried. The parents came for growth hormone treatment. But when we did a reassessment of the bone age, we found it was not 14, it was 10.5. And that really changed the everything, and this became CDGP rather than actually requiring growth hormone. Now, this is not uncommon. If you look at radiologists' reports of bone age, they would say sometimes 5 to 18 years. Sometimes they will say no evidence of fracture or rickets. So I told one of my radiologist friend that you should write it as 0 to 100 years, and you will have 100% sensitivity and specificity as far as the overall diagnosis is concerned. So radiologists are either too burdened or they are not equipped to report bone ages. So we pediatricians and pediatric endocrinologists should have a basic idea how to assess that. There are methods, and Dr. Hemchand really presented nicely about those three methods last time, the GP Atlas, the Tanner Whitehouse, and Bone Expert. But then this will take, for a pediatrician, it may take somewhere around 15 minutes. Atlas, again, you are basically compare. The Tanner Whitehouse will take around 15 minutes. The Atlas, sometimes it's not very easy because one bone will be different, other bone will be different. And Bone Expert is costing around 7 to 10 euros per analysis. So all these issues are there in that regards. So we developed and validated a tool in which we selected the various sites based upon regression analysis and found that the 5 sites of Tanner out of 20 were best suited to give you most diagnosis. If you ask me a single site, if you just use middle finger, middle phalanx, it will really be the best. So that is actually going to give you most of the results. But because other sites will add, that's why we have chosen 5 sites from that perspective, and a very good bland Altman distribution was seen. So clearly this was a method which was validated, and now it's being used across the country and other countries as well by a significant number of individuals. Now, problem is that once we have something, we want something better in that perspective. So people don't want to match those 5 sites. Our study shows it takes around 2 minutes roughly to get that for a non-expert also. But people in these day and era, they want like Blinkit immediate delivery. They want an immediate output. So there are tools. Of course, now AI is coming in terms of pattern matching, recognition, and deep learning. Vibha had talked about this. So we had this deep learning tool which we developed with IIT Kanpur, which goes into various methods and immediately in a few seconds will give the bone age. Now we are integrating it into our own platform of Big, and hopefully that will make it much easier. You just take this, you take the photo of the height and weight, and immediately it will give you the whole interpretation. We found that it had an acceptable mean absolute error of around 0.81 year. Up to 1 year is considered to be good enough, and a narrow distribution from that perspective. So here, clinician doesn't have to do anything, just upload the X-ray and you get the result back from that. So hopefully this will come in soon. So till now we had developed tools for growth, puberty, obesity, and bone age. We thought, why not club all of them into one and make it much more easier? So what we have come up now is known as bone age assisted interpretation of growth. This is big, which provides interpretation for growth, puberty, obesity, all those disorders in a click of a button. So all the clinicians have to do is to provide details about date of birth, gender, height, weight, and select the pubertal status, select the bone age. And what you will get immediately, the detailed interpretation, likely diagnosis, and likely treatment. So all the algorithms are done immediately, and you get as a personalized report. The use of big was associated with 96% reduction in discordance. So this is something which we have identified, and we are now going to plan for multicentric studies to identify how much benefit can it do at a district level, at a secondary level, and a tertiary level as well from that perspective. And ultimately, we want to club the AI tool with this so that it becomes even more automated from that regards. So we now talk about diagnosis and interpretation. What about management? And I said management errors are extremely common. So this was a 4-year-old girl with DKA given fluid and insulin with hypokalemia. Now in management, this patient was given normal saline followed by insulin and developed arrhythmia. So we all know that if you have potassium which is low, insulin is going to be lethal in that case. Correct hypokalemia first and then manage, but these errors will happen. And the golden hour of treatment often is done by people who are not experts in that. So you will have the trainees who don't have that much exposure. And if you don't have a structured management, that can cause a problem. So this is our own data from Regency. And what we found is that despite regular training, despite regular teaching, there were significant errors which were happening in terms of the fluid which was prescribed, duration of therapy, insulin. Now, by the time the consultant would change them, damage already is done. So therefore, although there is no increase in mortality per se, but morbidity like hypoglycemia, hypokalemia, duration of stay, all that increases. So what we then went out is to develop based upon largely the ISPAD guidelines. Often these guidelines are not 100% clear, because when you actually have to algorithmize them, you realize that some areas they are ambiguous. So we have to modify those. So this is largely based upon that. It takes into consideration not only the age, but also the pH, the bicarb, the CO2, the risk of cerebral edema, external fluids, and our own study on DKA. And based upon that gives guidance about what should be initial treatment in terms of how much fluid, how long, everything is spelled out. And after every 4 to 8 hours, you can put the data again, and it will tell you how you should manage subsequently. And this was associated with significant improvement in terms of outcomes. So this DKA tool is already there in our app from that perspective. Now, we have been talking mainly about clinical decision support at the level of the physicians, but most cases, particularly type 1, are managed by children, and 95% of problems are encountered by them. So this was a 14-year-old boy with type 1 diabetes, basal bolus, seizures, and hypoglycemia. HbA1c was 10.4. The child was not doing any carb counting. Now, if you look in your own cohort, you will see we may be explaining every time, but practically how many are doing a carb counting, it is not very easy to do also. And it's been shown that this is one of the most effective tools for improving management. So we went on to develop Diabuddy, which is a patient point of care support tool for children with diabetes. Once you provide the data of all their types of insulins and other parameters, it will guide them about what should be their basal dose. It will also help them identify based upon what they are eating. So we have got a comprehensive database of around 10,000 meal items with Prashant ji and has developed on that. And this is incorporated there. You just have to enter the data, and based upon that, it will calculate how much is the carb. Based upon your own calculation, it will give you this much unit is to be given. So this is what Diabuddy is. And we did a multi-level evaluation of Diabuddy. The first scenario was a preclinical study of scenario-based, in which we found that the errors were much lower compared to the families. Then we went out in actually doing a real-world study of 25 children, which showed that there was improvement in terms of HbA1c and increase in delta values of glucose. So this pilot study has already been done, and it is near publication in Hormone Research in Pediatrics. So this is some tool which hopefully will be one which is the first validated tool from India in this regards guidance from that perspective. We are also planning for a multi-center study across 5 centers in the country. So hopefully next year we will have more information about this tool from that perspective. It also guides about sick day management. And this is the tool with Dr. Sandeep was part of it and showed significant improvement in sick day management from that perspective. So till now, we have been talking about diagnosing, interpreting, and managing, but often we might see cases which are complicated, and how do we really decide about management? So like this 6-month-old child with failure to thrive in pigmentation, hepatomegaly, hyponatremia, and hyperkalemia. And you do an X-ray and you find these things. What do you think is the diagnosis? So pigmentation is there, hyponatremia, hyperkalemia. So this is a most likely it's an adrenal insufficiency. You have a large liver and you have got these calcifications, Wolman syndrome. So this is something which will be there. But often when you are in a busy practice, your brain doesn't start work in that point of time and you get confused on that perspective. You can go back to the books We already have come with book today, but I now realize that many people don't read with books anymore because books are becoming voluminous and everything. But yes, they are the first thing. You should have read the book, of course, once. But going back, we have e-resources, which are there. We have learning portals, and there are also large language models. And I think everybody now is using these large language models to get their answers in many of these clinical perspectives. So this was a chatbot based study which showed that there is improvement in terms of responses for that. And we keep on hearing that Claude has done better than so many USMLE people and so many other exams also it has been shown. The problem with large language models which are not dedicated to a specialty is that they use generic knowledge and they may not identify which is better and which is not better. And often if you put the same question to them multiple times, they may give some different answers also. And if you keep probing, they will become ambiguous. So this is a problem. This is because they are not meant to focus on that. They are helping you out. So this is a problem. But if you look at many of the answers which we get from Claude, Gemini or ChatGPT, they will be reasonable. But if you ask how confident you are, they will say a different answer on that. So what we realized that the better way would be to develop a sandbox model in which all the relevant information is there and the model does not search beyond it. So what we have developing or we have developed actually is based upon whatever information we have created, all our algorithms, all our tools, all our books, guidelines which are publicly available, and beyond that it will not search. We will have a mode in which if a clinician wants to have latest knowledge, maybe these things need updation. In that scenario, we can add that if you want search, you can include, otherwise it will not go out of them. Its main role is to read through that, parse through that, and then try to give an answer. Now, for that, all these algorithms and everything are converted into JSONs, which are, so I'm not going to go into too details on that, but all chapters. So suppose I have a chapter on multiple pituitary hormone deficiency, it will convert it into a sort of a complicated code sort of a thing. And then it is there, it is easy for it to identify. So what we have developed is MediSarthi. This is in a experimental stage yet, in which you get answers which are structured as well as a chat. So if you ask a particular question in that scenario, if you say 7-year-old girl is referred for vaginal bleeding, it will go through only the book and information. It will give you a differential, and we have structured that it gives you actual outcome. So this is your assessment. It is most likely McCune-Albright. It will make a diagnosis, and all these things are there. So based upon that, you can put your cases and it can interpret it. Now, this is one way. The other way is that already we have developed a personalized intelligent EMR in which suppose you have precocious puberty, you put only answer those questions, or you pull the form. This will automatically go to MediSarthi and come back as a report. So you don't even need to go through all that. So this is something which we are trying to develop, and we actually have validated it in 100 real life vignettes in which pediatricians and the pediatric endocrine trainees and endocrinologists were used as one arm. Second was MediSarthi versus typical LLMs like Claude, ChatGPT, and Gemini. And what we found that we had a very high level of concordance for basic as well as advanced compared to all other scenarios. Interesting finding is that in most LLMs were better as compared to the average of clinicians. Maybe there were top third percentile of clinicians who are better than even Claude and everything. MediSarthi did better because it was even focused on that perspective. But what's interesting in that regards is that already the large language models are above 95% of clinicians already. So what will happen maybe in a few years is something which is there in that perspective. Similarly, we developed a tool for diabetes. So we put our diabetes algorithms in here. So this is a large language model again, and you put the data and you will get the results. So you put you can act like a parent or a child, and you will get the answer of those questions which are there. If you put the information, you will, so like it says that I've given Lantus in place of Humolog, what to do. So automatically it will think over all that and it will give you an answer like that. So, and it is because it's not a simple algorithm, it will go through edge cases also very well. So this is there, and we'll always talk about the team. So we want to incorporate this as part of diabetes as well. And this also has been validated in terms of the patient response versus these responses, they were found to be quite good. We are now going to validate it in real life cases. So a diabetic educator, the questions they will get, they will give the answer, and then this tool will give the answer, and they will compare by the gold standard. So this is something which we're going to do the validation. Now, the question which comes in is that in this era, would we be replaced by AI soon? And this is a question which is often asked in that perspective. So be ready that there will be a lot of disruptions and a lot of changes which are going to happen, because already these tools are there. But then there are many things in which the human in the loop or the doctor in the loop has to be there, because otherwise there will be a lot of confusion. Who will have the responsibility in terms of care? If Claude makes an error, who will you put a case against? So these things are there. So doctors are going to be there, but clearly we have to be in the loop. It will act in assistance and regulation. To put it simply, AI will not replace doctors, but probably doctors who are using AI better will replace those who are not using AI. So this is, I think, the message. So all of us should learn how to use the tools. All of us should learn how to maybe improve our practices based upon that. Because if you read a guideline and guideline has changed, new guideline has come, you don't read, then you are obviously not going to manage it perfectly. While these tools will have everything in that. So why don't use it properly? When we didn't have a calculator, we were using. But now, how many of you even remember basic mental maths? So I think this is a evolution. Use the tool better in that perspective. So I think that will be the message from that regards. We are working on intelligent EMR, meal sensitive bolus, in which we actually not only go for carb, we also go for protein, fat, and everything in a go of a button. You will get that. Working on school health and as well as comprehensive health. I'll acknowledge the role of my gurus, Professor Menon and Professor George Werther from Australia, the entire group of fellows, 15 of them, 13 of them are present here. I think so that's good. And Prashant ji has been taking a very active role, particularly on the nutritional interventions, and our tech team and IIT collaborations from there. So thank you. Thanks a lot for that.
Thank you, sir, for this amazing talk and for developing all these interpreters. We all know how many errors happen in DK management in the emergency setting and how management of DST can be so confounding. And using these apps can really minimize errors. And this DiaBuddy and MediSarthi are really going to be amazing tools. Thank you so much, sir.
I can feel tachycardia creeping in with so much of inspiration from this talk by respected sir. A big round of applause for sir and the whole team for such an incredible feast, and it's a work of art. Thanks a lot, sir. Next up, may I please call Dr. Anshul Agrawal for talk on hormonal and fertility management of HH in males.
Endocrinologist in Jhansi, and he has been closely involved with our programs. And I think this is the third consecutive year that Dr. Anshul is coming. Thanks a lot for coming, and over to you.
Thank you, sir, for that invite also. And it is always a pleasure to attend this meeting, because now we are also getting to listen to you about the AI and detailed about the digital healthcare, which we are actually lacking and we need to implement on that. So today I have been allotted the topic on hormonal and fertility management in hypogonadotropic hypogonadism. Pointer. And pointer. Upper. Right. Thank you. Right. So if a patient of IHH comes to you, you also have to rule out CDGP, and that is an important marker, and then hypergonadotropic hypogonadism. Now, if you start with patients with you start with a patient child initially in the gestational period, testosterone tends to increase pre-gestation, and as we know in the mini puberty, like 1 to 3 months, the peak of testosterone occurs. Now, this mini puberty is responsible for penile growth as well as Sertoli cell growth, as well as an increase in the total germ cell number. Now, in patient with CHH, you will also see that there is an absent male mini puberty, cryptorchidism, as well as micropenis. In the childhood period, what we see is the LH is not completely invisible, but there is an low amplitude LH secretion during the childhood. And at the puberty, there is an reactivation of a GnRH pulse regenerator, and that lead to increase in the testicular volume and improvement in the secondary sexual characteristic. So if you can see that normal LV pattern is when there is a high amplitude LH, which will result in increase in the testicular volume as well as sperm count. But in IHH, what happens is there is a low amplitude LH, which will either there will be a apulsatile LH, which will lead to testicular volume of just 1 ml. Of course, they will have a azoospermia, but low amplitude LH is also seen where testicular volume will be much higher, like 5 ml, but still they will be azoospermic. So the androgens are not only responsible for penile growth, scrotum, and pubic axillary facial hair, but also responsible for anabolic effects on bone and muscle. So these are the causes for central hypogonadism which we need to rule out, and IHS is not that rare. It is found in 1 in 4. It is rare. It is found in 1 in 48,000 to 1 in 86,000 of the patient. Most of them are Kalman syndrome. 1/3 could be idiopathic hypogonadotropic hypogonadism. So of course you have to look for these congenital abnormalities also in clinically, midline defects, anosmia, renal agenesis, or cryptorchidism, synkinesia, syndactyly, hearing loss, dental agenesis can be seen. So during the whole childhood, initially you can find cryptorchidism and micropenis. Prepubertally, you will find decreased secondary sexual characteristic, and later they will come to us with infertility. So for them, you need a diagnosis clinically. You have to take up biochemical investigations, radiologic, and data genetic. Gonadotropins, of course, would be inappropriately low to the amount of testosterone. Testosterone is generally less than 3 nanomole per liter. Inhibin B is very important tool now to distinguish it between CDGP. Inhibin B will be much lower. It will be higher in CDGP and also in acquired hypogonadotropic hypogonadism. Even low inhibin B is a negative predictor of fertility. AMH, on the other hand, is initially low in IHH, patients with CHH. It will be low till childhood age, but in adults, you will find to have high AMH levels. So if you suspect other pituitary axis deficiency, check for prolactin, T3, T4, TSH, cortisol, IGF-1. We need a MRI to rule out cellular or extracellular lesions. And testicular ultrasound, I think, rarely needed. Oxidometer is more than sufficient, but it has been found to be much more superior as compared to oxidometer in studies. Brain MRI to rule out cellular, extracellular lesions, and also to look for the olfactory bulb hypoplasia which is there. Bone density need to be done in patient with CHH to look for bone mineral density, and rarely will you need hearing audiogram or spermiogram. So coming to the main part, that is treatment of CHH. So what is our goal of treating a CHH? You of course want to improve the secondary sexual characteristic, maintain the normal sex hormones and healthy sexual life, but also need to achieve a fertility. So for that, if you patient come of CHH comes in a neonatal period, they will comes mainly with cryptorchidism or micropenis. Their main goal are of us to is to increase the penile size and to increase the testicular growth. So in that cases, you can use an androgen therapy or even a combined gonadotropin therapy to increase the penile size. Both are superior, but to increase the testicular growth, combined gonadotropin would be much more superior. So there are some trials which has been done in the neonatal phase where combined FSH and LH were given in the 7.9 months and in 2 to 5 months, which have shown increased testicular volume as well as penile length. Now, if the patient comes to in puberty, which is the normal case, generally patients comes to us in the puberty, main thing what our objective is to improve the secondary sexual characteristic, to increase their height as well as psychosocial sexual development, plus to improve their bone mass and body composition. At last, we also want to gain fertility. So for that, best treatment which we often use to in our patient is testosterone treatment. Injectable testosterone is most commonly available in India. Testosterone has been started with 50 mg monthly, and with 6 monthly or 3 to 6 monthly, we tend to increase it to 250 mg 2 to 4 weeks. So over 24 months, you need a slow escalation of the testosterone treatment. Otherwise, you might have lot of side effects. Now, some cases, once you are giving testosterone, you might see in 10 to 20%, suddenly testicular growth start to happen. And this is the case of CHH reversal. And it has been seen in 10 to 20% of the patients. Common genes which are implicated are FGFR1, GNRHR, TEC3, TEC3R. And this suggests that final maturation of GNRH neuronal pathway might have been triggered by the testosterone which have given. And this has caused CHH reversal. And this is one case report from India only, where 21-year-old gentleman, after 8-month therapy of testosterone, actually developed increment in the testicular volume and ultimately had a CHH reversal. So this has also been seen in patients with CHH. Now, if you are giving a patient testosterone treatment with CHH, you have to maintain their normal serum testo level. You have to maintain their libido, sexual function, bone density, and general well-being. And generally, long-term androgen replacement is being needed. So for that, multiple testosterone treatments are available, which we'll discuss detail later on. And some patients in induction of puberty, you can also start with combined gonadotropin therapy, that is FSH and LH, because it have a improvement in the fertility potential later on in life. But this is generally very cumbersome, frequent injections and costly, and seldom used in our routine practice. So for puberty induction, as we have discussed, testosterone could be used as a 50 mg initially monthly, and then increase till 250 mg per month to 2 weeks. And if you are considering gonadotropin, HCG to be started with 250 IU subcutaneous twice weekly, increase by 250 to 500 increment every 6 months, and FSH dose 75 IU subcutaneous twice weekly to be increased till 150 IU subcutaneous thrice weekly. Pre-FSH treatment prior to SCG has been found in beneficial, especially those who are having low testicular volume or those are having history of cryptorchidism. So in adult form, the choice of therapy might change. Patient might need different testosterone. They might not be comfortable with only with injectable. There are formulations which are available in the form of oral, parenteral, transdermal, buccal, nasal gel. Pellets are available. And the modification of testosterone are mainly done by esterification or alkylation, which will result in increase in the T half of the testosterone. So these are commonly available testosterone available in India, like Sustanon 250, testosterone cypionate, and testosterone undeconate Sarno's depot is commonly available in India, 3 monthly injections. But there are also which are generally not available but are available in the worldwide. These are transdermal system endoderm testosterone gel is available, and then nasal gel and buccal tablets are available. There are implants which are being used outside India, and they are available for giving a testosterone level till 6 months. These are 200 mg pellets, 4 tablets can be inserted, implanted to the lateral part of the abdomen or hip. Problem is that 5% of patients, they might expel out the pellets during the vigorous physical activity. Transdermal testosterone are available in the form of patch or a gel. Gel can be applied over the trunk or axilla. They are available in the form of 5 to 10 grams gel, and patches are also available, which could be applied as a 2 mg or a 4 mg patch, which can be applied over the trunk or axilla. But these need a daily application and give you a sustained testosterone level till 24 hours. Transbuccal has an advantage. It is can be taken 30 mg every 12 hourly. It has an advantage that it does not avoid the first pass hepatic metabolism of testosterone, and it increases the local DHT, and intraprostatic DHT found to be very minimally impacted by the transbuccal dosage, and hence where you fear increase in the prostatic size, transbuccal have an edge. Nasal gel is also available to be applied to the nasal mucosa 3 times a day. Quite cumbersome, but still this is available. And injectable, which we commonly use, they depends upon the T half depends upon the ester side change or a volume of oil vehicle. So testosterone propionate is the having the smallest half-life, T half of 0.8 days. It gives you a immediate testosterone peak, and its effects lies only till 2 days. On the other hand, enanthate, it has a half-life of 4.5 days, and it gives a peak initially, and its duration of action is till 2 weeks. So what we are enanthate, if given 2 weekly, 3 weekly, 4 weekly, you can see the graph, it gives a normal physiological testosterone dose, but if given 1 weekly, it can give a extra physiological testosterone levels. So normally what testosterone injections are available, they are a combination of short acting and long acting testosterone. Like testosterone depot has a enanthate and propionate. Sustanon, on the other hand, has a propionate, phenylpropionate, isocaprate, deconate. So all these gives you a different testosterone value, and overall you will get a sustained testosterone levels till 14 days. Long-acting testosterone esters are available with a 11 carbon aliphatic fatty acid in an oil vehicle, which will increase their T half and duration of action to 12 weeks. So they are available as a Sarno's injection in the market. That is testosterone undeconate, 750 or 1000 mg, can be given 6 weekly or 8 weeks. So undeconate, they have a slight disadvantage that because of the oil, very rarely you might get pulmonary oil microembolism. Oral or deconate is also available if the patient wants that. Oral forms are also available in the form of 40 mg oil-filled capsule to be given after a fatty meal, twice or thrice daily. Oral testosterone undeconate also avoid the first pass metabolism and has a little risk in increasing the prostatic size. So talking about the adverse effect, if you are giving a long-term androgen therapy, testosterone might have some adverse effect. Most common is polycythemia. Increase in the prostatic size has been seen, but not in the risk of prostatic cancer. Hepatic side effects are minimal, but we do see that there could be a cholestatic or hepatitic pattern, and pileosis hepatitis is a specific form of hepatic side effect which can be seen with androgen therapy. Now, venous thromboembolism is being seen, but cardiovascular disease risk is found to be very low, not found in randomized control trial. Seborrhea and acne, modest weight gain, gynecomastia, these can be seen. And reversible depression of spermatogenesis and fertility has been seen with androgen therapy. That is, this is reversible. Once a patient has been stopped with androgen therapy and started on gonadotropin, you can again develop spermatogenesis. Only thing is, predictor of having a fertility might be less if the patient is already on androgen therapy in the long run because of the decrease in the intratesticular testosterone production. So coming to the next part, and this is the last part, and this is the induction of fertility in males with CHH. So induction can be done by a pulsatile GnRH therapy or a combined gonadotropin therapy. Now, pulsatile GnRH therapy has to be given every 2 hours subcutaneously. It is quite cumbersome, not available in India also, and has been found to be superior as compared to combined gonadotropin therapy in most of the studies. So if we talk about gonadotropins, which we commonly use, we start with either FSH followed by LH, that is pre-treatment with FSH, especially in those patients who are having low testicular volume. Or you start directly with the FSH and LH. So how much FSH to be given is to be started 75 2 to 3 times weekly and increase to 150 2 to 3 times weekly. And LH dose available in the form of SCG to be started with 500 to be started with 1000 IU subcutaneous 2 to 3 times weekly, to be increased till 2000 2 to 3 times weekly. So these are the doses which we have uh, discussed of FSH and LH. What we want from a combined gonadotropin, generally the response comes later, generally after 6 months of the treatment, not before that. So what we want from our treatment, that testosterone should increase by more than 3.5 nanogram per ml. You start getting some form of some amount of sperm, any sperm, or some amount of sperm like more than 5 million per ml, more than 10 million per ml, or more than 15 million per ml. What are the predictors which will identify that patient will have a better fertility outcome? That on the start of therapy, testicular volume was more than 4 ml. There was no micropenis cryptorchidism history. Inhibin level on starting were more, also is a predictor of fertility. And early initiation of gonadotropin therapy or prior testosterone treatment might have a negative impact on fertility outcomes in patient with CH. So these are some studies which have shown that pre-treatment with FSH have shown better treatment in almost 70% in this one study, and FSH and LH have shown better results. This in the terms of improvement in Sertoli cell function and in improvement in inhibin B and testosterone. So in summary, absence of mini puberty is being found in CHH males. If you find cryptorchidism micropenis, combined gonadotropins might have a better role as compared to androgen therapy. Testo injection to be given started at a 50 IU IM once a month to induce puberty and later increase subsequently over 2 years to 250 IU once in 2 to 4 weeks. So testosterone replacement therapy actually might interfere with spermatogenesis and it may impact future fertility. And that's why some argue that you should start directly with gonadotropins instead of testosterone treatment for induction of puberty. However, that is quite cumbersome to a child. And if you want fertility, GnRH pre-treatment, early identification has a better prognosis, and there are also cases of CHH reversal which should be well aware of, where patient might have a reversal. And fertility, you start with SCG and LH from the dose of 75 IU HMG started 75 twice to thrice week to increase to 150 to thrice in a week, or HCG injection started 1000 twice to thrice weekly, increase to 2000 twice to thrice weekly. Thank you.
Yes, thank you for nice presentation. So we have to see that not only to for hypog, you have to only have the masculinity, but rather testicular volume and the future fertility to be seen.
Yes.
So it is always that if we are going to maintain the testicular volume, and what are the predictors that there will be a good outcome. So you have already highlighted. So any question? Okay, thank you so much.
Thank you.
Thank you, sir. That was very informative. I would like to invite Anurag sir to give the memento. Sir, memento to the Anshu sir. The therapeutic landscape in pediatric endocrinology is expanding rapidly with newer technologies, newer molecules, gene based therapies, and precision medicine. So, may I invite Dr. Himchand sir to enlighten us on novel therapeutics?
I think this talk will be kind of a sum up of what has happened since yesterday morning. And if you look at novel therapeutic agents, We have three group of agents, I would say. First group of agents is they are there, they are available in the market, reasonably priced. There are a lot of patients who are eligible to receive them, but there is a physician inertia to prescribe them. So we'll have to do an introspection on that.
Therapeutics. Yeah, this one. Novel therapeutics.
The second group of is there are patients who are eligible to receive them. The drugs are available, but they are available for use in adults and they are percolating down to the pediatric age group. And third group is children, group of drugs which are difficult and we have to take a lot of efforts and we'll have to be very careful about the consequences. So I think these are the novel therapeutic agents in pediatric endocrinology. We'll look into over the next 15 to 20 minutes. So denosumab, I think this is a kind of a sum up of the talk which Sir gave yesterday. There is a lot of data on the availability and benefit of use in children with difficult osteoporosis, difficult OIs, and OIs which are not responding to conventional bisphosphonate therapy. I could identify 3 case reports on use of denosumab in children below 18 years from various Indian centers. And the uniform observation in these 3 were the rebound hypercalcemia that is bound to occur in them. So one has to be extremely watchful and expectant for these complications, be prepared, counsel them, consent them. And number 2, probably optimize the dose so that this complication can be prevented. So denosumab is a monoclonal antibody. The dosing is 1 mg per kg every 12 weeks. It is indicated in difficult OI who is not responding or tolerating bisphosphonates, good improvement in bone mineral density, vertebral projection area, reduction in fracture frequency. So rebound hypercalcemia and osteochlorosis should be watched for. Meticulous and need-based supplementation of calcium, vitamin D, and serial monitoring would be the precautions which practitioners should take when they are using denosumab in appropriate situations. Long-acting octreotide, it's another novel therapeutic agent. Again, this slide is a sum up of experience from different reputed centers across our country. And if you see, published data is available for nearly 30 to 40 children below the age of 18 years on use of long-acting octreotide. And I think across the board, the understanding is there is safety, there is efficacy, there is tolerability, and there is good response when chosen in the right patient. So children with hyperinsulinemia who need daily octreotide in multiple injections daily, they can be trialed to receive long-acting octreotide once a month. So the dosage calculation, as discussed yesterday, would be cumulative monthly doses. It would suppress the endogenous insulin production, lesser pricks, comparable efficacy. The worry is the impact on growth, thyroid functions, the need to monitor for gallstones and liver function tests. But I think the safety and cost effectiveness from these 3 reputed centers is very much in favor of use of this particular drug. This is again a sum up of the vosoritide, which Dr. Arun spoke about very beautifully. There is a lot of data from different centers. There is no Indian data to my knowledge. And I think vosoritide should be considered in the appropriate child aged more than 1 to 2 years with genetic confirmation of achondroplasia and unfused epiphysis. It is preferably given as a single daily injection once a day, 15 microgram per kg. So the reported improvement in growth velocity is around 1.5 to 2 centimeters per year. And there is improvement in the biomarkers and there is an improvement in the upper segment, lower segment ratio. And of course, the side effects one should keep in mind: the tonsillar hypertrophy, thyroglossal cyst, obstructive sleep apnea, and in children with grade 3 serings, which was summarized very beautifully yesterday. And I think there is a lot of difficulty in procurement of this drug, and the prohibitive cost of this drug, I think, is something which I'll come up in the last slide. Then transdermal estrogen. I think again, this is one drug where I would say there is physician inertia. It is very much available. And there is a very clear-cut regimen that is described in the consensus of the Turner syndrome. Possibly the fault is with us that we are not using them. If the patient is willing and it can be procured, I think we should definitely. And there are very beautiful recommendations on how to use it in small doses. It is uniformly distributed across the patch, so cutting should not affect the availability. Subcutaneous patches starting with around 3 to 7 microgram per kg with slow advancement to adult doses. And as Sir said rightly, the consensus statement gives the target estradiol level which we should be working on. So it has to be advanced to the optimal dose. It is absorbed into the skin capillaries and delivered into the bloodstream. And lesser cardiovascular risk, lesser cardiometabolic complications, better bone health, and very good improvement in the secondary sexual characteristics. The worry would be the addition of patches and skin reactions. The recommendation is to apply anywhere below the hip and buttocks and try to target estradiol levels. It can be used in girls with delayed puberty, hypogonadism, either primary or secondary. And I think there is a need for many of us to start using them with the right precautions. So this is again a condition which is increasingly being recognized in different centers with the availability of genetic testing, hypophosphatasia, where you have a genetic abnormality resulting in low alkaline phosphatase levels. It's always important to use age-specific norms to make the diagnosis. And there is one Indian report of use of hypophosphatasia, and which they have procured from out of country from South India. And they have noted a good improvement in the severe form. The infantile and childhood form with lot of difficulty and compromised bone health, recurrent fractures and calcium disturbances. What the authors have reported is there is a good improvement in motor milestones, radiological parameters, normalization of the biochemical parameters. So in genetically confirmed forms of hypophosphatasia on a named patient program, the disease can be procured, and it started off with 2 mg per kg on alternative days. You can go on to lower or higher doses based on the biochemical and clinical response. Local side effects is very, very common. The guideline and manuscripts give a lot of practical aspects on how to use it. The only worry is the dreaded complication that we worry about in these group of children is craniosynostosis. This enzyme has not reported to have any improvement in that, but I think the overall picture is very much in favorable. I think again comes the prohibitive cost that you are looking at in importing this drug. This is again recombinant IGF-1. I think with the availability of genetic testing, so many children are being diagnosed with IGF-1 deficiency. There is an indication, a licensed indication to use. There is a case report from All India Institute of Medical Science where they have reported a good increment in height velocity with short-term IGF-1 replacement. And our own experience, we have one child who is on IGF, and there has been an increase in the height Z-score by about nearly, I would say, 1 SD with considering the degree of discrepancy. 2 years of IGF-1 resulted in a 1 SD increase. So it might look very suboptimal, but I think for that child, it's a spectacular response. The worry about this drug is, of course, the cost, the hypoglycemia episodes, the practical difficulty in procuring the drug, which has to go through a lot of regulatory clearance, and of course, the prohibitive cost, which works to almost 1 lakh per month for a 10 kg child. So I think it's, and the hypoglycemia frequency, we had to take the help of CGM to monitor frequent feeding. But I think the efforts were worth when they saw the results. So children with genetically confirmed, I think genetic confirmation is very important, and GH1 gene defect with positive antibody. I think testing of antibodies is not feasible at this point of time, commercial testing. Probably a genetic confirmation of GH1 defect and an IGF generation test to prove that there is no response to growth hormone. I think with this combination, I think taking them forward to recommend IGF-1 replacement can be considered. You give them in a dose of 80 to 120 microgram per kg per dose, good improvement in oxology and final height. Always monitor them for hypoglycemia, features of raised ICT and tonsillar enlargement. There is a very beautiful BSPED guideline on how to use IGF-1 and monitor them that can be used when you are putting them on IGF-1. GnRH antagonists. I think this is one group of drugs which is available and used in adults for different indications. Very, very scarce pediatric data, but I think we need to, this is an unexplored area, I would say, because you do have children with central precocious puberty who do not tolerate or respond. The biochemical and clinical control just does not come with very high doses, and the axis, and they are idiopathic. So they are very difficult cases, but I think the available evidence is very scarce. There are just isolated case reports, I would say. Uh, uh, Probably putting together the available evidence and taking the consent, one can attempt, start off with a small dose, go weekly injections, and direct. The benefits would be there is no initial flare, there is quick recovery, but the scarcity of the data deters you from using them routinely. But on an individual case basis, one can explore this particular option. Again, with genetic testing, this particular genetic defect is being recognized in many centers. I think the Christian Medical College has a good cohort of children with this particular genetic defect of MCT8 defect, where you have peripheral hyperthyroidism, features of tachycardia and hyperthyroidism, but central hypothyroidism because of a transporter defect. So you have an analog which bypasses the MCT8 and enters, and it causes good improvement in the peripheral hyperthyroidism and good improvement in the biochemical parameters. Regarding the improvement in the neurological component is not answered yet, but I think this is a very potential and available and upcoming treatment. You have very clear, the basic need is, there is a need to establish the genetic defect by a concrete genetic test. There are a lot of centers from Europe which are offering both therapeutic guidance as well as the medication on a named patient basis. They are providing the medicine at very reasonable charge, and these are the recommended doses based on the weight, and they are also offering help in terms of performance of LCMS based thyroid function test assays, because you are looking at a new drug to maintain T3 levels at a particular recommended range, and using the available CLIA assays which are available in our country commercially, which is prone to error in this new drug. I think when they are offering help to do it on an LCMS based assay, we are really blessed to take the help of that support. The practical challenges would be transporting the samples, getting a consent, getting an institutional ethics committee clearance for this drug, which is not approved by the FDA. Reports, I would say, published data on nearly about 20 hyperinsulinism who have received sirolimus, and the dosing which they have reported from All India Institute of Medical Science, from Rainbow Hospital in Hyderabad. It's a very heterogeneous experience, I would say. I think this is one has to remember that the dosing guidelines are not clear, but we have the necessary safety checks in the sense that we have the facility to monitor the sirolimus level, and that can be done. And it should preferably be done in a tertiary care center with the backup of an ICU and a hematologist, because of the potential risk of immune-related complications and hepatic complications. I think diffuse disease unresponsive to medications. I think sirolimus should be attempted to avoid pancreatectomy. These are the dosing guidelines, 0.5 to 1 mg per meter squared. Avoids the needs of pancreatectomy, but of course, you always remember it's a war where you need the ammunition, a proper PICU backup and a hematologist support, and their clearance is mandatory. And checking the petrol tank indicator by monitoring the sirolimus levels is very important. And long-term follow-up data is available till about 5 to 7 years after using sirolimus. They have maintained remission. So I think when you can postpone a complicated surgery which can result in lifelong need of insulin, it makes sense for us to explore this option. The next is monoclonal antibodies and genetic dyslipidemias. I think this, with availability of genetic testing, this condition is being increasingly diagnosed, and Dr. Sain is very happy and smiling. And so they have explored the use of monoclonal antibodies against PCSK9 and angiopoietin-like protein 3. And this is the commercially and easily available molecule which is available in adults. This has been licensed and it has been used in many children with hyperlipidemia, and they have reported a good reduction in the lipid parameters. And this is Dr. Sayan's own study from PGA, where they used the evolocumab. They imported it on a special named patient basis and gave it as an IV injection. And you can see the beautiful response what he has described after the use of this drug in a patient with a null mutation in the LDL receptor. So I think in genetically confirmed cases of homozygous and severe forms of heterozygous familial hypercholesterolemia who are not responding to conventional statin therapy, I think it makes sense for us to explore these newer therapeutic options. Of course, the worry about the older drugs were the impact on neurocognition, etc. But I think all this has to be put on paper, consented, preferably taken in a tertiary care center with an IEC clearance, so that, if there is a problem, we have the backup of so many people to, endorse that we have done the right thing. And there is a reduction in about 50 to 80% reduction in the LDL. And of course, long-term safety is not available. It's a worth exploring a novel therapeutic option. I think Dr. Shalmi mentioned about this teplizumab, about the FDA approval to delay the progress from stage 1 to stage 2 to stage 3 diabetes, especially siblings of type 1 diabetes who have positive antibodies. This is the original trial where you had a delay in the onset of symptoms in those who were given the teplizumab therapy versus the placebo. And the median times to diagnosis was higher in those who received teplizumab, and a big group of them did not develop type 1 diabetes at all. It preserves the C-peptide, and the indication would be in sibling aged more than 8 years with 2 positive antibodies. And the dose, there is a very beautifully described in the protocol of giving it as an infusion over a period of 14 days. And some non-specific immune reactions are described. But this drug has a very big prohibitive cost, and it is not approved by DGCI. And so I think there are a lot of practical challenges in exploring this therapeutic options. Recombinant parathyroid hormone, for it's another novel therapeutic option that is coming up. So there is a beautiful sum up which was published to in the pediatric age group, though there is a black box warning against the risk of osteosarcoma in children to use recombinant PTH. I think it has been used by researchers across the globe in appropriate clinical situations. And what would be and they have been followed up. In India, there is one particular case series from St. John's Medical College, again a tertiary care center, who had a very short course of recombinant PTH in a critical care setting where they could not bring up the calcium levels. And they had a very good short-term response, and they normalized the biochemical parameters. So children with hypoparathyroidism with genetic confirmation and complications with conventional therapy, I think start off with 0.5 to 1 microgram per kg, and you can escalate. surveillance for this particular complication. Explore this option of recombinant parathyroid hormone. GLP-1 analogs, I think there has been a lot of discussion on this. There is a lot of data to support this novel therapeutic agent. The Indian Academy of Pediatrics has empowered pediatricians to consider this drug in class 3 obesity, and they have provided the extended BMI charts to use this novel therapeutic agent in class 2 with significant comorbidities and as an adjunct to weight loss. So it's the trial protocol which was discussed very beautifully, starting off with 0.25, slowly escalate to the maximum of 2.4 milligram. Practical guidelines on how it should be used, how it should be administered, how to tackle a missed dose. Similar to long-acting growth hormone is available for semaglutide as well. There is a good reduction in weight by 10 to 20% and BMI by 5%. So I think this should be explored when you have a right patient. Burosumab for hypophosphatemic rickets. I think this is again another novel therapeutic agent which is coming up, and there are no centers as such offering it on a routine basis. But if you look at the meta-analysis, the impact on every possible clinical and biochemical parameter is really amazing. So hypophosphatemic rickets with a genetic confirmation, and either if it's very severe or it has developed complications to conventional therapy, this option should be explored. It's a recombinant immunoglobulin against FGF23 used in children above 1 year of age. This is a dosing recommendation, 0.8 to 1 mg per kg, subcutaneous injection. And that causes a good improvement in the serum phosphorus. And there is not much of clear information about the impact on dental abnormalities. There are some local reactions that are described and some concerns about children with restless leg syndrome. But I think this is something which we should explore. And again, the problem comes with the need to import the regulatory clearances and the extremely prohibitive cost. The last drug, I think, is aromatase inhibitors, which I think is available for many years now. But I think there is very, very, very scarce Indian setting literature to support the use of this. Of course, yes, you don't have a heroic response, but I think a safe medication with good oxological improvement somewhere around 2.5 to 4 centimeters based on the indication, whether it is idiopathic short stature or GHDs, the response with 2 to 4 years of therapy is worthwhile to consider. It inhibits aromatase and delays epiphyseal fusion. There are occasional concerns about impact on the vertebral architecture as well as the impact on sperm count, but purely theoretical. So children who have ISS or late GHDs with compromised final height, pubertal, I think the onset of puberty is very important, and boys. Limited data on girls, this is available. Of course, there are some good trials that are recently there, but boys, it is pubertal boys. One should probably consider the use of these drugs to improve the final stature. So I think this is a sum up of the novel therapeutic agents. The understanding is that there is a need for genetic confirmation in most of them. The dosing guidelines are largely clear with good studies. The problem is the prohibitive cost, which really, and I think at this point, I think I really recognize the vision of our ISPE president to form advocacy groups who are probably working on to try to bring down and way to reduce the taxation and way to leak waste to help them to bring down the cost, and very importantly, regulatory clearances. Of course, there is a provision to get a clearance for an individual patient with a genetic disease and the capability to import the drug. There is a proper channel that is available, but still there are a lot of practical restrictions. It's not just 1 + 1 = 2. It has a lot of hurdles hidden in between. So I think this is a sum up of the various therapeutic agents which are there today, probably as small seeds, but I think in the days to come they will grow up to become big plants and make a huge difference. I think the steps we need to know as responsible physicians are: number one, there is a genetic need for a genetic confirmation. Regulatory clearances have to be gone through. The high cost availability procurement is something that we should fight. And I think there is a need to report the experience one develops with these. And there is always, betterment in networking with experts, because they will be very, very happy to give us finer inputs to optimize the health of these. So a responsible action, judicious use is probably the way forward as far as these novel therapeutic agents are concerned. Thank you. Thank you very much.
Thank you, Dr. Hemchand, for an excellent and lucid presentation and showing the new way and way forward for the future upcoming better management of these novel therapies. Thank you so much.
One small doubt, if I can ask. So I do have an experience with giving leuprolide as to at around 14 years of age for growth hormone patient, just to delay the epiphyseal closure so that the height is reached. Any experience of user or any experts on using aromatase inhibitor for the same benefit? Like how different is it from the growth benefit that we achieve from maybe leuprolide?
The optimization of final height, the novel therapeutic options, which so to say, the strategy of delaying the epiphyseal fusion by either giving GnRH analogs or by giving aromatase inhibitors, it's an upcoming topic. And but to my knowledge, there are no head-on comparison of one cohort which has received GnRH analogs and one cohort which has received aromatase inhibitors. Late presenting children who have a compromised final height, I think there is a justification after explaining the pros and cons to use both GnRH analogs and aromatase inhibitors. In that setting, I would say, considering the fact that you're manipulating puberty at an age of 14, I think it would be wiser to consider aromatase inhibitors in that particular setting because of the relative safety and thing. But I think one needs to explore these options. See, the benefit described in most of the meta-analysis somewhere between 2.5 to 4 centimeters with around 3 to 4 years of treatment. So I think a realistic picture has to be presented, and we have to follow up these steps. And most of them are the improvement in predicted adult height. The very, very few studies have looked into actual difference in the final height. So all these have to be factored, and we have to take it forward.
Thank you, sir. That was very informative. Now I would like to invite Vijay sir and Medha ma'am to accept our token of gratitude. Next up, we have a very interesting grand round on adrenal disorders. To chair this session, I would like to invite Dr. Hemchand sir, Dr. Shayan sir, Dr. Neha ma'am, and Dr. Riddhi ma'am. Thank you for joining us. This session will be led by Dr. Anurag sir and Nimisha ma'am.
So, adrenal disorders are extremely important, and I think they often cause a lot of confusion in that perspective. And it's good to have a discussion on this important topic with our learned speakers. So, we have got Dr. Hemchand, who just gave a wonderful talk on novel therapeutics. I think he has given a similar talk in 2017. And since then, there have been huge changes which have happened in that regards. Many of the drugs which were discussed that time have now realized into and translated into practice. So that is something which is good. Dr. Neha, who was one of our initial fellows with Dr. Chetan, I think that was 2017 only when they joined. and she is now working as a pediatric endocrinologist at Regency Hospital, Lucknow. Dr. Riddhi, who was just worked overlapping with Neha and who is working now at Vadodara, and Dr. Sayan, who has now joined the Neotia Hospital in Kolkata. So we'll discuss about the various aspects of adrenal disorders. And what we'll focus on are, I think, three groups of disorders: adrenal insufficiency, congenital adrenal hyperplasia, and Cushing syndrome. These are the three groups we'll discuss about. So we all know that when you talk about adrenal insufficiency, the problem can be at the level of the CRF or the ACTH, which is the central cause or secondary quote tertiary level. Herein, you will have a problem of only cortisol deficiency, because aldosterone secretion is independent of ACTH. What also is important is that the RAS axis will be normal, so they will not have any salt wasting, hyponatremia or hyperkalemia. They will also not have pigmentation. The most common causes in early age group will be genetic, followed by infiltration and trauma. And one condition which we are seeing very often is exogenous steroids. Now, these exogenous steroids may be given not only as part of treatment, but also as part of many complementary medicines, Ayurvedic, homeopathic, Unani, all those medicines often contain that, and that causes confusion. The second rare group of disorder is a problem in the ACTH action. So these are the MC2 receptor defects. These will have interesting finding. They will be very pigmented. In fact, they will be the most pigmented of all these conditions. Along with that, they will have a normal potassium because they will not have a aldosterone effect. And this will basically be two major groups of either the MC2 receptor defects, the MC2 receptor associated protein, and sometimes some milder forms of glucocorticoid deficiency. And what is most life-threatening and acute is usually primary adrenal insufficiency, in which you have a problem of the adrenal gland itself. It will present with pigmentation, with salt wasting, hyponatremia, hyperkalemia. So classic problems will be CAH or steroidogenesis at birth, and subsequently you can have adrenal hypoplasia congenita, or you can have other acquired causes like hemorrhage or infiltration. So these are the various groups. If you look at pigmentation and potassium, you can classify pigmentation and high potassium, that is primary. Pigmentation, normal potassium is your receptor problem. No pigmentation, normal potassium is your central cause. That is how we go forward. So anybody who has hyponatremia, but sometimes they present more with headache. Hypoglycemia is rare, but during illnesses may happen. Most often presentation would be mild symptoms like fatigability, and hypercalcemia may happen in the setting of hypoparathyroidism. So if you have a child with type 1 diabetes who has lower insulin requirements suddenly, a child with central diabetes insipidus who has now suddenly requirement of AVP has come down, hypertensive requirements have come down in hypertension, and calcium requirements in hypoparathyroidism, always think of cortisol deficiency. I think these are the things often missed out in that regards. Now, clearly what cutoffs to use? So generally we talk about 550, or if you're using a GCMS, it will be 400 nanomoles per liter. Some people are now using 500 as a cutoff. So whichever cutoff you're using for your lab is good enough. Remember, a single isolated low cortisol is of no value. You need to have either hyponatremia, pigmentation, high ACTH, or hypoglycemia, then it will be of value from that regards. And you can do a stimulation test using the ACTH, which is now easily available. The synthetic ACTH is now very well available. ATM values do not, a single value will not have a significant issue. Always remember that cortisol and ACTH have a log linear relationship. So if you have anybody whose cortisol is low, ACTH should be sky high. That is your primary insufficiency. If the ACTH is normal or slightly elevated, like we talked about FT4 and TSH, the same thing applies here. Low cortisol with ACTH below 300, question, this could be a central cause in that regard. Pigmentation typically happens when ACTH is beyond 700,000. So it's not going to happen with mild level of ACTH elevation. One of the biggest diagnostic dilemmas is in infancy. We know the cortisol levels fluctuate. Preterms have a different course. So there are different cutoffs which people have suggested, and preferably by using a GCMS-based assay rather than an immunoassay. Levels less than 100 in the first week, 70 in the next few months, and then 138. Now, of course, the diurnal rhythm is not established, so you can do cortisol level at any point of time in these individuals, and this becomes important. So other thing to remember that they can also have high level of sulfated products. So immunoassays are not good. You should do an extracted sample and preferably using GCMS, and diurnal rhythm, as I said, is absent. Very commonly during hypoglycemia, you will find low cortisol. This may be a exhaustion response as well. So don't diagnose everybody with low cortisol during hypoglycemia as a cortisol deficiency, especially if the ketones are absent. This may be hyperinsulinism with secondary exhaustion of the adrenal response in that perspective. So how do we approach? If ACTH is less than 300 during cortisol deficiency, think of a central cause, do MRI. More than 300, young child, think of CH. Older child, think of ALD. Now we have got genetic testing done, which can also be done in most cases. And of course, autoimmune workup can be there. We can now go forward with the cases, Dr. Nimisha.
So thank you, sir. We'll now begin with cases. So starting with our first case, it was a 12-year-old boy who had liver disease with hyponatremia. Potassium was also on the lower side, 2.8. Urinary sodium was done, which was 10 millimole per liter. There was fluid overload in the child, and cortisol was sent in view of hyponatremia, and it came out to be low, and hence the child was advised hydrocortisone. Dr. Hemchand, sir, do you think this is correct?
Right, thank you. I think the learning point is all that glitters is not gold. So whenever you have low cortisol in this sort of a clinical context, I think remember you cannot jump into cortisol replacement right away. Whenever you have cortisol deficiency, you remember that in a liver disease, cortisol deficiency comes in multiple contexts. It is a predictor of severity of the disease. You can be looking at concomitant sepsis, or when they're looking around transplantation, they can go in for transient adrenal insufficiency. And you can have children with neonatal cholestasis who are underlying, they have a central cortisol deficiency that is presenting to you clinically as a neonatal cholestatic syndrome. So a careful distinction of children who have cortisol deficiency and who have cortisol sufficiency is very, very important in children with liver disease. And unfortunately, in severe forms of liver disease, you have a reduced production of the CBG, which results in a false low cortisol level. And replacing these children with cortisol would not be the right approach. So you are always worried about missing the wolf in the sheep's clothing and picking up the sheep in the wolf's clothing. Children who are on OC pills, you are going to have higher production of CBG and have a false elevation of cortisol. And children who have liver disease, nephrotic syndrome, you're going to have a low production of CBG and you're going to have a false low cortisol. So in these situations, I think whenever the albumin level is below 2.5, cortisol level might not be the picture in itself. So alternate markers in this, the important clue is the urinary sodium, which is low, which is anticipated to be much higher in this clinical context. So I think one would not jump into cortisol deficiency. There are a lot of theoretical calculations, formula which correct for the albumin, etc. But I think one would be careful in the situation before labeling as cortisol deficiency.
Thank you, sir. So in this case, albumin came out to be 1.5, and on advising the free cortisol level, it came out to be normal. So the key messages would be urinary sodium will be high in cortisol deficiency, and cortisol levels were falsely low in low liver disease. So moving to the next case, 3-week-old girl presented with failure to thrive. Weight was 3 kg. Birth weight was 2.7 kg. Sodium was 142. Potassium was 3.9. Cortisol level here was advised and it came out to be 86. And again, the child was advised hydrocortisone. So Dr. Ridhi ma'am, how will you approach this case?
So firstly, only one criteria like failure to thrive doesn't fit into cortisol deficiency. If we look at the electrolytes, they are normal. This is generally not seen in any form of the cortisol deficiency. And secondly, measuring the cortisol in neonate and infantile period, we are mainly dealing with the two issue. What is the cutoff to use? And second, what are the assays which are used to measure the cortisol? So as sir has discussed that in 1 month of the age and first infantile period, the cutoff used is 70, which is 86 in this case. So not fitting into the criteria of cortisol deficiency by single level. And secondly, the assays, we should use the GCMS based assay. for measuring the cortisol, because otherwise falsely low or high value you will get based on the essay.
So we can do cortisol any time of the day, and during first month it should be less than 70. So the key messages, ma'am.
So non-stress cortisol is not reliable in infancy, especially single value. And if you are not looking for the clinical pointers of cortisol deficiency, as sir has discussed, single isolated low level of cortisol without clinical suspicious is not the diagnostic of adrenal insufficiency. And GCMS based assay are more preferred in neonatal and infantile periods.
Thank you, ma'am. Moving on to the next case, 2-month-old boy presented with failure to thrive. Weight was 2.5 kg. Height was 52 centimeter. There was hyponatremia as well as hyperkalemia. Cortisol was done here. Again, it was low. Now the treating physician advised ACTH. It came out to be high, 500 picogram per ml. 17 OHP was done, which was normal, and the child had normal genitalia. Dr. Neha, ma'am, how will you approach this case?
So if we look at the clinical picture and the biochemistry, there is borderline hyponatremia with hyperkalemia, low cortisol with high ACTH. So this points towards primary adrenal insufficiency. But as we see that genitalia is normal and 17 OHP is also within the normal range. So this excludes our possibility of congenital adrenal hyperplasia or 21 hydroxylase defects. So second possibility that we have as per the algorithm is that we need to look at the CT, lipids, and NR5A1 gene mutation. So a CT scan was done in this case, which showed shrunken adrenal glands, and this was a case of adrenal hypoplasia congenita.
Thank you, ma'am.
So the key messages from this will be that always a low cortisol with high ACTH should points toward a possibility of primary adrenal insufficiency, and all cases should not be thought of just 21 hydroxylase defects, and alternative possibilities should be kept in mind.
And I think this is also important to now we are finding cases of DAX1 and NROB1 at a later age also. So milder defects may actually present. So we discussed in the on-site course the child who presented at 8 years of age. So it may present later also, but definitely before 6 months. So these algorithms are from earlier guidelines. At 6 months below you go for genetics, but now probably you should be more ordering because it's easily available also, and you will find a lot of defects. We have basically a case with star defect, with DAX1 defect. So all these things come up now on genetics. So I think adrenal insufficiency is one which we should think of these possibilities.
Next case, a 2-year-old boy with fever and again failure to thrive. Blood sugar was 24. It was ketotic hypoglycemia with hyponatremia, and potassium was 3.2. Cortisol was done. It came out to be 112 nanomole per liter, and ACTH was very high, 1200 picogram per ml. Child was diagnosed as Addison's disease. Dr. Sayan, sir?
So just as discussed by sir in the previous slide, so for adrenal deficiency, you are looking at a cortisol and a aldosterone defect. So if you have a aldosterone defect, you cannot have a potassium which is at 3.2. So here you exclude Addison's, but the second possibility that you have here is that a ACTH is very high and a cortisol which is low. So this is pointing at some adrenal defect which is causing decreased cortisol synthesis. Now this is typically what was just discussed. Three things which you have to think of is of a receptor defect. ACTH receptor, that is MC2R, MRAP, and a rare possibility of AAA syndrome. So on these lines, you have to work up. So did we work up on
Yes,
these
sir.
lines?
So the child was diagnosed as FGD1, MC2 receptor defect.
So FGD, the two cases I remember which sir showed me, two brothers, the first time in my life, they were pitch black pigmented. And I think most of you in your on-site have also met him. So pitch black, isolated cortisol deficiency, very high ACTH, think of receptor defects.
Thank you, sir. Your key messages, sir?
Potassium normal is ACTH defect, not Addison's disease, and very high pigmentation suggests a resistance.
Thank you.
And I think just to add on that, the pigmentation is so much because if you have primary adrenal insufficiency, you don't diagnose, they will die. They will die because of salt wasting. While these children will keep on dragging, surviving, they presented to us, I think, 15 years of age in that perspective. So they were so dark on that. And I think just one part on DAX1 we missed out on is hypogonadotropic hypogonadism, which often happens in them on follow-up. So that is something to be added here.
Moving on to the next case, 2-year-old boy with feeding difficulty, with fever, with hypoglycemia, and again ketones were present during hypoglycemia. There was hyponatremia, potassium was within normal range, cortisol was 98 nanomole per liter, and there was pigmentation. Dr. Hemchand sir, how will you proceed with this case?
So I think the writing is on the wall. See, you're looking at a pendulum. At one end, you have central, sir rightly pointed out, central adrenal insufficiency who have isolated cortisol deficiency. The ACTH is normal. They don't have a pigmentation. Then you're looking at an isolated glucocorticoid defect, the midpoint of the pendulum. You're looking at cortisol deficiency. You're looking at pendulum, but the mineralocorticoids are normal. You're going to the other end of the pendulum where you have a total destruction of the adrenal gland. You have glucocorticoid deficiency. You have pigmentation, and you have mineralocorticoid deficiency and dyselectrolytemia. So here you're looking at a child who has cortisol deficiency, and you also have pigmentation. So primary adrenal insufficiency with isolated affection of the glucocorticoid axis. So this is what we are looking at. And here, always remember the tip of the iceberg phenomenon. You have to go deeper and find out the cause for the primary glucocorticoid deficiency. It can be a big spectrum. It can be a AAA syndrome with an underlying achalasia cardia which needs surgical correction, underlying alacremia which might need tear supplementation. It can be the first manifestation of adrenoleukodystrophy, and you pick it up early and you refer this child to the hematologist for stem cell therapy. The whole life is going to be changed for that particular child. So early identification, deeper diving into the tip of the iceberg and elucidating the cause is very important. In this child, that path was followed and a AAA syndrome was identified, and hitherto unrecognized achalasia cardia, hitherto unrecognized alacremia was picked up. So I think the key message is primary adrenal insufficiency is a spectrum. It can have isolated glucocorticoid or associated mineralocorticoid deficiency as well. Always look for hidden causes and silent abnormalities, which is very important.
Thank you, sir. Moving on to the next case, 4-year-old girl presented with diagnosed as hypoparathyroidism. She was stable on the levels on calcium and calcitriol. Suddenly presented with irritability and constipation. Now on doing calcium level, they were high. Sodium was on the lower side. Dr. Riddhi ma'am, how will you approach this case?
And before this, we were never able to get her calcium even in the normal range. And suddenly the level have gone up.
So as sir has already discussed in second slide, so somebody who are on stable on calcium and calcitriol dose, known case of hypoparathyroidism, and suddenly presented with the drop in the calcium requirement, calcitriol dose requirement, and with sudden high level of the calcium and hyponatremia that points towards the associated adrenal insufficiency. This can be part of the two autoimmune conditions together. So can be spectrum of the autoimmune polyendocrineopathy, and mostly APS1, which is associated with the hypoparathyroidism and adrenal insufficiency. So on further testing, cortisol found to be very low, that it was 80 nanomole per liter, and this was the diagnostic of the APS1. So if any patient of hypoparathyroidism or diabetes insipidus who are on stable on the routine doses but develop the decrease in the calcium and calcitriol requirement and hypercalcemia, think of the associated adrenal insufficiency, and calcium will normalize with the hydrocortisone supplementation.
Thank you, ma'am. Moving on to the next case, 12-year-old girl admitted in ICU with fever, and now there is sudden deterioration. She was hyponatremic with hyperkalemia. There was on examination petechial rash and flank mass was present. Dr. Sayan sir, how will you approach this case?
So the girl is admitted for some critical illness, and you have a sudden deterioration and a potassium that has gone up and a sodium that has gone low. So this is the classical thing that we learned. There is some there is some adrenal insufficiency. Now this was not chronic. This is acute, and you have the clinical setting of a petechial rash and a flank mass. And this is all that we studied from our primary MD days of a meningitis that can cause this sort of a presentation.
Management, sir?
So many other infections can also cause this, but the classical will be Neisseria. So acute adrenal insufficiency, you have a aldosterone and a cortisol deficiency. The first volume replacement, one is bolusing for any shock, and thereafter double maintenance. And then for cortisol replacement, you should have an acute bolus, that is 50 milligram per meter square. And then if you have an infusion pump, it will be 100 milligram per meter square per day throughout the day. But if you do not have that, you can divide that into 6 hourly doses, and the rest will be symptomatic management that you already have written. So this is the
And on tapering of
yeah. So tapering will depend on the and on how quick you control the rest of the parameters. But generally, if you supplement the doses within 2 to 3 days, you can take the patient out of the supraphysiological doses. And as rightly mentioned, as we do in CH, as we do in other adrenal insufficiencies, less than 50, add fludrocortisone.
Thank you, sir. So the key messages here are shock with hyponatremia, think of adrenal insufficiency, and flank mass suggests of adrenal hemorrhage. And hydrocortisone infusion is preferred over the bolus. So moving on to the next case, 12-year-old boy with septic shock admitted in ICU, multiple fluid boluses were given. On multiple vasopressors, there were no increase in blood pressure. Cortisol was sent and it came out to be 145 nanomole per liter. Dr. Neha ma'am, how will you approach?
So here we see that the patient was managed as per the sepsis protocol, first given fluids, then given vasopressors, but the blood pressure is not yet achieved in the normal range. So this is a case of catecholamine refractory shock. And although the cortisol is within the low normal range, but still hydrocortisone replacement is the drug of choice in the management of vasopressor refractory shock. So we need to consider hydrocortisone in such cases.
So the key
So
messages.
the key messages will be in all cases of catecholamine refractory shock, we may not need to do cortisol levels. Giving them hydrocortisone replacement is the management of choice, and just physiological replacement is beneficial. Supraphysiological doses need not be given.
Thank you, ma'am.
So now moving on to the second part of spheroidogenic defects, I think this is important when to think of it. Most of us think of DSD as the most important manifestation, particularly for 21 hydroxylase deficiency. But precocious puberty can also happen with 11 hydroxylase deficiency, delayed puberty with 17 hydroxylase deficiency, salt wasting crisis, of course, with anybody who has got low aldosterone production. Hypertension may happen with 11 or 17 hydroxylase deficiency, and hyperandrogenism as part of the increased androgen production. So just a simplistic classification, if the mineralocorticoid level is low and androgen is also low, we're talking about proximal defects, we're talking about star, side chain cleavage, 3-beta HSD. If the androgen is high, we are dealing with 21, 3-beta in a XX and POR in a XX individual. If androgen levels are normal, then we are talking about aldosterone synthase defect. If you have a normal mineralocorticoid with a deficiency of androgen, that is 17 beta HSD, presenting as a normal looking female with a XY karyotype. If it is XX, this is aromatase deficiency with XX DSD with typical history of maternal virilization during pregnancy. If on the other hand, mineralocorticoid is high and androgen levels are low, this is 17 hydroxylase deficiency, DSD in a girl, or a DSD in a XY individual, or you can have a delayed puberty in a girl, typically presenting as sexual infantilism and hypertension. While if there is androgen excess, this is 11 hydroxylase deficiency, which will present to you like precocious puberty in a male, and a XX DSD in that regards. And finally, if the androgen is normal, this could be a 11 beta HSG2, which is apparent mineralocorticoid excess. So if you combine your mineralocorticoid and aldosterone level and manifestation, you can broadly classify them clinically. Now, what can be done? So 11 hydroxylase, I said, is hypertension, XX-DSD, you can do DOC. 17 hydroxylase will be XY-DSD, and hypertension with delayed puberty in females. 3-beta HSD can cause DSD in both XX and XY. Again, DHEAS and 17-hydroxyprognenolone will give you the clue. Star HCC will cause XY DSD and delayed puberty in girls. POR is an interesting scenario where you can have DSD in both XX and XY. So this can be the way to go forward from that perspective. 17 beta HSG2 mainly as XY DSD, and 11 beta HSG2 is apparent mineralocorticoid excess. So how do you interpret 17 OHP levels? If 17 OHP levels are below 300 nanogram per DL, CAH is extremely unlikely. Above 3500, this is 21 hydroxylase deficiency. If it is 300 to 1200, you're dealing with variants like 3 beta, 11 hydroxylase. And if the levels are in between, you can do a ACTH stimulation test. So basically, this is how you can interpret 17-OHP levels. This is very important because now neonatal screening is available and a lot of children are coming to us with reports of neonatal screening. Remember, this is a screening test. This is not a diagnostic test. This is an immunoassay usually, and you will not get a direct good result from that regards. So 17-OHP is less than 300, unlikely. Above 1200, you have to confirm it using a mass spectroscopy. If it is in between, you can then go ahead and look for other possibilities from that perspective.
So moving on to the cases with adrenal. So day 1 neonate on screening was done and 17 OHP was high, 1400 nanogram per deciliter, and was diagnosed as CAH and advised hydrocortisone. The Hemchand sir, is this the correct approach?
I think as far as screening is concerned, the when, what, and why comes into picture. When to screen? Ideally, beyond 72 hours or at least beyond 24 hours would be the mandate. And it should be done on all babies. And the screening is done with FI, a fluoroimmunometric assay on 17-OHP. And why it is done to identify salt wasting type of 21 alpha hydroxys. That would be the main aim, to prevent hypoglycemia, to prevent dyselectrolytemia, to prevent incorrect sex assignment, to prevent a PICU admission or an NICU admission would be. So in this particular baby, the screening was done on day 1. And so I think one has to take that with a pinch of salt. Remember, there's a very beautiful article by Dr. Pallavi et al. In the Indian Pediatrics, which has given an Indian concept of approach to neonatal screening. The cutoff they look at is 12.5 nanograms per ml or 37.5 nanomoles per liter. They have given birth weight and gestational age specific cutoffs. It's for all of us to practice them and use them. The learning point in this case would be screen all babies, do the right screening test at the right age, and use a proper interpretation to guideline to streamline the management. And remember, preterm babies, stressed babies can have a false positive report, and mothers who have received steroids for lung maturity can have a false negative report. This has to be factored while interpreting it.
So in this case, on repeating 17 OHP, it came out to be normal and the child was reassured. So the key message is screening should be done after 72 hours and GCMS-based assay should be used. Moving on to the next case, day 14 child presented with atypical genitalia. There was bilateral gonads which were present. On doing ultrasound, no Mullerian structures were there. On doing karyotype, it came out to be 46XY. Testosterone level were done, which was low, and there was salt wasting. Riddhi ma'am, how will you approach this case?
So here bilateral gonads are present, suggesting XY-DSD clinically and also proven on the karyotype, and there was no Mullerian structure. And electrolyte abnormality suggests mineralocorticoid defect. So XY-DSD with mineralocorticoid deficiency, we have differential. We are looking at the star early pathway defect, that is star or tight chain cleavage, 3 beta HSD, P450 oxidoreductase defect, or Smith-Lemli Opitz syndrome. So 17 OHP, which was mildly elevated in this case, suggesting 3 beta HSD defect.
So key messages, ma'am?
Key messages are if androgen deficiency with aldosterone deficiency, think of proximal defects, and high 17 OHP, which points towards a 3 beta HSD defect.
Thank you, ma'am. Moving on to the next case, 3-month-old boy with micropenis with inguinal hernia was referred for surgery. On doing investigation, sodium was 130 millimole per liter and potassium was 5.8. Cortisol was done, which came out to be 70, and ACTH was advised, which was high, 560 picogram per ml. Head circumference was 32 centimeter in this case, and this is the photo of the child. And this is the genitalia, and there was microcephaly. Dr. Neha ma'am, how will you approach this case?
So this is the same case I think we got reference from an ICU for. So this was a case of primary adrenal insufficiency, as we can see on the basis of biochemistry, low cortisol and high ACTH, in association with obvious abnormalities such as upturned nares, microcephaly, micropenis. We need to think of SLO syndrome and we did lipid profile in this case in which cholesterol was very low. And after that, I think we did not proceed for the genetic testing. Just on the basis of clinical and biochemistry, this child was diagnosed as a case of Smith-Lemli-Opis syndrome.
Thank you, ma'am. Your key messages, ma'am?
So the key messages would be that in the presence of obvious congenital abnormalities such as micropenis and biochemistry of mild salt wasting, a possibility of SLO should be kept in mind. And with the availability of genetic testing, we can now offer genetic testings in these cases. And a lipid profile investigation showing low cholesterol level will be beneficial in diagnosing such cases.
Thank you, ma'am. Next case is 8-year-old boy presented with early puberty. Height was 134 centimeter, pubic hair stage 4. The potassium was on the lower side. Urine chloride was done, which was 100, and there was hypertension. Dr. Sayan, sir, how will you approach this case?
So a male with hypertension and metabolic alkalosis presenting with early puberty. So this is the typical setting that sir said. A boy will present to you with precocious puberty. Always think of 21 hydroxylase or 11 beta defect. Now this child has hypertension along with and metabolic alkalosis and low potassium. So we can directly think of 11 beta hydroxylase in this setting.
So the key messages, sir?
Sir, girl child.
So this was, so actually on examination, the child had cryptorchidism. So this was actually a XX individual who presented to us with appearing like a male.
Yeah.
So this child, I think Riddhi was also there, had come from Afghanistan. The child had come like that, yeah.
So actually these will present to you as a male because of the increased phallus length. On examination, we will not find any gonad in these patients and thereafter work up on the lines of 11 beta hydroxylase.
Thank you, sir. Next case, 14-year-old girl presented with delayed puberty. Height was 148 centimeter, Tanner stage 1. There was mild alkalosis, potassium was 3.4. There was hypertension. Hemchand sir, how will you proceed with this case?
So I think presence of hypokalemia and hypertension and alkalosis points out to a mineralocorticoid excess state. So the mineralocorticoid excess can be either because of excess levels of mineralocorticoid or excess action of mineralocorticoid. In the background of, a girl with delayed puberty, I think it points out to an adrenal biosynthetic defect. So presence of delayed puberty, presence of mineralocorticoid excess points to possible adrenal biosynthetic defect. So if you put it back in the algorithm, you're looking at a possible adrenal, you're possibly looking at a child with mineralocorticoid excess and androgen deficiency. So this is like a jigsaw puzzle, and you fit it into the algorithm, you find out a deficiency of 17 alpha hydroxylase enzyme. So
and there was this inguinal gonad which was present.
So it's a case of DSD, 46XY DSD presenting as delayed puberty in a young adolescent raised as a female with hypokalemia and hypertension. So as Rajni madam pointed out in her lecture, so adolescent with delayed puberty with hypertension is a red flag sign to evaluate. So the learning points from this case, I would say, would be that delayed puberty and hypertension, always keep in mind the possibility of 17 alpha hydroxylase deficiency. 46XY DSD should strongly be considered when there are possible gonads, and early genetic testing is always helpful in this group of children.
Thank you, sir.
So I think this was just a mirror opposite case of what Sayan was discussing. A XX individual presenting with precocious puberty because of 11 hydroxylase. This is XY presenting as a female with delayed puberty with inguinal gonad. So I think this we need to be open on. So now finally about adrenal excess. So when we talk about Cushing syndrome, many cases will be because of ACTH dependent, wherein the signal is coming from the pituitary. This is particularly common as pituitary and neuroendocrine tumor. In the age group of pubertal age group, this will be more likely. Children often have more hyperplasia. These will have gradual onset with pigmentation and typical features. Ectopic lesions are extremely rare in children, but they will present with more rapid pigmentation, hypokalemia and alkalosis with no classical features. You may also have increased receptor defects. So this is just mirroring what I talked about insufficiency. Excess will also be the same. So you can hyperactivity like McCune-Albright syndrome, GNAS1 defect, and of course Carney complex in which the adrenals are responding more in that perspective. These will be cyclical sort of a Cushing syndrome with a fluctuating course and multi-system involvement. And finally, you can have ACTH independent coming from the adrenals, which can be a adenoma or a carcinoma in particular. If you have a younger child, less than 1 year of age, often they will be adrenal carcinoma in that perspective. So anybody who has growth failure with obesity, violaceous thick stria, low bone mass, start thinking of Cushing syndrome. Other manifestations can be hypokalemic alkalosis with hypertension. Classical features like buffalo hump and those features are less likely in children, but short stature with obesity is the most common scenario in that perspective. Now, very important, as we know that there is a diurnal rhythm. So what you can do when you are thinking of excess, do it at night. So midnight cortisol is something which is effective. You can also look at suppression tests in which you give a dexamethasone and there is there is a decrease is not there in terms of that. The ideal test is increased urinary excretion. So what you can do is a 24-hour urinary cortisol. And if the levels are 3 times the upper limit, that is a specific test as far as this is concerned. The other thing would be a midnight cortisol or salivary cortisol, which is a good agent. Remember that you should have at least 2 screening tests to make the diagnosis of Cushing syndrome. And always go systematically. Screening test, diagnostic test, classification test, and then imaging. Do not do imaging early, otherwise you will get confused in that regards. So this becomes important. Now, what importantly, where should you not do it? If somebody is on estrogen progesterone, doing a total cortisol will not be reliable. If somebody has liver disease, again, go for urinary free cortisol. Renal failure is one scenario where urinary cortisol will be unreliable. So there you can go for ONDST. And for incidentallomas, we generally prefer ONDST because UFC may not be very good in terms of picking up max, which is clinically significant hypercortisolism in that regards. Anti-epileptics can cause effects as far as metabolism of DEXA is concerned, and therefore urinary free cortisol will again be checked on that perspective. So you should decide based upon condition as to what sort of screening test you want to do from that perspective. So how to approach? If you are suspecting Cushing syndrome in our country, always think of exogenous steroids. So that's why we do a morning cortisol to assess that. And then if you have diagnosed is Cushing's and your ACTH levels is less than 5, so this is already you have diagnosed Cushing's. ACTH is less than 5 picogram per ml. This is ACTH independent. Do a CT adrenal. If it is above 15, do a MRI head. Now, this is a common problem, and Dr. Saksham and us also had a similar case in which there was so much confusion because MRI often will not show you much. If you have an adenoma more than 6 mm, so in that scenario, you can consider it like a Cushing's disease. But other than that, I think the best way forward is to go for a IPSS. We have burnt our hands with HDDST. It is not a good test from that perspective. So better to go for IPSS, the inferior petrosal sinus, pituitary sinus sampling, which will distinguish whether it's coming from one side of the pituitary or not. So lateralization will come up. So clearly imaging is important, but only once you have confirmed Cushing syndrome in that perspective. If it's borderline, we can think of a CRH test, and people are also talking about AVP test as well. So these tests are there, but predominantly most cases will be ACTH dependent and your MRI will not show you anything. So that is a big hitch which happens in that regards. So we'll start with the cases.
Next case is 16-year-old girl with obesity and hirsutism. There was menstrual irregularity and buffalo hump. Overnight dexamethasone suppression test showed high levels 150 nanomole per liter. ACTH was 10 picomole per liter and MRI was advised. Dr. Riddhi ma'am, is this the correct approach?
So looking at the biochemical parameters, definitely we should go for MRI. But if we look at clinically, child is obese, hirsute, and child is having menstrual irregularity. So child was already on oral contraceptive pills for the PCOD. And somebody if who on OCD, then ONDST is not the right test to decide Cushing syndrome. So definitely go for urinary free cortisol, and that was normal in this case. So as sir has suggested, before making the diagnosis of Cushing syndrome, think twice. If there are clinical suspicious, first do the screening test, then do confirmatory test, and last is the radiological confirmation. So falsely high cortisol with the estrogen progesterone preparation, and UFC is the best test in this set.
I think that's a very big message you gave. So in adrenal insufficiency, we don't want to miss any case because the patient will die. So there we can use some test which has got a higher sensitivity, specificity may be low. But for Cushing's, if you diagnose the case, you will have to do MRI or CT or all those things. So better to have a higher specificity for that test.
Thank you, ma'am. Moving on to the next case, 15-year-old girl with obesity, no Cushingoid features. Overnight suppression test was 140. There was seizure disorder history. And on further assessment, what would you like to further assess in this child, Dr. Sain?
So a obese child, but as sir said, no Cushingoid features. So the classical signs of Cushing's not there. But again, biochemically, you have a non-suppressible cortisol level. But as you already have mentioned, the child is a patient of seizure disorder. So there are many drugs which can affect the metabolism of dexamethasone, clearing it off the system so that you don't get time to suppress cortisol in your system. So maybe the preferred test, as it is mentioned, you can go ahead with a urinary free cortisol in this state.
So child was on phenytoin and on doing urinary free cortisol, it came out to be normal.
Yeah.
So your key messages, sir?
So you have to, so as Dr. Riddhi also mentioned, in situations you have to consider apart from Cushing's and always rule out those causes before going ahead with a diagnosis of Cushing's syndrome.
Thank you, sir. Moving on to the next case, 14-year-old girl, again with obesity. The BP was 120 by 80. There was pigmentation. Cortisol 8 AM was high, 900 nanomole per liter. ACTH was done, hence, and it came out to be 20 picogram per ml. And then MRI was advised, which came out to be pituitary adenoma. So, Dr. Neha, ma'am, how will you go further with this case?
So this is a very clinically tempting situation in which a diagnosis of Cushing's is very hurriedly made. So we see that clinically child has obesity, pigmentation, hypertension, and as per the protocol, a morning screening test was done. But this is done just to rule out exogenous Cushing and not to rule in Cushing syndrome per se. So just a morning 8 a.m. cortisol made to diagnose Cushing was erroneous in this case. And as we have discussed about the 3 screening tests, either a 24-hour urinary free cortisol midnight or a DST should have been done in this case. And we did.
Yes, ma'am. So
So
overnight
we did an
suppression.
ONDST, which was suppressed, and this was not a case of Cushing's.
Right.
So the key messages will be that there is no role of isolated morning cortisol to diagnose Cushing. It is just done to rule out exogenous Cushing. And screening of Cushing should be made on the basis of these 3 tests.
Thank you, ma'am. A 12-year-old girl with obesity, height 142 centimeter and weight was 60 kg. There was buffalo hump, and on doing overnight dexamethasone suppression test, it was not suppressible. ACTH was done, which came out to be 6 picogram per ml, and MRI was done, which showed pituitary adenoma. Dr. Hemchand, sir, how will we go further on this case?
I think, as Sir rightly pointed out, Cushing syndrome is a treasure hunt game. If you follow the rules of the game properly, you really reach there. And here, one of the important phases where in this case, the sequence you see, till overnight DEXA suppression test, it was okay. But ACTH misguided us to a wrong direction. So I think it's a continuation of what was discussed yesterday. Pre-analytical factors while taking a lab sample is extremely important. It's not just you, the whole unit, including the lab technician, should be tuned to collection of samples. So whenever you are collecting sample for ACTH, it should be collected in a cold syringe It should be kept on ice. It should be transported frozen to an outsourced lab, and it should be stored at minus 70 degrees centigrade. So these pre-analytical factors must be factored, must be followed while you are collecting sample for a game-changing test like ACTH, which is going to kind of somewhere lead you to the pressure on this side into the pituitary gland or downside into the adrenal gland. So the learning point from this case is follow the sequence, take into account the pre-analytical factors while doing each of these tests involved in Cushing's evaluation, and ACTH extremely important to follow the precautions while taking the sample.
Thank you, sir. Moving on to the next case, 1-year-old boy presented with weight gain. There was hypertrichosis, round facies, as can be seen. Then cortisol level was done, which was 1200 nanomole per liter. ONDST was done, which was not suppressible, and ACTH was undetectable. Dr. Riddhi, ma'am.
Looking to the face of the child is totally fitting into the criteria of the Cushing syndrome. So here we should do the test to confirm the diagnosis, and looking at the clinical scenario, age of the child fits into the criteria of the adrenal carcinoma, and that was confirmed that ONDST is suggestive of the unsuppressed cortisol level. ACTH was also suppressed and suggestive of the adrenal carcinoma. CT was done, that has confirmed our clinical finding. So,
So a very early onset,
very
definitely.
early onset Cushing syndrome. And ACTH independent, do the CT adrenal, and infantile onset, always think of the adrenal carcinoma.
Thank you, ma'am. Next case is 14-year-old girl with hirsutism, rapidly progressive. There was clitoromegaly, hypertension, testosterone levels were high, 300 nanogram per deciliter. DHEA's level were also very high. The urinary free cortisol level came out to be 1000 microgram per day, which was also high. Dr. Neha, ma'am, how will you approach this case?
So this we can see is just a continuation of the key message that is just delivered by Dr. Riddhi, that a sudden onset of symptoms should give us a clinical pointer towards thinking of adrenal carcinoma. So this is a case of adrenal carcinoma because of rapidly progressive clinical condition, and there is no pigmentation. The child did not have sufficient time to develop pigmentation in this case.
The key messages, ma'am?
So the key messages would be rapid onset of virilization, and a high testo should point towards adrenal tumor, and no pigmentation was a clinical clue in this case to think of this condition.
Thank you, ma'am. Last case, 1-year-old girl with shock after fever. There was Cushingoid appearance. Cortisol 8 AM was low, 30 nanomole per liter. Dr. Sayan, sir, how will you approach this case?
So, yeah, sure. So if this is the child already has a Cushingoid appearance, but has a low cortisol, this is contrary to the clinical findings. So as sir said when presenting the part on cortisol and all, in our country, steroids are misused in forms of creams or in forms of homeopathic medications or any other forms. So a low cortisol with a Cushingoid appearance, you need to ask specifically for history of any creams or ointments which have been given.
So there was history of use of long-term topical clobetasone in this case.
So in these cases, you now need to supplement. You need to supplement, but as you do not know the duration for which the steroid was given, you need to taper very slowly and gradually for 3 to 6 months and then stop.
So the key messages, sir?
Yeah, so always rule out exogenous Cushing's before going on for a diagnosis of Cushing's disease. And if you have a diagnosis of exogenous Cushing's, very slowly, gradually withdraw.
Thank you, sir.
So I think this has been a wonderful discussion. I'd like to thank Dr. Hemchand, Dr. Neha, Dr. Sayan, Dr. Riddhi, and Dr. Nimisha for that. And we will give some mementos of appreciation.
Dr. Neha, ma'am. Dr. Sayan, sir.
Thanks a lot, sir. So, as we are nearing the end of this 2-day incredible academic feast here, I can request if you want to go, you can go for gastronomical feast as well. Coming to the last part of this 2-day incredible academic conference, the last ground round on ovarian disorders, I request presence of Dr. Yutika, Dr. Arpita, Dr. Saksham, and Dr. Vijay as to chair the session, and Dr. Ria and Dr. Anurag sir to kindly take over now.
Having this last session. It's been a marathon for everybody. Even today we started at 8. So it's 5 hours now continuous. So another maybe half an hour, 45 minutes, we'll close this one. So we are pleased to have Dr. Vijay, who has been here since the morning, Dr. Arpita, Dr. Yuthika, who is joining the panel. Dr. Yuthika is Director of Regency IVF, Reproductive Medicine and Pediatric and Adolescent Gynecology Specialist. Dr. Saksham Pandey has recently joined our unit as endocrinologist, and I am be joining with Dr. Ria as well. So we'll be talking about predominantly hyperandrogenism and oligomenorrhea, because hyperprolactinemia and other things have already been discussed earlier from that perspective. So hyperandrogenism is a very, very common finding, and we often mislabel everybody as PCOS. So we need to remember, when should we think of hyperandrogenism? Of course, if there is hirsutism, the most common presentation. Acne, which is refractory cystic nodular, is something which is important, and anovulation. These are the 3 common manifestations which are there. If there is virilization, that will indicate towards an aggressive tumor, which is causing this problem, as discussed in the previous case, and hidradenitis suppurativa, which is basically a swelling in the axillary region, which is painful, tender, and alopecia may also be there in certain scenarios. Now, when we diagnose hirsutism, we should not confuse with vellus hair, which are basically not non-sexual hair. So we want to have hair which are pigmented, dark, and increased in size from that perspective. Hypertrichosis, this is a child with diazoxide therapy, and you can see how hypertrichosis looks like in that perspective. And also hirsutism is basically in the key distribution areas from that perspective. And we all know about modified Ferriman-Galway score, the cutoffs being normal below 8, mild being 8 to 15, and moderate and severe above 15. It also depends upon ethnicity. So certain ethnicities like the Mediterranean populations and maybe Sindhi and Punjabi population in India have a higher FGS, while Northeastern and Asian people will have lesser. So it depends upon the environmental milieu as well as the family as well. So if the FGS is less than 8, hyperandrogenism is very unlikely. If it is 8 to 15, you can get a morning total testosterone done. If it is less than 55, and now people are talking about 50 and 45 also, so these cutoffs are coming down. And if it's above 55, makes hyperandrogenism likely. So total test, you can have clinical and biochemical hyperandrogenism. More than 15, you clearly have hyperandrogenism. You can get a testosterone done. Now, when we talk about polycystic ovary disease or PMOS, the new term which we are talking about, in adolescence, we are talking about hyperandrogenism and anovulation. There is no role of PCO appearance. So unexplained hyperandrogenism persistent for 2 years of ovarian origin is what PCOS or PMOS is, and both should be there. Now, how do we identify this is coming from the ovaries and not the adrenals? So there are a lot of tests available. DHEAS is a good marker. If your DHEAS is above 400, that will indicate adrenal origin. More than 700 will indicate likely adrenal tumor in that perspective. Androstenedione will be high in both scenarios. DEXA suppression is another one which you can see that if DEXA is causing suppression, it will be suggestive of a adrenal pathology from that perspective. And GnRH response also in ovarian can be considered. So just to summarize the approach, if hyperandrogenism features are not there, do not do a workup. If they are present and features of virilization are there in the form of clitoromegaly, voice change, or a very high testosterone, go directly for an imaging to exclude a tumor. If that is not there, exclude the common causes, thyroid, prolactin, all those things. And then DHEAS will help you classify from that perspective. So these findings will give you a clue from that regards. And management, I think we all know that estrogen progesterone is the cornerstone, but before that comes lifestyle and insulin sensitization. Remember, individuals in the first 5 years and plus 2 to 5 years of menarche, labeling somebody as PCOS is not appropriate. We can label them as at-risk PCOS. While if it is definite, we can think of lifestyle and metformin. There will be a lag phase for estrogen response. And if you find response, you continue till gynecological maturity. Add anti-androgens only after there is no response, because response to hirsutism may take time from that perspective, and these things are important.
So we'll start with the cases. In the first case, we have a 14-year-old girl who came with the concerns of hirsutism. She attained menarche 1 year ago and she's having periods every 2 monthly. Her FGS score was 6, and on ultrasound, there was polycystic ovarian appearance. So she was diagnosed with polycystic ovarian disease. So Dr. Vijay sir, do you agree with the diagnosis?
No, of course not. We don't have to make the radiological diagnosis basis on radiological features PCOD. So one. Second, that it's too early to comment on the PCOD because the girl has attained menarche 1 year ago and periods every, so it may take another 2 years to have mature response. So before going that, we don't have to jump on the just on radiological basis. It has to fulfill at least two criteria, that hyperandrogenism as well as an ovulation, and unexplained hyperandrogenism plus persistence of symptoms beyond at least 2 years, and that to be ovarian. Then only we are going to label. So probably we don't have to label on radiological basis. So that will be, so if any of them we are going to, how we are going to approach, that first we have to see that whether there are features of hyperandrogenism are there or not. If they are absent, there is no workup at least required. If they are present, we have to think for features of virilization in terms of clitoromegaly, voice changes, testosterone level more than 150 nanogram, or say FGS scoring beyond 50, anovulation, alopecia, testosterone more than 55. So then only we have to see. So if features of virilization are there, then we have to see whether this is from adrenal origin or ovarian origin. And if there is no features of virilization, then we have to see the common things, that is free T4, TSH, prolactin. If they are normal, then we have to see for what is the status of DHEAS. And if it is above 700 microgram, then we have to go for adrenal imaging. If it is below 717 OHP, and if this DHEA is normal, then probably we can label this as a PCOS. So the key home messages are no role of PCO appearance, the radiological diagnosis, a big no, FGS Ferman-Galloway score less than 8, not a marker of hyperandrogenism. So these are the things. So avoid workup. If this is in the early phase, not consistent to 2 year, then probably we have to avoid that.
Thank you, sir. Moving on to the next case, a 14-year-old girl came with hirsutism. She also attained menarche in the last 1 year. She is having periods every 2 months, but she has signs of virilization with increased muscularity. Her Ferriman-Galway score is 18, and she was also diagnosed with PCOD. So, how does this case differ from the earlier case, ma'am?
Now, this is a very early and a severe presentation of hyperandrogenism because the girl is virilizing. So even though she's in the first 1 year of her menarche, but this kind of hyperandrogenism with a Ferriman-Galloway score of 18, muscularity and virilization could not be explained by the immaturity of the HPO axis. So something is really wrong. But any kind of anovulation and hyperandrogenism will lead to an ultrasound appearance of a polycystic ovaries. So labeling such patients straight away looking at the ultrasound as PCOD is also not right. So again, we come back to the same approach. So if you've got virilization present and very high testosterone, this is a male level testosterone, 230 nanograms per deciliter, and a high DHEAS is pointing towards an adrenal origin of these androgens. And therefore, an early workup for this kind of severe androgenism with an imaging for adrenal should be done in this case.
It was done, ma'am, and it showed adrenal carcinoma.
So very important message with this girl. So even if somebody is presenting very early within the first 2 years of menarche, if it is severe early onset, very rapid onset of hirsutism, especially if it is severe enough to cause virilization, and especially if it is DHEAS elevation, which is adrenal origin, we should work up for severe causes like these.
Moving on to the next case, a 15-year-old girl came with the concerns of increased hair growth. She was having normal menstrual cycle, and the main concern was hair growth. Her Ferriman-Gallway score was 3, and there was a similar family history. So, Dr. Apita, ma'am, how would you approach this case?
So this is a common scenario which comes to our clinics on a daily basis these days with the girls concerned about the increased facial hair. But here you can see that the menstrual cycle is normal and there the Ferriman-Galloway score is also below 8, which is reassuring. But it causes a lot of distress among the girls particularly. So we have to first see the distribution of hair, the type of hair, whether it is villous or thin, which is normal, or take a adequate history regarding the drugs, which can cause hypertrichosis, and look at the FGS score, which was reassuring in this child. So this child just needs reassurance that it is normal, villous hair, and does not need extensive endocrinal workup on that regard.
So what would
So
be
clearly,
the
wellness here we don't need to be worried about in that perspective, and often unnecessary workup will cause more confusion in this setting.
next case? We have a 16-year-old girl with the concerns of hirsutism. She had amenorrhea from last 3 months. There was no obesity and no galactorrhea. Her testosterone level was 68 nanogram per deciliter, and 17 OHP was high. It was 600 nanogram per deciliter. So, Dr. Saksham sir, how do we interpret these results?
So as we see that she is having menstrual irregularity, testosterone is also high, and 17 OHP is also high. So we'll get tempted and we'll think that the child is having non-classical CH. But yesterday we had a talk, we had a great discussion in endocrinology and diagnosis, where Anurag sir mentioned that the timing of the hormone is very important. At what time you are doing the test. So 17 OHP should be done during the follicular phase. So that is important. And sometimes when the female is having amenorrhea, the question came from the audience also that the female is having amenorrhea. How will you come to know that at what time she had follicular phase or what time there was ovulation? So we have a marker also by progesterone level. We can correlate slightly that the 17 OHP should be done at what time. So that's very important because these are hormone tests and the timing is very important. And according to that, we can correlate at what time of the cycle it has to be done. And in this patient, as we can see, when we repeated it, it was normal. So,
and the progesterone was also elevated, confirming your suggestion that this was in the ovulatory. So amenorrheic girl, we don't know. So either you give a withdrawal and do it then, or if you're doing, do a progesterone. So I think withdrawal may be a better option to assess from that perspective.
So the key message is
is the same that 17 OHP should be done in the proliferative phase or the follicular phase. And when we are having doubt, we can go for the stimulation test. So unnecessary, don't label the person with non-classical CH. That's the point.
Moving on to the next case, we have 15-year-old girl who came to us with hirsutism. She attained menarche at 13.5 years and she was having periods every 3 months. Her Ferriman Galway score was 16 and she also had severe acne. Her testosterone level was 64 nanogram per deciliter and on ultrasound there was PCO appearance. So Dr. Vijay sir, how do you approach this case?
Yes, thank you. So here I am looking a girl who is having really severe problem in terms of high FGS scoring, severe acne, high testosterone level that is more than 55, and here USG PCO appearance. So at least even before labeling this girl as a PCOS, at least we can have that she is having a problem, and we could have labeled this girl as a PCOS, likely PCOS. So that will be a thing. And this girl really require need to help. So categorize at risk within 2 years of menarche, where we are standing. Need for urgent treatment, I think yes. So this to be followed up. And if there is definite, then we have to, yes, please go ahead. Yes. So at risk PCOS, consider oral contraceptives in this. Probably we are going to balance the hormone and we are going to help. So what are the key message that don't label PCOS before 2 year of menarche? One, but if she is having symptoms, that symptoms to be taken care of, and that can be labeled as likely PCOS. So may consider treatment here, it is required, and we can do with OCPs.
And remember that hyperandrogenism begets hyperandrogenism. If you allow the testosterone to be high, the ovaries will be damaged, and then that can cause more problem later on.
A 17-year-old girl came with hirsutism. She attained menarche at 14 years of age and she is having oligomenorrhea. Her FGS is 18 and she also had acne and the BMI was 32 kg per meter square. The testosterone levels were also high. It was 72 and ultrasound showed PCO appearance. So Dr. Yutika ma'am, how do you approach this case?
So she is presenting after 2 years of menarche. She's a clear case of PCO. And definitely, we call it PMOS now. She has a high BMI. Again, the gynecology teaching is still till the age of 23. We are not labeling these patients as PCOS. We're still calling them at risk and giving the chance, because it's been studied that the HPO axis actually matures later in some girls, especially if they are obese. So basically, in this girl, although she has all the classical symptoms of PCOS, she is anovulatory, she has hirsutism, elevated testosterone, and as Dr. Anurag said, testosterone is going to beget her testosterone. It's very unlikely to get treated, spontaneously resolved. So besides doing lifestyle management and other things like correction of her insulin resistance, it's very important to give her estrogen and progesterone and correct her testosterone, which will give her regular cycles, plus her current goals of hirsutism will be solved, plus her testosterone will be lowered, which gives us a better chance of probably correcting. So it has to be given till we say 5 years after menarche or till maturity is reached. So that is what the treatment
And I think metformin is also very, very important, especially in the obese girl.
The same girl was followed up after 3 months. She was now having regular periods. There was a weight loss of 3 kg, but hirsutism remained the same. So that was her major concern. Now, ma'am, what should we do?
So hirsutism, right at the start of the treatment, we have to counsel them that the hair cycles are longer. So first signs that you have your hirsutism corrected will be 6 months after the onset of treatment. So she needs reassurance in this case. And you could actually basically do a testosterone level also while on treatment, whether it is decreasing or not. But if the testosterone level is not decreasing, you could add other things. But here, lag phase is the reason, and follow up and reassurance is needed.
So after 6 months, she came again, and there was no improvement in hirsutism. There was also weight gain, and now she wants to opt for cosmetic measures. So, what will be your advice, ma'am?
Again, testosterone level is important before going into cosmetic measures. Basically, we need to actually add further anti-androgens to correct her testosterone, because even if you go for cosmetic measures, if the testosterone is high, this is not going to fade. So we have to start adding further treatment, something like spironolactone.
She was followed up 9 months later. Now she is stable, but she is having intermenstrual bleeding. This is the current concern. So, what should we do, ma'am?
Most common cause of intermenstrual bleeding in a patient who is already treated long term for OCP is either the patient is failing to take the medicine properly, or there is thinning of endometrium due to prolonged use of OCP. So basically, poor adherence as the major cause.
Now she is followed up 1 year later. There is improvement in hirsutism. The weight has also decreased, and she is having regular periods. So, what will be your further plan, ma'am?
She's a 17-year-old, 1 year of treatment. Periods are regular. There are two approaches to the treatment. Sometimes we stop and see. Other times we basically continue. So when we started, she had severe hyperandrogenism with severe hirsutism, which barely got corrected after 1 year of treatment. I would like to continue it till at least 5 years post menarche.
So, what will be your key messages from this whole clinical scenario?
Basically, for obese girls, lifestyle and metformin is very important, but because it basically is correcting the pathophysiology behind this disease. And you have to check for adherence of the treatment. If the girl is not taking the treatment properly, the time to get the hirsutism corrected will be more, intermenstrual bleeding will be more, and reassurance that even if she is taking things properly, because of the hair cycle, minimum lag phase would be required before the hirsutism is getting corrected. And the treatment, especially if she is slow to correct her lifestyle, she's not losing weight as appropriately as it indicated, we have to continue treatment at least 5 years post-menopause.
So, Dr. Saksham, in these cases, with obesity and availability and approval of GLP-1 analogs, do you think semaglutide could also be a good option now?
Yes, sir. Semaglutide is a good option. Those patients who are not able to reduce weight, and metformin, as we all know, it's not a very good weight loss agent. It's weight neutral. Some effects are there. So in those patients, guidelines have mentioned to use semaglutide as a second line option. We can use them. And some studies have shown that there are also benefits in hyperandrogenemia and some fertility also, like it will be improved, definitely.
So I think
I think for adolescent kids, use of GLP-1 still we are thinking that it is a little difficult. But if
no, it's
we
now
actually,
approved beyond
that's
12.
what I'm saying positive about it, because it is sort of a preventive therapy.
Yeah.
Once you are an adult, and if your menstrual cycle is fixed at a high LH state, it becomes very difficult to revert PCOS. So it's sort of a semi-emergency to treat their obesity. If it's not possible through lifestyle and metformin, I think GLP-1 should be taken as a second line and an important treatment for PCOS.
Because we consider that it is adolescents are the best candidates for GLP-1 because there you can completely reverse the whole disease. While adults, you can just control it.
So actually, this talk has to be between the endocrinologist and the gynecologist. Most of the patients are going to the gynae, and gynae people think that when they get older, then we will think of it. When we're losing a very precious time of prevention of development of a true PCOS.
Thank you, ma'am. Moving on to the next case, a 16-year-old girl with the concerns of hirsutism. The onset is from last 1 year ago, and she is also having oligomenorrhea. She also experiences severe menorrhagia. Her testosterone level is 90 nanogram per deciliter, and ultrasound shows PCO appearance. So, Dr. Apita, ma'am, how do you approach this case?
Right. So this girl has clinical as well as biochemical evidences of hyperandrogenism. However, the emergency situation here is the menorrhagia. So in this situation, she must be treated with high dose estrogen. But before going on to that, we have to also hemodynamically stabilize the child, look for her hemodynamic status, BP, and offer her blood transfusion if it is required. So the key treatment here is high dose estrogen, and later the progesterone may be added onto the treatment.
So maybe to acutely terminate, we need higher dose and maybe progesterone also for some time. We often give it for 3 weeks. Dr. Yutika, what will you suggest? Anything else?
Yeah, I think I completely agree with Dr. But in an obese child, a higher dose estrogen, I think a high dose of progesterone, something like a, long-acting norethindrone, in a dose of 30 milligrams, acutely stops bleeding within 48 hours. Then you can taper it down and give it for 20 days. It will cause thinning. So most common cause of excessive bleeding in a PCOS patient is endometrial hyperplasia, and estrogen is going to actually increase, but sometimes it could be very thin endometrium where the higher estrogen, so it's sort of you
I
give,
think
try
for
and give.
emergency
So in
progesterone
a
and then
obese patient I have seen, it's usually hyperplasia. In a leaner patient, it is usually thinning of endometrium where high dose estrogen is to be given.
Moving on to the next case, a 16-year-old girl came with severe hirsutism. Her FGS is 28, and she is also having oligomenorrhea. Her testosterone level was 110 nanogram per deciliter, and ultrasound showed PCO appearance. Dr. Saksham sir, how do you approach this case?
Thank you. So diagnosis is clear, there is no doubt. So we have to start the management, but we have to understand that the patient is having very severe hirsutism. FG score is 28, testosterone is also high. So what we generally follow is a standard regime, that is 21/7, and most of the doctors follow that also only. But we have to understand that in this patient, we have to be slightly aggressive and we have to go for a continuous therapy. That is like give continuous estrogen for 3 months, don't give a gap. The reason is that when we are giving a continuous therapy, so there will be more suppression of the ovarian androgen synthesis. There will be a better estrogen level also, like stable level will be there. And third, the hirsutism will also improve. So in that case, in this case, like we can go for a 3 months continuous E plus P. And after that, accordingly, we can decide what we have to go, whether 21/7 or continue the same.
So, what would be your key messages?
So the key message is that always don't follow the standard regime. Depends upon patient to patient. As ma'am said for the last case also, that sometimes the progesterone works very well. Because we have also done the same thing, that when there is severe menorrhagia, you give progesterone only and there is gastric response, usi se hi bleed rukta hai. So it depends upon case to case. In this case, there is severe hirsutism. FG score is 28. It's very high. So for that, we should go for a continuous estrogen therapy and not for that 21/7.
And I think this is a very catch situation because this may actually go on to a scenario where you can actually develop hypertrichosis. And if you don't control it early, then it becomes absolutely like a time bomb and it's very difficult to manage.
For our next case, we have a 17-year-old girl with hirsutism, which started immediately after menarche, and it is rapidly progressive in nature over the last 6 months. She also has amenorrhea, increased muscularity, and voice change. Her testosterone level was 200 nanogram per deciliter. So, how do we approach this case, sir?
Yes. So here is an emergency that immediately after menarche, you can see the rapid progression for the 6 month amenorrhea, even to such extent that muscularity and voice changes and testosterone is very high, that is beyond 200. So this girl will really need investigation in terms of imaging and so this is rapidly progressive. Testosterone is very high. What we can see that large ovary and hypertrichosis is there. What Dr. Anurag sir was worried that these children too be required very aggressive management. So next, what we can do? So persistent symptom, virilization, progressive, yes. So this is testosterone very high. So we have to see that what are the other options beyond our conventional OCPs. So we can here, this is the place where we can have GnRH analog therapy to prevent hypertrichosis or at least to stop that. So here is the role of GnRH analog and backup estrogen is going to be there.
What would
And
be your
what about other interventions? Like in couple of cases, Dr. Yutika, you had gone for wedge resection. So is that
So the child is presenting like a classical seen Levanthan syndrome, and sometimes the thecal part of the ovary is so hypertrophied that it becomes autonomous, and even GnRH suppression we are unable to correct the hirsutism. So it is autonomically producing a lot of androgen, and in those cases nowadays we are not doing resection because it decreases a lot of ovarian reserve. So we do what is known as laparoscopic ovarian drilling. That causes a peripheral cauterization of the thecal tissue, and some improvement is seen. But in very severe cases, one of the cases that we saw, we did a partial oophorectomy, sort of a wedge resection in one of the cases that Dr. Nurag had sent me, and there was a marked improvement after the
so this is like
resection.
ovaries are doing nothing good, they are all doing harm. So better to remove. Some people say for CAH, you can do adrenalectomy, although that's a very drastic step, but it is similar to that situation. Yeah, Dr. Vijay. Yes.
So the key message is that consider hypertrichosis with virilization to such extent. GnRH analog with estrogen add back. But yes, we have to involve the gynecologist friends, and probably they need some intervention in terms of say wedge resection or at least multiple dot formation laparoscopy.
So we have gone through hyperandrogenism, the most important presentation. The other common one is oligomenorrhea. For that, we need to understand really as to how do we define oligomenorrhea, though there have been some changes also. But broadly speaking, we should remember that in the initial phase, there is anovulation. So first year, if we have 4 or more cycles, 2 to 4 years, less than 6 cycles, fifth year, less than 8 cycle, and beyond that, 9 cycles is generally considered to be oligomenorrhea. There have been mild variations, but I think this figure will roughly remain true. Amenorrhea is defined primary none by 15 years of age or 3 years after thelarchy, that is your stalled puberty classically. And secondary amenorrhea is 90 days if you have regular cycles and 180 days if there is an irregular cycle. So these are the classical definition. Of course, clinical variations may happen in terms of your assessment. So how do you assess? Very importantly, exclude pregnancy. We talked about the case as to how pregnancy could be there. Rule out common causes like hypothyroidism, prolactin, and then FSH will give you a clue. If FSH is high, this is classically your premature ovarian insufficiency. Remember, always do karyotype in young girls who present to you with ovarian insufficiency, because this could be a XY-DSD also, especially if it's a primary amenorrhea. All autoimmune workup, especially cortisol, becomes important. We don't have those antibodies easily available at this point of time. If the FSH is normal or low and you assess your estrogen status, now how do you do it? You can ask for, you can feel for the breast if they are soft versus hard, dryness of mucosa or endometrium. So this will tell you whether the estrogen exposure is currently there or not. If there is hypoestrogenic, then that means that there is a problem actually of hypogonadism. Then you do all the common tests, CBC, ALT, creatinine, TTG, and all those scenarios. If they are normal and you have low FSH, consider that this could be a central cause. Do an MRI. While if they have a normal estrogen status and hyperandrogenism, you go from the PCOS workup, which we talked about. If they are not there, then we are talking about the local cause. So oligomenorrhea can be because of the hypothalamic pituitary axis, the ovarian axis, or the uterine axis as well. So if you have normal FSH, normal estrogen status, no hyperandrogenism, directly requires a gynecological assessment and evaluation. Maybe give a estrogen progesterone response. If there is no response, in that scenario, you have to do a local evaluation by a gynecologist from that regards.
Moving on to the cases, 15-year-old girl came with the concern of scanty periods. She attained menarche at 13 years of age. She is now having periods every 6 weeks, which lasts for only 1 day. She was advised estrogen progesterone combination. So, Dr. Yuthika ma'am, what is your take on this case?
Again, first we need to define whether this patient has a problem. So she is not very happy with 1 day period, which is generally a case. You will have patient one cycle, 1 day period, they will come back. But if you have 5 years of heavy bleeding, they will not go to the doctor. So it's in the psychology that if you have less period, they will go to the doctor. But having less period doesn't always mean that it is a problem. And especially in this girl, only within say 2 years of her thelarchy, if this cycle is not regarded as oligomenoric and an immature hypothalamic pituitary axis and ovulatory cycles, you can have a thin endometrium and a light period. Doesn't need treatment. You need to look for other things. Maybe she's very lean, adiposity is less. General things can be seen. Just keep her in follow up and see whether what is the estrogen status of her, and no actual treatment is required in the first 2 years of Thilaki.
What will be your key messages?
Yeah, no an unnecessary workup. Please don't do. Use age-specific criteria for oligomenorrhea and reassure patient that period is not bad blood which has to be out of your body. So it has to flow very in adequate amount. That is the main concern. They're thinking that something is there and I will get tumor or something. So that they need proper counseling about what period is, how periods are made, and why you're having scanty period, and because this is not going to cause any problem. Keep her in follow up.
Okay. Thank you, ma'am. A 17-year-old girl, she attained menarche 4 years ago. Now she is having infrequent periods, none for 3 months. She is also having significant weight loss with lethargy. Her LH level is 0.8, FSH 1.2, and estradiol level is also low. It is 12 picogram per ml. She was diagnosed as hypothalamic amenorrhea. However, on follow-up, she developed seizures. So, Dr. Arpita, ma'am, what do you think went wrong and how should it have been managed?
Right. So if we look closely at the girl, she's symptomatic. She's having oligomenorrhea for sure, and she's fitting into the picture of hypogonadotrophic hypogonadism. But before labeling her as hypothalamic amenorrhea, which is a diagnosis of exclusion, we have to follow the algorithm. So with low FSH and low estrogen, we have to look for the screening test. And here, because the girl already has neurological features, we had to do MRI upfront in this girl and see if there is something, tumor or something in the child.
So the MRI was done and this was seen, the cellular lesion, well circumscribed.
So we have to keep in mind that the hypothalamic amenorrhea is a diagnosis of exclusion, and MRI head is mandatory before labeling any individual with this diagnosis.
So again, hypo is not a simple diagnosis. I have seen boys with craniopharyngioma, girls with craniopharyngioma. So it's something you should always get a MRI done in that scenario.
Moving on to the next case, a 17-year-old girl has secondary amenorrhea. She attained a menarche at 12 years of age and she is having periods every 2 monthly. Her FSH is 4.4 and LH is 4.9. Breast is normal and FGS scoring is 4. Dr. Saksham sir, how do you approach this case?
So we should always follow the approach as sir has mentioned, because these cases are very common. They'll come to us every day. So the first thing is we saw the FSH level. So at FSH is normal. So when FSH is normal, this means the ovarian insufficiency is not there. So no need to do any karyotype and all. Second thing, the breast was also normal. So this means that the estrogen part is also normal in the female. So FSH is normal, estrogen is also normal. That has been proved. Now the third step is see the approach only. We'll see the hyperandrogenic features are there or not. And in this, the FG score was not high. So this means hyperandrogenemia is not there. So in this case, we should first go for a progesterone challenge test. And generally we do this only in a case of a secondary amenorrhea. We should go for a progesterone challenge test. That's the first step. And that's very easy also to do. And if there is no bleed with that, then we can go with the E plus P test. And if still there is no bleed, then we'll refer the patient to the gynecology as mentioned for some obstruction cause or some cryptomenorrhea or anything like that. So this is the basic approach that everyone should know, that it's not a gynecological case. Even physicians should also know about this basic approach.
So with progesterone, she did have a withdrawal, suggesting a anovulatory finding.
Moving on to the next case, 16-year-old girl who came with secondary amenorrhea. She attained menarche at 11 years of age, and she was having periods every monthly. Now she has presented a secondary amenorrhea. Her FSH is 3.2 and LH is 3.4. Breast was normal and FHS scoring was 1. There was no response to progesterone. So, Dr. Vijay sir, how do we approach this? This
What I can see with this case, that initially she has attained menarche at right time. She was having regular bleeding. FSH and LH are within normal limit. She is not having any signs of hyperandrogenism. So what I can see that no response to progesterone. So again, we have to follow a standard protocol on algorithm basis, that if any girl presenting to you oligomenorrhea, first you have to exclude the pregnancy, the common things, that is hypothyroidism, hypoprolactemia, major FSH level that is normal. So this assess estrogen status, that is also normal in this case. Whether she is having any hyperandrogenic feature, so no estrogen, progesterone, she is not having any response. So it means that this girl will require local examination with here hysteroscopy was advised, and the systemic disorder of tuberculosis was found out.
What are the key messages?
So the key messages are local cause with normal breast and FSS. So a hysteroscopy is really required in these cases, and we have to make the local diagnosis for that.
Thank you.
I think still tuberculosis is an important cause,
Still.
but we often see some form of malformations also. But being normal to begin with makes that less likely.
Next case. So we have a 15-year-old girl who presented to us with primary amenorrhea. On examination, she had breast stage 1, pubic hair stage 1 with no menses. Her height was 152 centimeter and weight was 52 kg. FSH levels were high, it was 67, and LH was also high, it was 32. Although estradiol levels were undetectable. She had mild hirsutism and large cyst on ultrasound. On karyotyping, it showed 46XX pattern. So Dr. Yutika ma'am, how do you approach this case?
This is hypergonadotropic hypogonadism, delayed puberty, and primary amenorrhea. But significantly, as against usual causes of hypergonadotropic hypogonadism, you have smaller streak ovaries. Here, the ovaries are actually showing cysts. And she's a normal 46XX. So it could be, yes, a significant perinatal history, because it looks like it's sort of the ovaries are functioning, but ovarian effect is not there. So maybe the estrogen is not working properly, maybe a receptor defect, or maybe what is rarely seen in aromatase deficiency, where mothers usually, because of absent aromatase, develop hyperandrogenism during perinatal period. So this is a key history in a patient with large cysts and a primary amenorrhea with delayed puberty, hypergonadotropic hypogonadism, and a normal karyotype. It could be aromatase deficiency.
So this is a classical presentation. There are PCOS mimics also. Often you will get atypical genitalia at birth, but milder defects now have been identified who present to you with large ovarian cyst as well. So this was aromatase deficiency in this case.
Yes, the key message is, if you've got large ovaries with hypergonadotropic hypogonadism, look for something which is blocking either the estrogen production or estrogen effect. And as Dr. Anurag said, these girls sometimes have some sort of hyperandrogenism, maybe a clitoromegaly or even DSD.
Thank you, ma'am. Moving on to the next case, a 17-year-old girl came to us with primary amenorrhea. On an examination, she was breast stage 4 and pubic hair stage 4 with no menses. Her height was 168 centimeter with weight of 52 kg. FSH height was 75 and LH was 23. Estradiol levels were again undetectable. So, Dr. Apita ma'am, how do you approach this case?
Thank you, Ria. So as you can see in this girl has the breast stage development as well as pubic hair development, but having primary amenorrhea. And you can notice that the girl is tall for her age. And as sir already mentioned, that any girl presenting with primary amenorrhea with high FSH, you have to find out the karyotype and to look for the XYDST,
So
because that may
karyotyping was done, ma'am. It was 46XY.
right. So primary amenorrhea in an apparently female-looking girl with high FSH, karyotyping should be done and should be mandatory to. And gonadectomy should be offered because the gonads will have the risk for gonadoblastoma in the later on period.
So what would be your key messages, ma'am?
So a tall girl with primary amenorrhea, we should be having a high index of suspicion for XYDST, and karyotype in that situation becomes mandatory, and the family should be counseled for gonadectomy.
Thank you, ma'am. For the next case, we have 16-year-old girl who came to us with primary amenorrhea. On examination, she was breast stage 1 and pubic hair stage 1 with no menses. Height was 168 centimeter, weight was 52 kg. The FSH-LH levels were high with undetectable estradiol levels. Her karyotype was done and it was 46XY. So, Dr. Saksham sir, how does this case differ?
So as we can see that she's a 16-year-old girl and she has not developed any spontaneous pubertal development, and FSH LH is high. So as we have already discussed so many times that when FSH is high, we have to go for a karyotype, and karyotype is showing 46XY. So this means that the patient is having XY DSD. And now the first thing is that we can see the gonads. Is the gonads are palpable or not? It's always not the inguinal, like at the scrotal, it can be inguinal, or even abdominal also can be there. So inguinal gonads are a very big clue in this patient. And second thing is that sometimes it's difficult to diagnose only on the clinical basis. You need a biochemical investigations or a genetic testing. So we can advise a steroid metabolite like profile, and which can tell that what's the exact defect is there. So both the scenarios are possible in this patient. This can be a case of XY-DSD Sewer syndrome. That is, there is gonadal failure can be there, but gonads are palpable. So slightly unlikely in that the gonads won't be palpable. They will be destructed. So they will be present on the MRI, but they won't be palpable. So first DD can be that. And second, if it is not fitting in Sewer syndrome, then by steroid metabolite analysis, we went for the diagnosis and it came to be 17 beta HSD3 defect.
I think that's a very important point of having inguinal gonads. That was what is different from Dr. Arpita's case.
Yes. So that was the case. Thank
So
you.
we have to always look for the gonads in that regards. So I think this has been a wonderful discussion, and we have been able to finish the session, I think, in 15 minutes after the time. So it's, I think, acceptable. Already 5-hour session is already there, 5.5-hour session. I like to really thank Dr. Saksham, Dr. Arpita, Dr. Vijay, Dr. Yuthika, and Dr. Ria also for this perspective. And we will like to provide a memento of appreciation.
Yuthika, ma'am. And we would also like to give the new edition of our book. Dr. Saksham. Arpita, ma'am, she has.
We'd like to thank all the people who have been attending the session from across the various regions of the globe. And we'll be concluding the session, and hopefully we will have a similar session next year as well. So we'll stop the session here.